and the lunch is for 12 minutes. So we have to be quick for consumption. So diet for cardiovascular health, that was the subject. I added my thought process, too many cooks spoiling the broth, just to make it more interesting. First thing first, ESC said a healthy diet is recommended as a cornerstone of cardiovascular disease prevention in all individuals, and that is class 1. That means diet is important to prevent cardiovascular disease, and not only important, it is the primary important finding, and it is applicable to all individuals, which is corroborated by Salim Yusuf's INTERHEAD trial, which was published 15 years ago, with 9 attributable risk factors for heart attack, which accounts for more than 90% of first heart attack. 2 actually dealt with diet. One is vegetable fruit diet, where the population attributable risk is 13.7, and another is alcohol, where the attributable risk is 6.7. So we know the importance of diet is not overemphasized. This is in nutshell. In 2016, European Society of Cardiology gave the broad perspective of what we should take diet for our cardiovascular health. Saturated fatty acid to account for less than 10% of total energy and should be replaced by polyunsaturated. This PUFA, trans should not be there. It should be all cis, and trans should be absolutely avoided, at least less than 1%. Salt should be less than 5 gram. It is not sodium. Sodium comes about 2.2. It is the total salt, 5 gram, with 30 to 45 gram of fiber, 200 or more of fruit and vegetable daily, individually 200 gram. Fish 1 or twice a week, and should be oily fish. 30 gram of unsalted nuts per day. And if alcohol, 2 glass per day, that is 20 gram for man. And as the guideline is written mostly by men, they are a bit more generous for men, and they were not so generous for ladies, because the only cost increases if you allow too much alcohol for the ladies. So it is 1 glass per day for ladies, and that was allowed by the men guideliners, and sugar sweetened soft drinks and alcoholic beverage. But because of the female revolution, within 4 years they have changed and made alcohol at par for male and female. So females increased their allowance from 10 to 15, and males have to sacrifice from 20 to 15. Salt was a bit more liberal, from 5 gram to 6 gram, and fibers was slightly more, 30 to 45 is now 35 to 45. Not much of gross difference. But then came the first cook. In Munich, 2018, in ESC Congress, Andrew Menti, on behalf of Salim Yusuf and group of pure on-target transient interheart and interstroke investigators, they presented the 218,000 patients of dietary quality, not patients, but population, from 50 countries, where India was represented very nicely. And what they showed, look at this slide very carefully. It showed on the left side, if you take these fruits low, you have problem. If you take them high on your right side, you are good. Fruit and vegetable, high versus low, there is a 4-fold benefit. Nut and legume, there is again a 4-fold benefit if you take more. Interesting part comes in the dairy. And what is in the dairy? You see on the right side the picture. It contains, they explained, whole fat milk, cheese, and butter. And if you take those high, you have 5 times more benefit than you take them less. Red meat, you see the picture down, and if it is unprocessed red milk, you get benefit 0.3 versus 1.4. So 5 times more benefit if you take red meat, 1 serving per day, compared to if you do not take it. Rather surprisingly, fish was not so good, 0.2 versus 0.3. Now, percentage of carbohydrate, if you reduce from 69 to 54, you get benefit. Fat, if you increase from 18 to 28, you get benefit. And protein from 12 to 18, you get benefit. And what benefit? If the score is below 11, if your mortality is 1, if your score is above 18, your mortality is 25% less. If you take more dairy, more butter, more milk, more red meat, you have 25% less chance of dying. But surprisingly, for cardiovascular disease, the p-value is not significant. Whatever you take, you die of heart attack in the same rate, almost at the same rate. P-value is 0.04, but total mortality is very different. So what was different is dairy and meat. Now the second cook was cooking in a side room in the same ESC Munich. When Salim Yusuf was presenting in hall A, he was presenting in some other hall. Mohsin Mazidi from Sweden, they took up 447,000 participants with 15 years follow-up. And what they showed is low carbohydrate diet showed increased risk of total mortality and cause-specific mortality. What are the cause-specific mortality? Cardiovascular death, stroke death, cancer death, all increase if you take low carbohydrate diet. Why? Might be explained by the fact that missing carbohydrate were replaced by more fat. That cannot explain because we saw that more fat is good. Then came only this year in January, low carbohydrate and low fat diet from US adults. And what they showed? Overall, low carbohydrate and low fat diet were not associated with any mortality. But unhealthy LCD and LFD were associated with higher mortality, and healthy LCD and LFD were associated with lower mortality. So overall, they did not matter whether you take carbohydrate or fat or whatever. Next comes the salt. WHO said target is 5 gram, very good. But you see, this group said from PIOT trial that salt intake was positively associated with stroke only. And that also when it is more than 12 gram, not 5 gram. And it is inversely associated with heart attack and death. More salt, less death. More salt, less heart attack. And it is independent of blood pressure. And of course, it is provocative. And of course, it challenges whether we should restrict to 5 gram per day or not in Sahara, in India, or in Brazil. Now come the egg. Very fond subject of our chairperson. US government removed the daily cholesterol limit of 300 milligram from its 2015 to 2020 dietary guideline. And it stated cholesterol is no longer a nutrient of concern for overconsumption. So you can consume it. There is no term for overconsumption as far as egg is concerned. And cholesterol in food has little effect on the amount of cholesterol in the bloodstream. But immediately after that, there was a publication, very good publication in JAMA, concluded that higher intake of egg and cholesterol significantly increase the risk of cardiovascular disease and premature death. So another cook to spoil our pleasure. Then come the potato. It only came last week, 26th October 2020, in a very good journal, Clinical Nutrition. For the first time in a rigorously controlled clinical trial showed diabetes don't need to avoid potatoes. Though potatoes have got a higher glycemic index, but they showed glycemic index has got nothing to do with sugar control and nocturnal glycemic response. And you can jolly well take a skinless white potato rather than a better, so-called better meal of basmati rice. So this evening, friends, you may not take the basmati pulao, but you can take jacket potato for your dinner, even if you are diabetic. We actually did a trial, me was part of it, and published it in JAPI in 2016, seeing what we are doing in India. On an average, we are taking 10 grams of salt every day, which is more in North, and North again are taking more fat, which is mostly coming from ghee. We in Eastern India are taking ghee and cheese almost same, but in Punjabis and Rajasthanis, they are taking about 10 grams of ghee every day. And what about carbohydrate? We in the East region take the highest percentage of carbohydrate, almost 67%, whereas the national average was 60%. and we are taking the same amount of fat, but we are same amount of protein, but we are taking less amount of fat, and we are getting the energy from carbohydrate as compared to northern or western counterparts. And now to carry coal to Newcastle, everybody here is a connoisseur here compared to me of alcohol. And what the alcohol shows, never drinker mortality and current drinker mortality are the same. But if you stop drinking, you die more. Former drinker, 1.5 times more death. So if you start, don't stop. Is that the message? I don't know. Cardiovascular disease, nothing to do with alcohol. And so there was a revel in UK and everywhere. Going to the pub is officially good for you according to Oxford University, and moderate drinking may reduce heart disease risk. So people are rejoicing, but we Asians cannot, because it was shown in Interheart study that all other countries get some benefit with alcohol consumption as far as heart is concerned, but South Asians are actually unfortunate. They cannot take alcohol. And this is Ramakrishnan's group published this in Atherosclerosis 2010. We did not observe any protective role of alcohol for coronary heart disease. In contrast, our study indicated an association in the reverse direction, suggesting possible harm of alcohol for Indian men. So ultimately, my last slide, American Heart Association gave a very wise approach only last year without quantifying anything, and which I think is beyond argument. A diet emphasizing intake of vegetable, fruit, legume, nut, whole grain, and fish is recommended to reduce ASCVD risk, that is class 1. All other as class 2 recommendation, that is replace the saturated fat with monounsaturated and avoid trans fat. A diet containing reduced amount of cholesterol and sodium may be beneficial. As a part of healthy diet, it is reasonable to minimize processed meat and refined carbohydrate, but do not take trans fat. So, friends, too many cooks spoil the broth, but still we may get a nice meal if we are pragmatic and see in between the lines. Thank you very much.
Thank you, Soumitra. Excellent talk. Can we have the discussion now for 2-3 minutes?
I have to go for the CSI vote counting, so you can finish me off.
I will ask you just one question. A patient who had a recent heart attack came to your chamber and asked about the diet, as almost every patient asks us. What will be your advice to him?
Number one,
forget about whatever you have said right now.
Yes. What
is your advice?
Number one is to achieve the right BMI. You have to calculate the total calorie.
Fine. That is one.
That is most important.
Right.
Second is, I would ask them to take a balanced diet. Do not shun carbohydrate. Do not shun your fat or anything, but take a balanced diet. Give the good quality of food. Sometimes people say, should we take the brown rice, brown bread? They are obviously good, but there are publications that this brown is actually an artificial color in India. So we have to be careful. I think your most concern is regarding the meat, poultry, and egg.
And the cooking medium.
I always recommend egg 3 or 4 times a week, as long as it is boiled or water poached, not with fried. Anything deep fried you should avoid. And the cooking medium should be a mixture of 3 types of oil. One is the safflower or sunflower oil. Number 2, the white oil, that is the rice bran oil. And number 3 is the mustard. Of course, you can, according to your food item, you choose the oil, cooking medium, but keep the total amount about 1 tablespoonful a day for yourself. Though it is very difficult to calculate the amount in a joint family where food is kept and consumed for 3 days, it is sometimes very difficult.
So in a nutshell, you are suggesting low amount of cooking oil, preferably mustard oil, sunflower oil, or rice bran oil, any mixture of them. That is number one. Number two,
fried oil.
You said about the eggs, not to take too many. It may be 2 or 3 or maximum 4 per week. Regarding the meat, regarding the red meat, what is your advice?
Right. Firstly, chicken is poultry. It is not meat.
I'm not asking about chicken, red meat.
Now, goat. Now, goat is a very dubious character because in Western world, goat is not consumed and goat is never classified as a red meat. Even lamb is not a red meat. The red meat starts from beef, pork, and veal. These are the three red meats. Goat and lamb, what we take, are in between, and there is no proper study. So I think if you can avoid that Rewaji meat with too much of fat, you can take that thing off, and if your medium is good, you can consume about 100-150 gram of goat about once or twice a week. That I always suggest.
So it boils down to what we used to say 15-20 years back. You are telling exactly the same thing today.
Exactly.
After going through all Selim Yusuf, all age and everything. Thank you, Soumitra. Thank you very much for retelling the same thing after 15 years. And thank you very much because you presented it in a new format. Thank you. Thank you very much.
Dr. Rai.
So, Anjuna, the organizers are telling me to quickly shift to the next one. You please have one question and go.
We are accustomed to believe that South Indians have high incidence of diabetes and ischemic heart disease because of increased incidence of diet intake of carbohydrate. Is it first thing that is it true that they have a greater intake of carbohydrate? And no. Second, is it true that the incidence is high in diabetes in South India?
As I showed that the carbohydrate intake in our study, the SCRIPT trial, showed that the Eastern Indians consume the highest amount of carbohydrate. The North South Indians, they take more fat because of the oil and other things. But diabetes is more because that may be genetic. That may not be anything to do with the food. That is genetic, their body structure and their genetics. I believe that.
Thank you very much, Soumitra. Thanks for enlightening us and putting the old wine in a new bottle. Thank you. The next speaker is Jayanto. Can you please suggest? I don't have the program with me.
Dr. Arijit Ghosh.
Dr. Arijit Ghosh. Is he here? Yeah.
Yes.
Arijit, please start your deliberation. We'll have the discussion at the end of the session.
Slides visible?
Yes. Nicely.
So, respected Professor Shantanu Guha, it is always very difficult to present after Dr. Soumitra Ray's presentation, but I have been given a task to discuss what we see beyond LDL. So I thank at the outset the organizer, Dr. Jayanto Shah, for giving me this opportunity. So let us not waste much time. LDL has been the optimal strategy is FT-LDL lowering the optimal strategy for patient care? Low density lipoprotein is widely recognized as an established cardiovascular risk marker predicted on the results from numerous clinical trials. This has been tried in the various primary and secondary prevention trials over the last few decades, which have demonstrated the ability of LDL-C to independently predict development and progression of coronary artery disease. And hence, LDL-C remains the primary focus in various of the lipid-lowering trials, as well as while assessing the evaluation of pharmacological effectiveness in treating patients of dyslipidemia. But yet, a large body of evidence suggests that narrow focus on LDL-C assessment and treatment alone is not the optimal strategy for patient care. Why do most of the guidelines have LDL-C as the primary target? Because of the overwhelming data that we have, the genetic influences, the clinical evidence of LDL causality and decreasing LDL decreases event that has been well established. These are the landmark secondary and primary prevention trials, which we have learned over the last few decades, which show that LDL has lowering of LDL proportionally decreases the ASCVD events. This is a community-based ERIC study, which also reiterates the same thing, that is, more LDL, more is the risk of future cardiac events. So this recently published 2019 ESC lipid guideline is not something which differs. It still holds the LDL-C lowering as the primary target for dyslipidemic patients. So there is a much residual CV risk with statins, even with intensive therapy. even after the reduction of more than almost 30% of CV events with statin therapy, we find a very high residual risk remaining for the prevention, and this ranges from 7 to 20% in the various trials. This is all true and is unacceptably high in patients who have received very high intensive statin therapy post ACS trials like PROVI-TB22, IDEAL, and TNT, which also shows a huge residual risk burden. This is true even when we are treating dyslipidemic patients with diabetes. So the unmet needs requires treatment of high triglyceride, low HDLC, as well as non-HDLC cholesterol. Framingham study was the first study to depict the fact that coronary high risk is most in the patient of insulin resistance, along with low HDL and highest quartile of triglycerides. Is there a role of non-HDLC cholesterol? Yes. What do we actually mean by the non-HDLC cholesterol? That is the total cholesterol minus the HDL cholesterol. And we all know that the atherosclerotic, the lipoproteins which carry the cholesterol to the different tissues of the body are atherogenic, and the HDL, as it carries the cholesterol from the peripheral tissues to the liver, is anti-atherogenic and protective. How do we calculate the LDLC? This is the Fred-Waals equation, which says that the LDLC in most of the labs are calculated based on this equation. That is the total cholesterol minus HDL and TG by 5. TG by 5 is actually the VLDL level, which becomes grossly unreliable with the increase in the triglyceride level, and it is not to be used when the triglyceride level is more than 400. So the points to ponder for non-HDLC goals. LDLC is still recommended as the primary target, but non-HDLC and ApoB can be used as a secondary target in the group of patients who are at very high risk. That is, patients who are having an established ASCVD, patients who are suffering from diabetes, or is patient from Southeast Asian ethnicity. So what did the British guidelines say in 2014? Non-HDLC cholesterol should be used in preference to LDLC cholesterol as the treatment goal for lipid-lowering therapy. This was said way back in 2014. We all know that triglyceride-rich lipoproteins, namely the VLDL remnants, chylomicron, and the chylomicron remnants, which are responsible are they at all responsible for the future CV events? Yes, this has been seen in the population-based Copenhagen CT trial, as well as the Copenhagen General Population Study, which shows that with the increase in the non-fasting triglycerides, the hazard ratio of myocardial infarction, ischemic events keep on increasing. So there is probably a relationship between the non-fasting triglyceride level and the future cardiac events. So whenever we talk about VLDL or the triglyceride-rich lipoproteins, they actually get bound to the proteoglycans on the arterial intima, which subsequently gets internalized by the macrophages, imbibed by the macrophages, giving rise to the foam cells, which leads to progression of the atherosclerotic burden, atherosclerotic plaque burden. So this is a very interesting trial. In the PROVI-TB22 trial, it was seen that the lowering of triglyceride beyond LDL was a predictor of preventing future cardiovascular event. This can be a secondary prevention strategy as well, where lowering of LDL along with lowering of TG to less than 150 gives the protection of future prevention of secondary cardiac event. So when we talk about lowering of triglyceride, we see that lowering of triglyceride in ACS patients have benefit both in long-term and short-term secondary prevention of coronary events. And this has been the data from the MIRACLE study. So the importance of targeting triglyceride points to ponder. A large body of epidemiological evidence substance a causal role for triglyceride and remnants in ASCVD at the population level. A small body of evidence from the interventional trials, such as the TB22 trial, PROVI-TB22 trial, shows that the lowering of triglyceride might be effective in preventing future cardiovascular events. And the achievement of low or normal levels of triglyceride may therefore merit consideration beyond LDLC in post-ACS patients. So this is ApoB, which is the major apolipoprotein of all the atherogenic lipoproteins, including VLDL, LDL, lipoprotein, and chylomicrons. And almost 90% of the total plasma ApoB is carried by the LDL. Can this be a preferred target? Non-HDLC incurs no expense in calculation, because I have already mentioned the formula by which we can calculate the non-HDL level. It can be obtained both in the non-fasting state. It is a better predictor in various epidemiological studies, and ApoB can be quantified as an atherogenic lipoprotein, and it can be reliably measured, especially in group of patients who have a very high triglyceride level. So in this graph, we find that the ApoB and the LDL can be predictive of future MI, and even ApoB might be more sensitive. So these are the primary prevention trials which show that ApoB might be a better predictor than LDL in predicting future cardiac events. The non-HDL and the ApoB predict CHD almost identically. And these are the hazard ratio which go in the same direction with both the non-HDL and the ApoB in similar trends. This is the typical lipid profile that we find in our population. This is ICMR India-B study published in 2014, which had shown that hypertriglyceridemia is very prevalent among the Indian population. Low HDLC is the major dyslipidemia that we find in our population, which accounts for almost 70 to 80% of the cases. LDL rise is not a very major problem in our part of the world, but so just merely targeting LDLC might not be serving the population that we cater. So what was the reason that LDL was of benefit? Because we have an extensive data, we have specific goals, and it becomes the disadvantage is that we cannot prevent CVD events if the triglyceride level is very high with just merely targeting the LDL by statins, or as we find in our population, the LDL being very low. On the other hand, non-HDLC supported from the various epidemiological data used in patients with high triglyceride, less sensitive to analytical errors. HDL analysis may be affected by high triglyceride. Automated measurements might be required in that situations. It is not a primary target in various RCTs, and it is not still in the risk algorithm. And the ApoB also has the similar advantages and disadvantages. So rising HDL, does it at all matter? This is the reverse cholesterol transport by which we find HDL anti-atherogenic. It is anti-inflammatory, it is antioxidant, and it is anticoagulant as well. So we have evidence. What are the evidence of HDL intervention? Studies which show benefits are the Framingham study, the various meta-analysis, a large-scale population-based study from Denmark, some observational study, and the COURAGE trial on stable patients. These are the studies which show that HDL hike might be of benefit. But there are various neutral studies as well. AIM-HIGH, HPS2, Jupiter, TIMI-22. No, there was no benefit of CETP inhibition. These were neutral effects of HDL rise. Lipoprotein A, is it at all effective, or it is the treatment is at all required? Lipoprotein A is basically a combination of lipoprotein, apolipoprotein A along with LDL. So this is the ESC lipoprotein statement, which shows that in the patients of CVD and diabetes, the goal should be less than 50 milligrams per DL. What we find is that with lipoprotein A, there will be a 50% reduction, and which will be equivalent to 1 millimole decrease in the LDLC level. So points to ponder. Reducing lipoprotein is likely to reduce other vascular outcomes, including stroke, PVD, aneurysm, and aortic stenosis, because 100 milligram per DL mass has the same effect of 1 millimole of LDL decrease. This patients who are having very high levels of lipoprotein A will be benefited from lipoprotein A lowering. Atherosclerosis and inflammation is always a much discussed topic. So we tried to find out whether CRP lowering will be beneficial, which was not beneficial in the various animal studies. Jupiter trial was the first trial to address the elevated CRP in patients who were having a permissible LDL and did not require a statin therapy for the LDL level per se, which showed that by addressing the CRP, there might be benefit in the primary outcome. But this was not this was not a consistent finding. The various other trials did not show the benefit of CRP in the future prevention of future cardiac event. The residual risk
time is almost over.
Okay, sir. So what I want to conclude is
complete it quickly.
The NCAP ATP3 guidelines, which was published in 2014, which has both LDLC and the HDLC target. These were the conventional risk factors. So the current ESC guidelines show that the HDL analysis, triglyceride analysis is a class 1 indication. Non-HDLC and the ApoB is also a class 1 indication. Lipoprotein estimation should be done in each adult person or for once for his lifetime, because more than 180 might be a very high risk for ASCVD. In the recent trial, in the targets, we find there are targets for all non-HDLC, ApoB, and triglyceride as well. So LDL is not the only target. What does the Indian experts say? The Indian experts say that non-HDLC should be calculated in every subject. This is the target for our lipid panel. And the targets for HDLC is not yet fixed. Targets for triglyceride is very important in our population. And the first step should be by lifestyle modification. Achieving non-HDLC goal will correct hypertriglyceridemia up to 200, up to 500. Statin might be used, more than 500, fibrates to be used. The take-home message is residual CV risk remains problematic despite LDLC. The studies provide evidence supporting the rationale of using non-HDLC targets. In both males and females, non-HDLC targets might be superior to LDLC, although it was previously believed that LDLC was the most atherogenic lipoprotein and thus became the target of therapy surveillance. It was now realized that all these lipoproteins confer the same atherogenic potential. Thank you.
Thank you, Arijit, for a very comprehensive illustration of the lipid risk factors and all. I was just wondering one thing, one question I will just ask. You didn't mention anything about the triglyceride lowering by the recently introduced icosapent ethyl and these drugs. Will you just have a single word on this?
So yes, triglyceride lowering by these drugs will be very helpful, I think, because
it has shown to be beneficial. At least it reduced the mass, though it did not reduce the it didn't increase the survival, but it reduced the mass in patients, even in statin-treated patients. So that is a very promising new drug, icosapent ethyl. Is a very promising drug because fibrates has not shown to be very much beneficial in different studies. Anjanda or anybody, any question? We can have one more question.
No, I just reiterate your question. The reduced IT trial have clearly shown icosapent benefit in reducing triglyceride, and reducing triglyceride means you reduce the non-HDL cholesterol as well.
Exactly.
4 grams BD is the dosage.
Yeah. That is what I wanted to just emphasize, because that thing should have come here. That is a new thing, and that is important. It has some good prospect. Thank you, Arijit, for your nice illustration of the non-lipid risk factors and all. Let us move to the next subject. Joyanta, can you tell me who is the next speaker?
Dr. Hema Rao.
Hema, please start your deliberation. And keep a watch on the timing. Your timing is 12 minutes. Am I any problem?
Yes, sir, I'm coming. 1 second. Can you see my slide?
Yeah, very good.
Good afternoon, sir. Respected Chairperson Dr. Go, sir. And my dear colleagues, the topic for me today is the newer concepts in primary prevention of CAD. See, as we know, ASCVD remains the leading cause of morbidity and mortality globally. Though substantial improvement has been there for the AVST outcomes in recent decades, because increased cost of healthcare service, cost of medication, loss of productivity has led to the suboptimal implementation in controlling these risk factors and increasing the AVST risk in many adults. So what exactly is meant by primary prevention here is to take an action prior to the onset of the disease to remove the possibilities that the disease will ever occur. That is, hit the disease at the pre-pathogenic phase of the disease, either by tailoring the therapy and so that it clinically significant disease does not occur by screening or health examination techniques. If you see the healthcare burden, it is almost 65, more than 65 years of age, people are going to increase by 20% in 2030. So which is going to lead to an increased economic burden for treating the CAD diseases. So what is, we have seen the death, if you see the death list, coronary artery disease tops the list. Even the morbidity, ischemia in coronary artery disease also is highest, which is shown in the million death study earlier. We know that CAD is multifaceted. There is the same modifiable and non-modifiable risk factors which has to be addressed. There are the 9 significant risk factors which has been shown in InterHeart study to reduce the risk of CVD has to be addressed. So out of which we can see 50% corresponds to the diet and the exercise pattern of the patients, which has led to the CV risk. The primary prevention of all these will lead to the further improvement in the coming decades. So what exactly is the efforts done? It's the recent ACCHA guidelines has given a very good clinical practical guidelines. They have just consolidated the existing recommendations by variant recent scientific statements and consciousness documents and giving a comprehensive patient-centered approach. What is it? It is a class 1 indication that it has to be a patient-centered approach for any primary prevention henceforth. What exactly is patient-centered approach? It is a team of interhealth personnel like physicians, dietitians, physiotherapists, and even the pharmacists. They'll take care of this the AVSD risk in the population. The clinician estimates the social determinant, social inequalities, which is the main determinant globally. He has to consider the patient according to his economic status, his cultural habits, and educational status to counsel him in every clinical visit. There'll be a shared decision making by the patient and the relatives for the exact treatment plan. For any treatment plan, we need to have a risk estimator. So apart from the Framingham risk score earlier, now the AVSD risk remains the foundation of primary prevention. It just estimates the near 10-year risk of the patient developing a heart disease and gives the cardiovascular outcome. It is external validation by MESA trial also signifies the overestimation, underestimation bias in considering the race and the age of the patients. What exactly is this risk score? 0.49 is low, 5 to 7.4 is borderline, 7.5 to 20 is intermediate, and greater than 20 is high. This estimator comes as an app which estimates the percentage risk in any patient and also gives, not only estimates, it also gives the treatment benefit, this app. So what exactly is the class 1 recommendation for any patient for primary prevention is in the age group of 40 to 75 in every clinical visit should be assessed for AVSD risk by pooled cohort equation is class 1 recommendation. Why it is important to address people in intermediate and borderline risk? There is tsunami of heart diseases in India, premature heart diseases. So we consider the intermediate and borderline risk by estimating the risk enhancing factors in every patient beyond other than this age group. That is by considering the family history of premature coronary artery disease, less than 55 in males and 65 in females, patients to see whether he or she is having a metabolic syndrome, chronic kidney disease, chronic inflammatory disease. What is new? To use the coronary calcium score by Augustin's unit. It actually recalcifies risk upwards if it is above 100 or downwards if it is below, if it is 0, that is. So who are the patients who get benefited in this additional tool? They are patients who are reluctant to take statin for prevention. They are having statin associated symptoms, young or high age women with less AVSD burden or borderline risk group. It is also, this additional tool also has this AstroCharm risk score. It is this estimation of risk factors along with this coronary artery calcium score to estimate the approximate risk in this different population rather than the usual one. The ABCD of primary prevention still remains the aspirin, blood pressure, cholesterol, cigarette smoking, diet, and diabetes and exercise. So what is it? It's a class 1 recommendation for as it considers 50% of the risk factors, nutrition and exercise has to be given the first preference and counsel in every clinical visit. As Dr. Ray has told about the nutrition in detail, it is usually advisable to prescribe the Mediterranean diet, which contains vegetables, fruits, legumes, fish and whole grain. Saturated fats to be avoided, trans-saturated fats to be stopped anymore. Then there is what is the new concept of exercise and physical activity? At least 150 minutes of moderate exercise and 75 minutes of vigorous is advised for general population to avoid the further AVSD risk. What is moderate exercise? It is brisk walking, you can say biking, yoga, recreational swimming. Vigorous is for younger patients who can go for biking, swimming laps, jogging, etc. What are the other factors we have to address? Obesity. Obesity per se is a major risk factor, but it also can give rise to the other risk factors like hypertension and other major factors of cardiovascular risk. To address this, we got to calculate the BMI of all the patients, waist circumference, advise them to keep below 104 for males and less than 88 for females. If it is unsuccessful after 3 months or 4 months, consider the bariatric surgery is reasonable for these obesity patients as a newer strategy. What is the role of SGLT inhibitors in diabetes now in recent as a primary prevention? If you see the DECLARE-TIMI, CANVAS, EMPEREG, CREDENCE, it is not only decreases the glycemic index but also decreases the CV risk, good CV outcome, cardiorenal outcomes. So it is reasonable to consider, along with the other glycemic index reducing drugs, to add with the established type 2 diabetes having an AVSD risk. But metformin still remains the class 1 first line of treatment for any newly diagnosed diabetes. What about hypertension? We have seen ACCORD trial did not support much in microvascular complications. So recent HOPE and SPRINT trial having an intensive blood pressure control of less than 120 has shown a lower rate of fatal and non-fatal cardiovascular events in the and deaths. Even we can see the microvascular complication in diabetes is independent to that of the risk factor as diabetes itself. So it is very ideal to keep an intensive blood pressure control to all the patients according to the risk. First and foremost is a non-pharmacological intervention for blood pressure should be advised for all. That is weight loss, heart-healthy diet, Mediterranean DASH diet treatment, sodium reduction of 1 to 1.5 grams, increased potassium supplement, and increased physical activity. What is the other recommendation? Any blood pressure above 130/80 has to be targeted with an intermediate AVSD risk. And in other patients with established hypertension on treatment, target to be 130/80, even in patients having diabetes or chronic kidney disease. What about high blood pressure, high cholesterol? Statins remains the primary line of treatment here. In primary line of treatment here, it is established that higher risk patients do benefit with statins. And coming to the intermediate and borderline, they have to be considered accordingly. Intermediate, you have to advise a moderate intensity statin. In patients who are undiagnosed, we don't have a decision whether we have to start a statin. We got to take on different tools like here the role of coronary artery calcium score comes. If it is 0, there is no need to treatment. If it is 1 to 99, above 55 years, he is reasonably benefited with statin. And if it is above 100, it is definitely benefited with statin. The most important here of next is the tobacco smoking, which increases with the number of cigarettes smoked. The CV risk increases with the number of cigarettes smoked. So the most important target here is to counsel the patient for total tobacco abstinence and then go for the pharmacological therapy, which is now the class 1 indication in form of nicotine replacement therapy in the form of gums, patches, lozenges, and all those things. If they ask the dosage, you can say 1 to start with, then 2 until we watch for 3 months, and there is no improvement in 3 months. They can go for a pharmacological approved drugs like bupropion and varenicline as once or twice daily dosage. Lastly, aspirin use, as per the recent trial ARRIVE, ASCEND, and ASPIRE, it still is not the class 1 indication for the primary prevention. As considering the patients of 40 to 70 years of age, it is reasonable with AVSD patients to start as a primary risk, not having the increased bleeding risk. And for the other patients above 70 years, it is shown there is a higher bleeding risk incidence. So there is no role of aspirin as a primary prevention, and is contraindicated in age more than 17. Other age groups, there is not seen any risk benefit as per ARRIVE trial. So take home message for the newer way of primary prevention is most important is prevention of atherosclerotic cardiovascular disease, promoting healthy lifestyle throughout the life in every patient has to be counseled. A team-based approach is a newer concept here. All patients around 40 to 75 are the target for AVSD risk estimation. Most importantly, considering the country like India, we have to see the patients with intermediate and low risk, assess the enhancing risk factors, go for newer tools like coronary calcium score, and provide with the available drugs like statins to prevent the CV risk in future. So anytime prevention is better than cure, an ounce of prevention also is better. Thank you.
Thank you, Hema, for a very nice demonstration of this primary prevention and finishing just in time. You have finished just 1 minute before your scheduled time. Thank you very much for that. Just one question.
Yes, sir.
You have very nicely said most of the things in primary prevention. Only issue which actually hit the ear is why you are insisting on ACVD risk or by the pooled cohort equation. No Indian patient was involved in that study. This is for the Americans, basically white Americans, Hispanics, and all. So just extrapolating this thing in the Indian subset, how reliable it is, I have my own reservation. Your opinion.
Actually, the AVSD risk has a simple data entry, which can
I
be...
I know that.
Simple data entry, so the risk calculation is easier at the clinical setting.
Absolutely. There is an app, you can get the risk calculation in just a few minutes. That I know. But how reliable it is in the Indian perspective, that itself is a question. There are other risk calculators like the European Society have used SCORE and they have given a multiplication factor.
Overestimating. So there are some studies.
With a multiplication factor for South Asians, 1.4.
It's very complicated to calculate.
It is more complex, agreed. Framingham's can be done with some multiplication factor.
Overestimation for Indian population.
Exactly. So we do not have any risk calculator which is specific of our own. It is better we try to develop something. Any question? Anybody?
Sir, good afternoon, sir. This is Dr. Imran Ahmed. Nice to see you back recovering from COVID.
Thank you.
And once again, Hema has done a very good job. She has covered a lot of topics. One thing about aspirin, I would just like to mention that once aspirin primary prevention, now a lot of concerns are there. Age in between 40 to 72. Once you can prescribe, you have to individualize. So you have to see the bleeding risk. Suppose there's a history of GI bleeding or any other visceral bleeding.
Exactly. You need to use what you said is correct.
Correct, but in
very high risk patients, you can individualize it and give it. You need not give it as a blanket treatment.
Yes,
Thank you. Thank you, Hema.
Thank you.
Let us call the next speaker.
One question.
Anjana, quick.
Q risk should have been mentioned because that includes certain collagen.
In England, that is being used. Q risk can be used here, but there are several other things. We didn't go into it.
I covered the major risk factors. That's it.
The reason because is that it includes the inflammatory disorder, rheumatoid arthritis, psoriasis, atrial fibrillation, which are very common.
She mentioned it.
I mentioned
in one of the
population of enhanced primary risk factors.
And second,
but you did mention this word Q risk. Q risk can also be tried.
Q risk.
Okay.
And second issue is that SGLT2 inhibitors causes CV reduction death through reduction of the heart failure.
Heart failure only.
This is for primary prevention. So I did not consider heart failure for this
that's right.
presentation.
SGLT2 inhibitors should not be mentioned because there is no evidence that it reduces coronary artery disease. All the reduction is heart failure related.
Heart failure.
Reduction of death.
Okay, sir.
Okay, Anjana, thank you very much. So the next speaker is?
Dr. Ram Mohan Rai.
Dr. Ram Mohan Rai, please. Is he here?
Yes, sir. Can I share my screen?
Please. You're welcome.
Is it visible, sir?
You are visible, but your screen is not visible.
Is it visible, sir?
Ram Mohan, sorry, we couldn't see your screen.
Screen share you have to do, Ram Mohan.
Doctor, open your presentation first. Please open your presentation first. Open it and don't minimize it. Just open your presentation.
Okay, I've opened it already.
Now share screen. At the bottom, you see a share screen button.
Okay.
নিচে সবুজটা
Is your presentation on the desktop?
Okay. Yeah.
Okay. Now it is coming right. Fine.
Okay.
Excellent.
So, good afternoon, moderators, sir, respected chairpersons, faculty members, and delegates. So, when we discuss about statin intolerance, more common terms we often use are statin-associated side effects and statin-associated muscle symptoms. Statins, as we all know, substantially reduce the risk of myocardial infarction, stroke, and other manifestations of atherosclerotic cardiovascular disease. It reduces the risk of vascular mortality by about 1/5 per each millimole per liter reduction in LDL cholesterol. Statins are usually safe and well tolerated, and the adverse effects of statin in different randomized controlled trials are mainly myopathy, which are actually reported in 1 to 2% in different RCTs, and around 5 to 10% in different observational studies. Now, statin-associated muscular symptoms are mainly myalgia, myositis or myopathy, and rhabdomyolysis. Myalgia are nothing but muscle aches or weakness in absence of CK rise. Myositis or myopathy is called when there is the symptoms of myalgia along with CK rise more than upper limit of the normal, with concerning symptoms or objective weakness. Rhabdomyolysis is called when there is pronounced a CK elevation that is usually more than 10 times of the upper limit of the normal with muscle symptoms, and it is usually associated with urine myoglobin and renal dysfunction. Now, we also have to remember about other causes of the CK elevations. This may be hypo or hyperthyroidism, renal dysfunction, artifactual elevation, physical exertion, seizures, or trauma.
Okay, thank you.
Now, European Society of Cardiology 2015 consensus, they have also uttered the term myalgia, myopathy, severe myopathy, and rhabdomyolysis. Now, they have divided the upper limit of the normal, the CK level, into two groups. If it is less than 4 times of the upper limit of the normal, they use it, the myopathy term, and if it's more than 10 times of the upper limit of the normal, they specifically use severe myopathy. And in case of rhabdomyolysis, they actually use more higher elevation of the CK level, that is more than around 35 to 40 times of the upper limit of the normal. Now, it is important to remember that in certain persons, the CK level normally can be elevated, and in those persons, these are not actually related to statin therapy, and these are of no significant clinical relevance, so we can easily continue statin therapy in those persons. Now, other statin-associated side effects are new onset diabetes mellitus, which is more infrequent if diabetes mellitus risk factors are present, such as BMI more than 30, fasting blood sugar more than 100 milligram per TL, metabolic syndrome, or A1C more than 6%. Transaminase elevation can occur, which may even go beyond 3 times of the upper limit of the normal, but these are very infrequent. Hepatic failure is very much rare. There has been few case reports of memory or cognitive impairment, but the randomized controlled trials didn't show any increased incidence of this memory impairment. Statin can cause proteinuria because of inhibition of reabsorption of protein in the tubular lumen, but it does not usually cause renal impairment. It is important to know that there is no association of statin therapy with cancer, renal failure, cataract, hemorrhagic stroke, tendon rupture, interstitial lung disease, or low testosterone. Now, when you use the term statin intolerance, the National Lipid Association defined it as inability to tolerate at least 2 statins, one statin at the lowest starting daily dose and another statin at any daily dose due to either objectionable symptoms or real or perceived or abnormal laboratory manifestations which are temporarily related to statin treatment and reversible upon statin discontinuation. Now, what is the incidence of statin-associated muscle symptoms? In different randomized placebo-controlled trials, it has been seen there is no such significant increase in SAMs in the statin group in comparison to the placebo group. But in retrospective observational studies, there have been increased incidence of statin-associated muscle symptoms. Why is it so? The main causes of discrepancy between the RCT and observational studies may be that exclusion of patients unlikely to adhere or using interacting drugs by a pre-randomization phase or a run-in phase were done in the RCT group. So there have not been much increased incidence in the statin arm. On the contrary, in observational studies, lots of patients of whether elderly, infarction patients, stroke, diabetes, ESRD, they were included. So there had been a much improved incidence of SAM. There may be a lack of questionnaires in certain studies for muscle symptoms like don't ask, don't kill. Suppose in one study, in heart protection study, the investigators questioned muscle symptoms every visit and around 1/3 experienced muscle symptoms more than one time. Lastly, the patients often associate muscle symptoms with statin use by either package inserts or a doctor's warning or a media attention or an internet search, which often create a negative placebo effect, which are also called a nocebo effect. Now, the incidence of muscle-related symptoms during high-dose statin treatment, the onset is usually within first month of the starting of the statin therapy. The trigger for muscle-related symptoms are unusual physical exertion, starting new medication, muscle pain location is usually widespread, lower extremity is more involved than the upper extremity. It is usually bilateral and involves the proximal muscles. The muscle pain is usually continuous in around 1/4 of the patients, and in other 3/4, it is usually intermittent and lasting for minutes to hours. Now, what about the mechanisms of statin myopathy? The common mechanisms that have been postulated are excess exposure to statins that may lead to increased plasma levels, increased transmembrane flux of statins. There might be pre-existing neuromuscular disease, which may be previously undiagnosed. It may be caused by impaired calcium handling in skeletal muscle. The statin-induced myocellular metabolic dysfunction can happen. And lastly, the immune-mediated inflammatory myopathy. Now, one important thing about this immune-mediated inflammatory myopathy is that it does not regress after stoppage of the statin therapy, and it often requires a specific treatment for the polymyositis or dermatomyositis. Now, it is important to remember that certain hydrophilic statins, like rosuvastatin, pravastatin, or fluvastatin, are thought to be actively transported into hepatocytes by expressing OATP, that is organic anion transporting polypeptide, whereas lipophilic statins diffuse non-selectively into extrahepatic tissues such as muscle and is more commonly associated with muscle symptoms. As you can see, the pravastatin and rosuvastatin are more hydrophilic drugs, whereas simvastatin, atorvastatin, lovastatin, these are lipophilic drugs. Certain other risk factors we might remember for statin-induced myopathy are older age, that is more than 8 years of age, female gender, Asian race, genetic predisposition like single nucleotide polymorphism in chromosome 12, family history of statin intolerance, certain comorbidities we must consider, that is hypothyroidism, systemic disease involving liver or kidney, alcoholism or drugs, major surgery, particularly the perioperative period, excessive physical activity, and lastly, different kinds of hereditary or acquired cardiomyopathy. Now, muscle-related side effects usually are not related to the lipid-lowering potency of the statins. The high-dose statins, when we have used above the approved doses, then there is more chances of muscle-related side effects, and different RCTs have proved that in high versus low statin dose, in high-dose statin groups, didn't show any increased myopathy. Now, properties of statins, what we should consider is lipophilicity, what I have already discussed, the bioavailability, and the potential for drug interactions. Now, there are certain inhibitors of the CYP enzymes which metabolize the statins and that may increase the symptoms of statin-induced muscle symptoms. Now, these are mainly the protease inhibitors, cyclosporine, amiodarone, fibrates, macrolide antibiotics, or diltiazem. So, it is better to avoid statin and gemfibrozil combination. Statin plus fenofibrate combination should be used very cautiously. When we are using anti-rejection drugs like cyclosporine, we have to limit the statin dose to rosuvastatin 5 mg or atorvastatin 10 mg. When we are using macrolide antibiotics or antifungals or HIV protease inhibitors, if the patient develops the symptoms of statin intolerance, we might have to discontinue statin during the treatment. It is better to avoid lovastatin or simvastatin, and we can initiate atorvastatin at 10 mg. Now, amiodarone and diltiazem are very commonly used in our day-to-day practice. So, if the patients complain of symptoms, we might start with a lower dose of statin, though it rarely causes a statin myopathy. Now, what the ACC guidelines say on statin-associated side effects. A clinician-patient risk discussion is recommended. It's a class 1 indication regarding the risk as well as the benefit of the statin therapy, particularly patients of atherosclerotic cardiovascular disease. A thorough assessment of symptoms is recommended if any patients present with any symptoms. Now, in patients with indication of statin therapy, identification of potential predisposing factors which might lead to statin-associated symptoms should be sought before starting the initiation of the treatment. It is important to reassess and to rechallenge to achieve a maximum LDL cholesterol lowering by modified dosing regimen and alternate statin or in combination with a non-statin therapy. In case of new onset diabetes mellitus, it is recommended to continue statin therapy with added emphasis on adherence, net clinical benefit, and the treatment of the diabetes that includes the diet and lifestyle modifications. It is recommended to measure creatine kinase level in individuals with severe statin-associated muscle symptoms, objective muscle weakness, and to measure liver transaminase if there are symptoms of hepatotoxicity. In patients with stable liver disease, it is better to do a baseline measurements before starting statin therapy, and recurrent statin-associated muscle symptoms, despite appropriate statin rechallenge, if occurs, then it is better to seek to a non-statin therapy.
Ramon, your time is almost over.
Sir, I have a few slides left. Coenzyme Q10 is not recommended for routine use, and routine monitoring of the this creatine kinase and liver enzymes are also not recommended. Now, statin withdrawals, of course, we all know that it leads to increased cumulative mortality or cardiac mortality over years. Now, can you identify patients at high risk of developing statin-induced myopathy? We must take the history of myopathy, the personal history of unexplained cramps, the history of CK elevation, the family history of muscular symptoms, myalgia while receiving lipid-lowering therapy, and untreated hypothyroidism. Now, it is important to remember that antidepressant medications often significantly reduce the prevalence of muscle symptoms. Now, as far as the ESC guideline, if you have the symptoms of statin-associated muscle symptoms with a CK level less than 4 times, we wait for 2 to 4 weeks for washout of statin, we rechallenge with statin, we check for other causes of muscular symptoms, or if the symptoms improve, we can start with the second statin. If the symptoms recur, we can start with the third efficacy of statin. We can increase the interval of the dose to once or twice weekly. If the enzymes is more than 4 times, a 6-week washout time is given, and then to start a low dose third efficacy of statin and increase the interval. In case of rhabdomyolysis, better to stop statin. Now, the aim is to achieve LDL cholesterol goal with maximally tolerated dose of statin. We might consider adding ezetimibe, PCSK9 inhibitor, or bile acid sequestrant agents. The statin intolerance to be assessed carefully. The nocebo effects should be kept in mind, and patients' clinician risk discussions should be done. Hydrophilic drugs might be safer. Maximally tolerated statin dose and interval are to be applied, and consider other lipid-lowering agents. Thank you very much, sir.
Thank you, Ram Mohan. Thank you very much for a very nice and elaborate description of the statin intolerance. Particularly, you have emphasized on the muscle symptoms. Jayanto is pushing me that there's hardly any time. I'll ask just one question. That's my also, I have a personal doubt as well. A patient who has been given a statin, you are finding the SGPT at around, say, 125. What you are going to do? You have repeated it at the same dosage, this remains same, even after a gap of 2-3 months. What is your advice in these patients? You reduce the dose of statin, continue same, or switch to something else? That is the issue.
If the patient have any complaints, muscular complaints, and
no muscle complaint, no complaint. No patient is asymptomatic. Only SGPT is high.
Okay, sir. The asymptomatic patients with persistently raised hepatic enzymes, we must stop statin for 2 weeks. If it remains persistently elevated, we should consider about other causes of liver diseases, or we should find out some other causes. If we found that there is no such cause and the patient is absolutely stable with no such clinical manifestations of different liver diseases, that we might safely continue the statin therapy.
Exactly. Thank you very much. This is exactly what I wanted you to say. You can stop it temporarily, but if there is no cause is found and it remains elevated, you can restart the statin and continue. That is exactly the message I wanted you to percolate. Thank you very much, Ram Mohan.
Thank you, sir.
The next speaker is Somnath Mukhopadhyay. Somnath, please start your deliberation.
Good afternoon, sir. Good afternoon, my respected colleagues. And a heartfelt thanks to Professor Jayanto Saha for giving me this opportunity. My topic of discussion is PCSK9 inhibitor, the current status of this new molecule in our lipid arsenal. Protein convertase subtilisin pexin type 9 inhibitor is an LDL controller. It's a low abundance plasma protein which reduces LDL receptor expression by promoting upon binding internalized LDL receptor lysosomal catabolism and a subsequent increase in plasma LDL. So therapeutic strategies are developed using monoclonal antibodies to reduce PCSK19, and statin treatment increases circulating PCSK9. Thus, best effect has been demonstrated with combination with statin. Why PCSK9? Because the answer lies on genetic significance. Gain of function mutation leads to FH, and loss of function mutation revealed 40% lower LDL-C than mutation-free controls. And a study, ARIC study, which revealed reduction of LDL-C 28% is associated with reduction of ASCVD 88% with loss of function mutation populations. Some individuals are noted to have complete absence of PCSK9 with LDL-C 15 to 20 milligram per TL. Now, the LDL lowering capacity, clinical trials showed significant LDL reduction on an average 60%, depending on dose, either alone or in combination. Efficacy appears largely independent of any background therapy, and in combination with statins, they reduced LDL around 46 to 73% more than placebo and 30% more than ezetimibe. They have shown efficacy with ezetimibe where statin could not be prescribed. Role in FH, given the mechanism of action, they are capable of reducing LDL-C in all patients capable of expressing LDL receptor in the liver. This pharmacotherapy is effective in heterozygous population and to a lower extent in homozygous population where residual LDL receptor expression is there. Receptor deficient patients respond poorly. Role on triglyceride and HDL, evolocumab and alirocumab both lowered triglyceride and raised HDL and raised ApoA also around 4 to 5%. Effect on triglyceride must be confirmed in patient populations having higher plasma triglyceride at initiations. Now the important thing is role on lipoprotein A. Is it a novel lowering agent? LPA is an independent risk factor for ASCVD. there is no FDA-approved therapy till date, and PCSK9 has the capacity to lower it either alone or with niacin. Evolocumab lowered it around 27% from baseline, and alirocumab lowered it 23.6%, and greater efficacy was displayed with higher baseline values. Mechanism being increased clearance via either LDL receptor or other receptor like LRP1, CD36, TLR2, etc. And reduction in ApoA secretion production assembly also plays a role to lower LPA. But there is little correlation seen with LDL reduction and LPA reduction even with PCSK9. PCSK9 inhibitors reduce LPA more than LDL in homozygous patients having null LDLR mutation. There are two well-known trials, Fourier and Odyssey outcome. In Fourier trials, there are 27,564 patients having ASCVD with LDL more than equal to 70 milligram per DL on statin, randomly assigned to receive evolocumab or placebo, and evolocumab reduced median LDL-C from 92 to 30 at 48 weeks. There is 15% reduction in primary endpoint, composite of CV death, MI, stroke, hospitalization due to unstable angina or coronary revascularization, but evolocumab did not reduce CV mortality or all-cause mortality. Next is Odyssey outcome trial, in which 18,924 patients are included, where LDL-C more than equal to 70 or non-HDL more than 100 or ApoB more than equal to 80, but the setting was AMI or unstable angina, SCS setting. And mean LDL reduction was from 92 to 48 after 12 months. Again, there is 15% relative risk reduction for primary endpoint after follow-up of 2.8 years. Although there was a significant reduction in all-cause mortality, this was an exploratory outcome and was not supported by a significant effect on CV death. So, compare those studies and those molecules. Evolocumab is approved for a broader range of indication than alirocumab. It is approved in homozygous patients also, homozygous FH, and heterozygous FH for additional LDL-C lowering and prevention of CV events. Now, the clinical scenarios are different in choosing patients in Fourier, where ASCVD was there stable, and ACS was there in Odyssey outcome. Odyssey outcome trial had a target LDL in lowering, which is 25 to 50. And there is a relative reduction of mortality was there in Odyssey outcome trial. Now, considering the adverse effect and interactions, itching at the site of injection or flu-like syndromes were there, Ebbinghaus trial assured that there is no significant neurocognitive dysfunction. Mendelian randomization studies suggest risk for diabetes with an LDL-related effect, but 7-year data from IMPROVE-IT study have shown prolonged low LDL is not associated with any clear side effect. Another thing is bococizumab was discontinued due to neutralizing antibodies, resulting in attenuation of LDL lowering effect as well as injection site reaction. It was postulated that the presence of 3% murine sequence in the IgG of bococizumab that was responsible for this anti-drug antibody. Now, regarding controversies, the main controversy is the high cost of therapy. Regarding resistance of the PCSK9 inhibitor, the hyporesponsiveness means less than 15% reduction in LDL-C. The most common cause of apparent resistance is discontinuation of concurrent lipid-lowering therapies after PCSK9 initiation. Anti-drug antibody is rare, more or less theoretical, and its presence does not necessarily reduce effectiveness, as they may not reduce the ability of therapeutic antibody to bind its cognate. To assess the possible PCSK9 inhibitor resistance, there is an algorithm where they measured plasma PCSK9 concentration on therapy and again 2 weeks later off therapy. And they measured PCSK9 value, whether it is less than 1200 nanogram per ml or more than 1200 nanogram. Where the PCSK9 level is reduced, then there is a chance of lack of adherence, injection technique, dermatological pathology, antibody disposition, and target recognition. But where the PCSK9 is elevated, but the reduction of LDL is less than 15%, there may be dysfunction of PCSK9, dysfunction of LDL receptor, or dysfunction of ApoB or ApoE. So considering these things, guideline-based recommendations led class 1 indication for 2 conditions for PCSK9. PCSK9 inhibitor. First is for secondary prevention, patients at very high risk not achieving their goal on a maximum tolerated dose of a statin and ezetimibe, a combination with a PCSK9 is recommended. For very high risk FH patients, that is with ASCVD or with another major risk factors who do not achieve their goal on a maximum tolerated dose of a statin and ezetimibe, a combination with a PCSK9 inhibitor is recommended. And 2 class 2 indications are for primary prevention, patients at very high risk, but without FH, if the LDL goal is not achieved on a maximum tolerated dose of a statin and ezetimibe, a combination of PCSK9 inhibitor may be considered. And when the statin is intolerated, then dosage, if even after rechallenge, a PCSK9 inhibitor with ezetimibe may be considered. So the last thing is future direction of this PCSK9 inhibitor, whether it is opening the door of primordial in prevention. Another molecule is inclisiran, that is siRNA oligonucleotide, which inhibits translation of PCSK9 mRNA into biologically active protein. Inhibition of intracellular production of PCSK9 leads to lowered plasma PCSK9 without compensatory increase, which is seen with monoclonal antibodies. But the clinical significance of this thing is unknown. The siRNA technology allows prolonged duration of action and attractive pharmacokinetics. Other oral small molecule inhibitors, vaccination, and clusters of regularly interspaced short palindromic repeats are other recently developing approaches, and that is the current status of these PCSK9 inhibitors. Thank you for patient hearing.
Thank you, Somnath. Very nicely said about the PCSK9. All the entire session is open for a discussion. We have 3-4 minutes time. Onyanda, Imran, any chairperson, co-moderator, anybody can ask. They can ask anybody because now we are having 3 minutes time. Imran, you are here. So Imran or Onyanda, none of them are there. So it leaves only myself. Okay, Somnath, I'll ask you just one very practical thing. In this era of very cost effectiveness and the very high cost of PCSK9, what is your real indication for giving this molecule in a patient? When you will tell the patient that you try this thing?
Thank you, sir. It is a very difficult question, but perhaps only some heterozygous familial hypercholesterolemia patients who are having very high LDL and having ACS and affordable, those patients might try for PCSK9 inhibitors.
I give you a clinical scenario. Patient had an ACS. Now you have tried with maximal dose of a statin. LDL is still high. You added ezetimibe. LDL is around 60, between 60 and 70, but the patient's risk is very high. Do you consider giving PCSK9 in this?
Yes, sir. Then I have to consider. Definitely.
So these are the scenarios we need to individualize when we cannot rely on the guidelines, because the guidelines do not consider the cost, and we have to consider the cost of therapy here.
Absolutely.
That is the main issue. This is a very good drug. PCSK9 inhibitors are very good drugs. It reduces LDL by around 60% only, and in combination even more. But because of the cost, perhaps we are unable to give it. Any question on this lipids to anybody? Otherwise, we close the session and hand it over to.
Hello. Can I ask a question?
Sure. Kumar, welcome.
I think I joined just now because for the next session, but in the context I'm just hearing in the last part. So whether it can in future, if the cost is solved, whether it come in the first line, then if it is so good a drug, first line before start.
If cost can be, sir, can I answer the question?
Yeah, it's to you only.
Sir, I think it is an extremely good molecule, and added to its LPA reducing quality, it should be the first line drug if the cost benefit ratio alters, if the cost lowers. It should be the first line drug.
It's premature to comment or not, I don't know.
It is little premature to comment. And regarding the LPA, one issue is that is important in the younger age group. Beyond the age of 55, hardly LPA has any role. So in the younger age group, if it is high, well, what you are telling may be correct, but in the relatively middle-aged or elderly, LPA doesn't have much of a role. Anyway, perhaps the time is up. And Jayanto, if you are here, we close the session and hand it over to you.
Thank you, sir. It was a nice session. So you are moving over to the...
hello, Raghu.
Hello.
Hello.
Sir, we will have to give a break of just 2 minutes. Kindly, this is a small break of 1 to 2 minutes. Kindly bear with us. Please go ahead.
Yes, Raghu.
Andalika, can you show some advertisement thing first?
Sir, okay. My technical team will show you. Okay. Sir, just a minute.
All right. Go ahead.
Hello, Dr. Jayanto Shah, am I audible?
Just hold
on. This is for 1 minute. Break.
Just hold for 1 minute, sir.
1 minute.
Raghu, please enable me.
Yeah, it's done. Done. You're already enabled.
Post disabled participant screen sharing.
Go ahead. It's done.
Done. Okay.
Okay, Jayanto, thank you very much.
Thank you,
for
sir.
giving me the opportunity. And I leave now. Thank you. Thank you very much.
Thank you.
Okay, done, Raghu.
Yeah. It is share. You have started. If you're not seeing it, you have started screen sharing. Yeah, it is there now. Yeah.
It is there.
Put it on slide share mode. Put it on full screen mode.
I understood. Slide share mode. I understood. Okay.
No, it's fine. It's coming. Yeah. Right.
It's done. Okay. Now I stop share.
Yeah. Stop share.
Okay. Acha, Raghu. Hello.
Yeah, bolo.
Raghu, can you please play the video of any industry for 2 minutes right now?
Yeah, sure. Give us the videos.
Please.
Which video?
Sir, Dr. Bityajit, sir. Sponsors video, sir. Which company, sir?
Anyone, all of them.
Any, Raghu, any.
Yeah, we'll just play after the next talk because we have to download those videos.
Okay.
So
the next talk in between.
Next on cardiomyopathy. Our next session is on cardiomyopathy. Our chairpersons are Dr. Achut Sarkar, Dr. Sukumar Ghosh, Dr. Spandan Bhaduri, Dr. Prakash Hajra, and our moderators are Dr. Manoranjan Mandal, Dr. Tanmoy Majhi, Dr. Sandeep Patro, Dr. P.C. Bagchi, and Dr. Dipesh Agarwal.
Professor Ghosh, please introduce the speaker.
Okay. Good afternoon to everybody. And our next session is a very important and interesting session of cardiomyopathy. My co-chairpersons are Professor Achut Sarkar and Spandan Bhaduri and Dr. P.K. Hajra. Our first topic is on HCM, risk stratification, is going to be delivered by Dr. Munna Das. So may I request Dr. Munna Das to start the deliveration.
Thank you, sir. Dr. Jayanto Shah, can you share your screen? Hello. Dr. Jayanto Shah, can you share your screen? Yeah. So to start off with, I thank
Sorry. Yeah. Sorry.
So to start off with, I thank all the executive members and the Scientific Secretary of CSI West Bengal branch for giving me this opportunity, the platform, to speak on a very important topic, hypertrophic cardiomyopathy. Basically, we know that hypertrophic cardiomyopathy is a genetic disease. This particular disease has several risk markers on that can predict roughly whether this patient is prone to sudden cardiac death. We know that we have severity of LVH, septal wall thickness more than 30 millimeter, or patients having non-sustained ventricular tachycardia at rest or during exercise, an abnormal blood pressure response that is on exercise, that is hypotension during treadmill, or a family history of sudden death in the first degree relative, or unexplained syncope are all established risk markers. Others include fibrosis or scar as detected on the CMRI, and outflow obstruction significant with a gradient more than 50 millimeter mercury during provocation, and more than 30 millimeter mercury at rest on echo, and also genetics including a role of isolated myofilament mutations, in particular your beta-myosin heavy chain and troponin C mutations.
The slides are not visible.
The slides are not visible, I think. Dr. Jayanta Saha was going to share his screen.
Actually, probably they have centered the presenter.
Hello?
The slides are not being visible.
Hello? Is the co-host sharing the screen?
Hello, technical team, hello.
Anyway, I will just continue. Because
Adhunika, are you? One second, sir. Whose presentation you are trying to share, Adhunika?
Dr. Munna Das. Munna Das, sir, okay. Please now share your presentation, sir.
Send Dr. Das, we have to share your presentation.
No, I had already asked Dr. Jayanta Saha. I had already posted my presentation already to the this executive people of the CSI thing who are actually.
So right now, if you have your presentation handy, do you have your presentation handy?
I have my presentation handy, but it is in. I'm operating through a smartphone, so I cannot share.
You send it to us on WhatsApp. If you can do that now, we will share it for you immediately.
Okay, then I have to just give me just 1 sec. 1 sec.
Yeah. What is your number, Dr. Munna Das?
It's already sent. See in the WhatsApp CSI West Bengal update 2020.
Okay, great. Thank you so much. We'll just share it.
Immediately, please, sir. Already my first is gone.
Just take 20 to 30 seconds more. Okay. Another 10-20 seconds, sir. It's just sharing. It's just transmitting.
Sir,
it should have been done earlier, no? I had already informed.
Yeah, there's some communication gaps. Apologies.
Yeah. So you can share your screen now.
Yeah. Go ahead. Which slide do you want to see from the beginning, or you want to go from the second?
The first slide. You go
next slide. Next.
Okay, sorry.
Yeah, so this was the slide I was discussing. So to recapitulate, we have some traditional established risk factors like patients having a septal thickness more than 30 millimeter with abnormal exercise-induced blood pressure response, non-sustained VT, family history of sudden death in the first degree relative, and unexplained syncope as risk markers for sudden death in these individuals. Other subtle markers being detection of fibrosis or scar, outflow obstruction significant, and the role of genetics, including mutation in isolated myofilaments. Next slide. Yeah, so every hypertrophic cardiomyopathy patient should know, we should inform them regarding the prevalence. It is about 1:500 among the general population, and family needs screening because it is an autosomal dominant disease, and the overall prognosis is good, and only 1% of patients annually have an attrition due to sudden cardiac death, and medications are there to treat symptoms, not to prevent sudden cardiac death, and exercise, vigorous exercise, competitive sports are prescribed, but healthy lifestyle should be maintained. Next slide. Next slide. Yeah, thank you. So the historical changes in hypertrophic cardiomyopathy related mortality, as you know, the annualized mortality rates have decreased from the referral cohorts in the initial years of this century and to presently prior to the current therapies that we offer to our patients. And present hypertrophic cardiomyopathy cohorts have mortality figures just like the normal population if detected early. Next slide. So a point regarding the gender bias. No, the previous slide. The previous slide. Yeah, this is okay. This is okay. So a point regarding the gender bias that we should know is like women with hypertrophic cardiomyopathy have a worse survival compared to the males. And this was based on a study done by Geske et al. In European Heart Journal 2017, where they showed that US women who had hypertrophic cardiomyopathy fared worse compared to the US men. Next slide. Yeah, so risk stratification, as we try to mention, is imperfect for this particular disease. If we expect to tell us yes or no for any individual patient, we can speak of as a cohort, but for an individual patient, it is very difficult. Next slide.
Sir, it takes about 5 seconds. Sorry to interrupt you. It takes about 5 seconds if a third party is sharing the slide for the slides to move.
Sure.
Just informing you. Yeah.
Sure. So risk stratification should be based on a shared decision consultation, and the discussions should include features that identify the patient as having high risk of sudden cardiac death, the magnitude of that risk, the risk benefit of the treatment options that we are to offer to the patient, and it should allow the patient to express their level of risk tolerance or aversion, because patient's choice is very important and I think is the final choice. Next slide. So we have established hypertrophic cardiomyopathy risk SCD calculators based on variables like age, maximum LV wall thickness, left atrial size, maximum LVOT gradient, family history of sudden cardiac death, occurrence of non-sustained VT and unexplained syncope, on which we can actually calculate the risk percentages. And if it is less than 4%, ICD is generally not indicated. If it is between 4 to 6%, it may be considered. And if it is more than 6%, quite substantial risk, then ICD should be considered. And these are all 5-year estimated risks for sudden cardiac death in this particular population as derived from the ESC guidelines. Next slide. So in a flowchart fashion, we have, if the patient has a history, family history of a sudden cardiac death in the first degree relative, or a maximum LV wall thickness more than 30 millimeter, or recent unexplained syncope, then ICD is reasonable straight away. That is a class 2A indication. If not, then we have to look for non-sustained ventricular tachycardia on the Holter or abnormal blood pressure response on exercise. And if either of them is present, then we look for the sudden cardiac death risk modifiers that include young age, wall thickness approaching 30 millimeter, remote family history of sudden cardiac death, or LV outflow tract obstruction with no planned intervention, that is myectomy, delayed enhancement, septal ablation done previously, known specific hypertrophic cardiomyopathy mutations, and a syncope less than 5 years ago. And then again, ICD becomes reasonable. If neither of them are present, then ICD is not warranted. And if no other risk modifiers are present, only NSVT is present or an abnormal blood pressure response on exercise, then role of ICD is uncertain. Next slide. Yeah, thank you. So obstruction, as we know, is a very basic anatomical component of a subset of hypertrophic cardiomyopathy patient. And it gets worse if more vigorous contraction, a decrease in resistance, systemic resistance, and a decreased volume of the LV. And all of these occur with physical exertion. Next slide. Yeah, so no competitive athletics and no serious exercise has been the historical recommendation till date. Next slide. For drug therapy in hypertrophic cardiomyopathy, these are all used to provide symptom benefit to the patients, and successful therapies as were established were beta blockers from 1964, verapamil use from 1979, and disopyramide use from 1982. Other unsuccessful therapies were tried, including sodium channel blockers, metabolic modulators, aldosterone blockers, and ARBs, but with no outcome benefit. Next slide. Invasive therapy in hypertrophic cardiomyopathy, indications we all know, is to reduce if the patients have significant LVOT obstruction, and if exertional symptoms result in significant impairment in the quality of life, and symptoms persist despite appropriate medical therapy. Next slide. And by obstruction, we mean a peak gradient of more than 30 millimeter mercury at rest, and with symptoms, sufficient symptoms with a peak gradient more than 50 millimeter mercury itself signifies significant obstruction. Next slide. And we know the age-old therapy myectomy for severely symptomatic obstructive hypertrophic cardiomyopathy is safe and effective, not only in terms of symptom benefit, with an operative mortality only 0.8% in experienced volume centers, a gradient reduction from an average of 67 to 3 millimeter mercury, and a post-op improvement in NYHA class about 1 to 2 classes improvement in about 94% of patients. And the patients also had fewer arrhythmic deaths, as noted on ICD discharge rate in patients who had undergone myectomy, or to the right-hand side, as you can see, versus patients who didn't have myectomy. Attrition rate of 4.3% in those who did not, vis-a-vis to only 0.24% those who did annually. Thank you. Next slide.
Hello, Dr. Munna Das.
Yes.
Hello.
Yes.
I've spoken to, I would stick to your time actually.
Yes, yes, because initial,
okay, I understand it. Okay, I understand.
Next slide.
Okay.
Continue.
Next slide. Yeah, so ablation, as we know, is a fancy of our interventional cardiologists. There also we have achieved a gradient reduction of from 63 to average of 14 millimeter mercury, and NYHA class improvement from 2.8 average to 1.3, and complications have now improved drastically compared to previous data what we have initially encountered, and a mortality reduction and the mortality is now only operative 1 to 2% in this subset of patients. Next slide. So this is my last slide, and what I want to share is myectomy. The reintervention rate in myectomy is very low, around less than 2%, and the late SCD occurrence is very low. So this is an important point when we are counseling patients with obstructive HCM who need intervention to relieve their obstructive symptoms and the obstruction failed medical therapy. there myectomy obviously scores in terms of late SCD occurrence. Vis-a-vis in those who had ablation, the occurrence rate is higher compared to myectomy, and obviously the role of ablation itself is uncertain in this subset of patients. And gradient reduction is obviously more in case of myectomy, and ppm requirement is also less in case of myectomy. But obviously patient turnover rate and the number of duration of stay is less in ablation compared to myectomy. Next slide. So I end my talk here with this message that in hypertrophic cardiomyopathy, the risk stratification should be individualized and based on both the traditional risk markers as also the risk scoring that we follow, and counsel the patients, their family, regarding the non-pharmacologic measures, the pharmacologic measures that we need to offer to them to relieve their symptoms. And those who qualify for ICD, the options should be discussed to them, but the final say is from the patient. Thank you.
Thank you, Dr. Dash, for excellent elaboration of, though there were some technical hitches. Thank you very much. We will can take up questions at the end of the session. You please stay with us. Let me invite Dr. Basavendra Chaudhary to deal with the issues of peripartum cardiomyopathy. Is Dr. Basavendra Chaudhary available?
Yeah, am I audible?
Yeah, you are very much audible. Please share your screen and start your deliberation.
So I would start by thanking the CSI West Bengal branch, especially.
Your slides are not visible, doctor.
My slide. Is it visible now?
No. First push the share screen button. Use the share screen button.
Open the presentation and then share screen.
Yeah.
Oh, ওখানেই আছে।
Is it visible now?
Now your
Yeah, visible.
Okay.
Yeah. So come to full screen view and go on.
Okay. So thanks to CSI West Bengal and especially Dr. Shah for giving us young cardiologists this opportunity. My topic of discussion is peripartum cardiomyopathy. So it took 80 years to be recognized. Various terms have been given over the years like pregnancy-associated cardiomyopathy, Meadows syndrome, Zaria syndrome, myocardiosis. Finally, since 2010, after the ESC has suggested a working definition for this entity, which includes the following points: development of heart failure towards the end of the pregnancy or within 5 months following delivery. So some definitions suggest that within 6 months following delivery also we should consider cardiomyopathy. Absence of another identifiable cause for the heart failure, which is very important. LV systolic dysfunction with LVEF less than 45%, in which the LV may or may not be dilated, and no recognized heart disease before the last month of pregnancy. So these 4 points we should keep in mind. Among these, the absence of another identifiable cause for the heart failure is very important because certain conditions are there which should not be missed and which provide other modes of treatment and specific treatment modalities which usually improve the patient condition significantly, like pre-existing dilated cardiomyopathy, pre-existing other forms of cardiomyopathy like HCM, pre-existing valvular heart disease, especially stenotic lesions, congenital heart disease with the left to right shunts, which the conditions exacerbate during the later half of pregnancy due to volume overload, hypertensive heart disease including preeclampsia and eclampsia, acute myocarditis, which is often underdiagnosed in a country like ours, acute pulmonary embolism, which is not that uncommon, And coronary related conditions like coronary spasm, dissection, which are relatively less common. Thyrotoxicosis, even severe anemia can present with heart failure, and maternal sepsis. So keeping in mind these things, I would like to share a case scenario. Just a few weeks earlier, a 30-year-old female, day 15 purperium, came to us with progressive shortness of breath, palpitation for last 10 days, tachypnea, tachycardia, and orthopnea with a low BP. So she was referred as a case of postpartum cardiomyopathy. However, when we did the ECG, we clearly saw that it was an adenovirus tachycardia, PSVT, most probably AVRT. After adenosine IV bolus, it reverted to sinus rhythm, which showed right accessory pathway, WPW syndrome with the right accessory posteroseptal pathway. These conditions should not be missed, and we should not just label every heart failure in this sort of conditions as peripartum cardiomyopathy. Looking at the worldwide epidemiology, it is more common in African countries, especially in Nigeria, in a district Zaria, where dry salt lake is eaten, dry lake salt is eaten in the later half of pregnancy after delivery. Also in Haiti, whereas in Japan, the incidence is quite, the prevalence is very less. In India, it is around 1 in 4,000 pregnancies. So increased maternal age, preeclampsia, maternal CV risk factors like diabetes, hypertension, history of previous pregnancy loss, multiple gestations. These are the factors which are associated with increased incidence of peripartum cardiomyopathy. So if you look at the etiopathogenesis, it is the exact mechanism is unknown. Multifactorial mechanisms are there. The final common pathway comprises increased oxidative stress with cleavage of prolactin to a 16 kilodental fragment, which inhibits angiogenesis and impaired VEGF signaling. Apart from this pathophysiological mechanism, inflammatory cytokines, myocarditis, abnormal immune response to fetal cells, genetic predisposition, all these, the roles are not quite certain. So what are the risk factors which predisposes a mother of developing this condition? Age more than 30 years, African descent, pregnancy with multiple fetus, history of preeclampsia, eclampsia or postpartum hypertension or pulmonary embolism, cocaine abuse, more than 4 weeks oral tocolytics due to preterm labor. So relationship with diabetes and some mineral deficiency, there are conflicting data. So clinical manifestation, the timing is very rare before 36 weeks. Usually it presents at around 36 weeks. Signs and symptoms of heart failure, we know left and right sided heart failure, both can be the presentation. Initial diagnosis may be delayed because they are often ignored as non-specific symptoms of a normal pregnancy. And LV thrombus also can be found in as many as 16% of patients, especially if the LVF is low. So for diagnosis, we can follow this proposed approach by ESC. If a PPCM is suspected, late pregnancy, postpartum with heart failure sign symptoms, first we should do the routine investigations to rule out the reversible causes like anemia, thyroid disorders, cardiac troponin, NT-proBNP for prognostication as well as diagnosis. And echocardiography is very vital. If the cardiac disease, if the disease is diagnosed with suboptimal imaging, that is, there is still confusion, then we should go for cardiac MRI. Usually echocardiography is enough to clinch the diagnosis. And obviously the other causes, the reversible causes and DDs should be ruled out. Now, if a patient comes with acute decompensated heart failure, so oxygen supplementation and assisted ventilation as per need, saturation should be kept at around 95 or above. Optimization of preload with strict intake output monitoring, hemodynamic support for low normal BP, we can use inotropes like dobutamine or milnacol. For low BPs, we should go for vasopressors. Symptomatic relief with diuretics to achieve euvolemia. When possible, when patient has been stabilized, chronic therapy should be instituted. What comprises the chronic therapy part? Judicious use of diuretics, beta blockers are the mainstay. Digoxin can be used if required in HFrEF, that is ejection fraction less than 35%. AC, ARB are contraindicated during pregnancy, so hydralazine with or without nitrate can act as a suitable alternative. And recent data suggests there is some role of bromocriptine. So this chart includes all the drugs which can be used, and it clearly shows that SE inhibitors are contraindicated during pregnancies. ARBs are contraindicated during pregnancy as well as during lactation. MRAs, same as ARBs, contraindicated during pregnancy as well as lactation. Beta blockers can be used keeping in mind the risk of bradycardia of the fetus or the mother also, but it is not that common if we gradually up-titrate the dose. Vasodilators like hydrogen and nitroglycerin is definitely an option in refractory cases. Hypotension should be avoided. Diuretics, judicial use should be kept in mind to prevent uteroplacental insufficiency. Inotropes, digoxin in HFrEF, dobutamine, milrinone in acute cases, and bromocriptine, which is a prolactin inhibitor, can be used. However, we should talk on bromocriptine later in the later slides. So arrhythmia management, as many as 18.7% patients have been documented to have arrhythmias of various kinds, supraventricular as well as ventricular. 2% of patients can have cardiac arrest. So these things should not be ignored. Atrial fibrillation is also quite common, but this should be managed in most of the patients medically, because 20 to 70% of PPCM usually recovers by 3 to 12 months. So the decision regarding ICD implantation and also for CRT implantation should be deferred. And a variable defibrillator is also an option, but it is often not feasible in our setup. Anticoagulation issues, the definite indication for anticoagulation in PPCM and sinus rhythm is intracardiac thrombus and evidence of systemic embolism. If the patient is having atrial fibrillation or flutter, however, by CHA2DS2-VASc coding, we can go for suitable anticoagulation. And also, if the patient is given bromocriptine, since bromocriptine has increased incidence of MI and stroke, anticoagulation should be strongly considered in those patients. Considering advanced management, mechanical circulatory support and other temporary devices, including ECMO, should be used only in refractory cases. No role of immunosuppression, IVIG, has been documented yet. Apheresis and treatment with miRNA are upcoming topics. Role of bromocriptine, it reduces prolactin production by dopamine agonist action. Though the role is controversial, however, small studies have shown symptomatic benefit and also recovery of LV function. The dose is 2.5 twice daily for 2 weeks, followed by 2.5 once daily for 6 weeks. So a weak recommendation has been given by the recent ESC updates. Delivery, if in stable patients, vaginal delivery with epidural anesthesia is preferred. In unstable patients, planned CS with central neuraxial anesthesia is preferred. No definite role of early delivery is there. Breastfeeding, in patients having active heart failure, breastfeeding should be prevented because metabolic demand will be increased. Also, prolactin level will be increased. But if the patient is stable and can tolerate, breastfeeding should be started. If breastfeeding is started, obviously we should avoid MRAs and ARVs. Contraception is very vital in this regard because subsequent pregnancies, a patient who has had PPCM is bound to develop PPCM in the subsequent pregnancies as well, especially if the LV dysfunction is persistent. So contraception using intrauterine devices should be encouraged. Sterilization may be used for the patient or the partner. Estrogen containing contraceptives should be avoided because they have increased incidence of thromboembolism. Prognosis, recovery of LV function usually takes 6 months, but may even take 5 years. Mortality is not so low, 3 to 9.6 is quite low. Complete recovery in 50% of patients we know, and persistent symptoms and complications may be present in 25% each. Recovered patients may have subtle systolic diastolic dysfunction, limiting their maximum exercise capacity. Persistent LVF more than 50%, if it is achieved, then after 6 months of that, we can gradually win the heart failure therapies, and echocardiography should be done 6 monthly and in more critical patients more often. Adverse prognostic factor are increased NYHA classes at presentation, LVF less than 25%, black race, multiparity, age above 30 years. And what are the predictors of persistent LV dysfunction? LVEF less than 30%, fractional shortening less than 20, LVIDD more than 60, reduced.
Chaudhary, please conclude.
So coming to my concluding slide, I would like to say that it is quite common and this condition should not be ignored. with a high incidence of mortality up to 10% and various complications including arrhythmias and sudden death. However, the reversible causes and causes which mimic PPCM, which have specific treatment modalities, should not be missed. Thank you.
Thank you, Dr. Choudhury, for your excellent deliberation on the topic. Our next topic is ARVT diagnosis and management, to be delivered by Dr. Prithviraj Bhattacharjee. And moderator is Dr. Sanjeev Patra. Dr. Prithviraj Bhattacharjee available?
Yes, I'm available.
Okay. Please share your screen, please, and have your slides on and start delivering. Thank you.
So, good afternoon, respected chairpersons and my dear colleagues. My talk is on ARVD, diagnosis and management. So, ARVD, you know, is a disease of young athletes and young patients. Not many years ago, in 2016, a promising English batsman, international batsman, had to retire, was forced to retire early in his career at 26 years because development of diagnosis of this condition. So this disease was diagnosed 40 years ago. In 1977 by Fontaine et al., they described the finding in a series of patients undergoing surgical treatment for stable recurrent ventricular tachycardia, and there was a remarkable dysplastic appearance of RV unrelated to ischemic heart disease. So this is another landmark paper published from Veneto region of northeastern Italy by Thien et al. They described the autopsy finding in 60 patients less than 35 years of age who died of sudden cardiac death. And they found that in 12 patients, that is almost 20% of patients, there is a morphological change in the RV free wall where the RV myocardium was replaced by lipomatous and fibrolipomatous tissue. So after this finding, the attention was drawn to this disease, and it was the concept was this disease is probably not that much uncommon. So if we look at the anatomoclinical definition of this condition by Corodo et al., it's a genetically determined autosomal dominant inheritance pattern of right heart muscle disease, which predominantly affects the RV, and fibrofatty replacement of both right and left ventricular myocardium may be present, and clinical presentation is usually ventricular tachycardia and arrhythmic sudden death. This disease is usually caused by mutation in the desmosomal proteins, and characterization of this disease was as a cell adhesion disorder was first suggested in the molecular genetic study involving patients of Naxos disease, which is a cardiocutaneous syndrome characterized by ARVC, palmoplantar keratosis, and woolly hair. And subsequently, mutations in genes encoding other desmosomal proteins were known, which caused the more common autosomal dominant variety of ARVC. This panel shows the normal heart. In the panel A, there is a full-length histological specimen of normal right ventricular myocardium with the azantrichrome dye, which takes a pink stain. But on the panel B, you can see with the same dye, there is a blue stain which represents the fibrous tissue, and white color represents the fat. And the panel C represents the schematic diagram of a gap junction of cardiac myocytes, where you can see the proteins of cell adhesion proteins. There are three components of desmosomes. One is desmoplakin, which binds to the intermediary filaments. There are transmembrane proteins like desmocolin 2 and desmoglein 2, and there are also the linker proteins, the plakophilin and plakoglobin. When there are mutation in the genes encoding these proteins, there are gradual separation of the cardiac myocytes, and this gradual separation is also promoted by physical activity, stress, because during physical activity, there is increase in the RV pressure, and that pressure also promotes the development of this phenotypic pattern. And there is another pathology, another pathologic pathway, because this desmoglein, these genes are also these proteins are also important in gene signaling. You can see there is a component beta-catenin pathway. Beta-catenin pathway of the gene signaling helps in myogenesis and reduces adipofibrogenesis. But when there is a mutation in the desmoglobin genes, there is translocation of the plakoglobin part from the sarcolemma to the nucleus of the cardiomyocytes, and it binds with the T cell factor, lymphocyte enhancing factor, which is the gene transcriptor factor, and it promotes the fibrogenesis and lipogenesis, and alternately reduces the myocyte generation. That is why there is gradual substitution of the myocardium by fibrofatty tissue. So clinical presentation, it is found in 1 in 5,000 population, and almost 50% patients have a family history. That is very important. And usually the disease is asymptomatic up to second decade of life, and predominantly male patients are affected, and they are more prone to have cardiac death, and common presenting symptom being palpitation and effort-induced syncope. If you look at the ECG feature, there are both depolarization and repolarization abnormality. Depolarization abnormality is a prominent U-wave inversion in anterior chest leads from P1 to V3 or beyond. There is repolarization abnormality in the form of terminal activation delay in the QRS complex, which is more than 55 milliseconds. There is also presence of epsilon waves. There is also late potentials of signal average ECG. And if we look at the slide of VT, the VT is usually of LBBB morphology with superior axis. The echocardiographic features. Echocardiography definitely is the initial diagnostic approach of the patient, where there are typical features are like this enlarged RVOT. There is also increased trabeculation in the RVOT and prominent moderator band present. There are definite criteria for the size measurement of RVOT. In the international task force, which we'll discuss, you can see the prominent moderator band, trabeculae, and the hollowed out pattern of the RV myocardium. And there is always RV dysfunction in the form of akinesia, regional dyskinesia, and there is severe tricuspid regurgitation in most of the cases, and dilatation of inferior vena cava. CMR may be a better technique than echocardiography, specifically because it combines the evaluation of both structural and functional ventricular abnormalities, and there is also the advantage of non-invasive tissue characterization. The typical criteria that can be demonstrated are presence of high signal intensity areas indicating the substitution of myocardium by fat and fibrofatty replacement, which leads to diffuse thinning of the right ventricular myocardium. And there is also regional contraction abnormalities, which can be better picked up by CMR pictures. These are the findings you normally look for in the cardiac MR. There is outpouching in the basal inferior wall of the right ventricle, also some aneurysm formation in the RVOT region. There is myocardial thinning and diffuse fibrofatty infiltration. There is a prominent trabeculae, and some in the later stage, the apical part of the RV is also informed in the form of aneurysm or bulging. So ARVC is a clinical phenotype where there are multiple features but no single diagnostic modality. We have to take into account multiple factors. So diagnosis was first proposed in 1994 by International Task Force, and they took the help of different modalities like structural and functional abnormalities, ECG abnormalities, and family history, and they tried to quantify the major criteria and minor criteria. At least 2 major criteria, or 1 major, 2 minor, or 4 minor criteria are necessary for definitive diagnosis of this condition. Subsequently, the problems were detected with this original criteria that many parameters are subjective and they are not evidence-based. And because at the time of the publication of the original criteria, the diagnosis or experience of this condition was dominated by symptomatic cases, index cases, and sudden cardiac death victims. And therefore, although the criteria was very specific, but it lacks the sensitivity for early cases and familial disease cases. So the revised International Task Force criteria was published in 2010, and it was published to provide quantitative criteria for RV dilatation and dysfunction to enhance the diagnostic specificity of morphofunctional RV abnormalities and to differentiate the diagnostic specificity of RV arrhythmia according to the morphology or site of origin, and also to recognize the specificity of right precordial Q-wave inversion and QRS prolongation, and also to add molecular genetical criteria for increasing the diagnostic sensitivity of right ventricular dysplasia. So these are the criteria in detail. I am not going to read it out because you'll find it in a textbook or in the internet. So the important feature is the tissue aspect were included, quantified here with the help of endomyocardial biopsy, which is not nowadays a preferred modality. Depolarization abnormality, Q-wave inversion beyond the lead V3 has been put into a major criteria. And another important thing is depolarization abnormality. Another important thing is the inclusion of family history and inclusion of identification of pathogenic mutation classified as associated or probably associated with ARVC. So if there is a genetic mutation, it is suggestive of ARVC, or proven to be associated with ARVC, it falls into a major criteria. So there has been a need since last 10 years, the diagnostic modalities has improved, and there has been a need to improve on this diagnostic criteria of ARVC, as published in this paper recently in 2020 by Coroto et al. In ESC, and they have suggested that major limitations of 2010 criteria was genetic test is an integral part, because if there is one diagnosis based on the genetic criteria, major criteria, you may have to ignore the morphological changes of the ventricles. A diagnosis can be made only on the basis of molecular findings, because this subsequently papers have been published showing that in normal control patients also 16% of patients may have desmosomal gene mutations. So there is a high background noise in ARVC. Only genetic finding may not be enough to stamp a diagnosis of ARVC. Diagnosis is definitely should be done on the basis of phenotypic features, and genotype is definitely useful, specifically for diagnosis in relatives and for prognosis. The second limitation was the diagnosis, as we have discussed, it is may be fulfilled in the absence of structural and ventricular abnormalities. And we can see with the improvement of cardiac MR, contrast entrance cardiac MR, we can definitely pick up the RV morphological changes and functional changes, the dilatation, the echinacea, the dyskinesia, which can be nicely demonstrated, and this should not be ignored. The morphological change must be there to stamp a patient as ARVC. Tissue characterization images findings by CMR were excluded in 2010 criteria. There is a suggestion that although endocardial biopsy was suggested in 2010 criteria, but it is now mostly out of favor. Why we'll discuss. But in CMR can help us. Yes, I'll try to finish quickly. Tissue characterization is helpful by cardiac MR also. So another point was there was lack of specific diagnostic criteria for left dominant disease. Nowadays, we have seen that advogenic right ventricular cardiomyopathy has specifically three phenotypes. One is RV phenotype, where there is predominantly RV involvement, and biventricular phenotype is there, where both RV and LV involvement is there, and left prominent phenotype is also there when early and prominent LV manifestations are there. So this is a study showing that isolated early left ventricular involvement can give rise to sudden cardiac death. So with that concept, the idea of triangle of dysplasia has been shifted to quadrangle of dysplasia. And the diagnosis of ARVC, from the term of ARVC, spectrum of ARVC, we are more moving towards the term of arrhythmogenic cardiomyopathy. So there is also a proposal of etiologic classification based on the desmosomal gene mutations, which constitute about 40 to 50% of patients, and non-desmosomal mutations, which constitute about 20 to 30% of patients. Role of endomyocardial biopsy, the sensitivity may be limited due to patchy distribution of the disease, although the right ventricular free wall is affected, but biopsy is usually taken from the septum, and pathological changes are usually more conspicuous in the epicardium of RV free wall and tends to pair the endocardium and IV septum.
Your time is already over. Please conclude. Huh?
I'll take 1 minute more, 1 or 2 minutes more. Please allow me. So for management, important variables as stratification is important. Most important is the history of ventricular tachycardia or sudden cardiac death and cardiac syncope. RV and LV biventricular systolic dysfunction is also an important criteria. And most important thing is lifestyle changes. Specifically, the patient's current guideline recommends that not only affected individuals, but also desmosomal gene mutation carriers should not participate in competitive or endurance activity. And beta blockers should be prescribed in all patients, regardless of the symptoms or arrhythmic manifestation, but they should be prescribed to only phenotype positive patients, not only genotype positive patients. Antiarrhythmic drug, not much role because they do not prevent sudden cardiac death. They have some role in adjunct therapy with catheter ablation or ICD therapy to prevent the recurrence of VT. Catheter ablation, yes, there is chance of high recurrence due to progressive nature of the disease, and according to 2015 treatment consensus, patients with ventricular tachycardia or frequent ICD intervention on maximal pharmacological therapy should be referred for catheter ablation. When catheter ablation is done, it is better to go for both endocardial and epicardial approach and with the help of genetic mapping, because it increases the success rate. ICD is definitely the only therapy to interrupt the potentially life-threatening VT, and recent meta-analysis reported a data of 600 patients, and in the both primary and secondary prevention, there was annual risk was 0.9%. And this is the chart showing how the ICD treatment of ICD implantation should be chosen. The highest risk patients are mostly benefited. So heart failure therapy and heart transplant, these are the last options. For heart failure, ACE inhibitor, ARB, and diuretics should be prescribed. Long-term oral antithrombotic therapy should be prescribed in atrial fibrillation patients with thromboembolic events, and heart transplantation is the final treatment option in case of debilitating heart failure. To conclude, ARVC is associated with significantly high risk of sudden cardiac death, and its diagnosis is multiparametric. CMR will be considered as a standard of reference for evaluation of RP morphology. And ARVC is known to predominantly affect the RV, but early and predominant LP involvement is now increasingly recognized, and ICD therapy for high-risk patients is indicated early in the disease when ventricular function is still relatively well preserved. Thank you so much.
Thank you, Dr. Bhattacharjee, for nice elaboration of the topic. Though a little bit more time is required. Now we are quickly shifting to, thank you, Dr. Bhattacharjee.
Thank you.
We are shifting to granulomatous topic of granulomatous myocarditis and its sequelae, to be handled by Dr. Rakesh Sarkar with moderation by Dr. P.C. Bagchi. Dr. Rakesh Sarkar, please. Dr. Rakesh, yes. Dr. Sarkar, please go ahead with your presentation. Dr. Sarkar?
Am I audible?
Yes.
Yeah, very much so. Please.
So, good afternoon, respected chairperson, moderators, and my dear colleagues. At the outset, I would like to thank my the organizing committee of CSI West Bengal, especially Dr. Jayanta Shah sir, for giving me the opportunity to present the topic. So granulomatous myocarditis is an increasingly recognized entity, which is a very fascinating area to talk on. So I will just take you through one case. Yeah, I'll take you through one case. My slides, yeah. So this is a 55-year-old diabetic and hypertensive gentleman who came with a complaint of VT, and he is suffering for last 4 years. In the year 2015, he first came for the first occurrence of the VT, which he was evaluated by angiography, followed by PTCA plus stenting to LAD, with the finding of critical blockage in the LAD. Following 2 months, he was underwent ICD implantation, dual chamber ICD, although at that point of time his background ejection fraction was 54%. In 2007, again he had a stormy VT course, which he had to get resolved by getting admission. And finally in 2019, when he came to us, he presented with hypotension and anuria because of multiple shocks delivered from the ICD. So in the background, am I audible?
Yeah, go ahead, please.
Yeah, so in the background, the ECG is showing the atrial pacing ventricular sensing rhythm. And when he presented with the VT morphology was showing the white QRS with inferior axis and little slurred onset of the QRS, and predominantly Q in V1 and V2, which is suggestive of epicardial VT. So as I said in the investigation, he already came up with and LV global hypokinesia and RV hypokinesia with ejection fraction of 25%. We plan for PET CT scan for that patient, and the PET CT shows avid intake of FTG in RA, RV and LV both, along with the mediastinal lymph node and supraclavicular lymph node uptake. Serum ACE was quite high, 55 nanogram per milliliter, and EBUS was not showing any significant finding in the mediastinal lymph node biopsy. as I said, the PET scan was showing the avid intake in the LV and RV, especially in the basal septum. We went ahead with the biopsy of the supraclavicular lymph node, which shows non-caseating granuloma, and TB interferon was positive. So with that, all the constellation of the finding and workup, what we are dealing with, we are probably able to answer at the end of the talk. So what we are going to discuss in next couple of minutes, that will be revolved around these subheadings: nomenclature, pathophysiology, types, clinical presentation, evaluation and workup, and finally management of the granulomatous myocarditis. So historically, myocarditis was first described in 1837, but the distinction between histologic subtypes was delineated late till 19th century. And in 1929, it was first coined as idiopathic granulomatous myocarditis with the view of histologic finding of giant cell, which was located within the non-caseating granuloma, and now it is also called cardiac sarcoidosis. So as the name itself suggests, the histological finding granulomatous myocarditis, so we need to have a bit of concept, clear concept regarding what is granulomatous myocarditis. So granulomatous disease is nothing but the occurrence of the granuloma, which is nothing but the conglomeration of the multinucleated giant cell along with the epithelial cells and so many other inflammatory cells like plasma cells or mast cell or other lymphocytes found in presence or in absence of the caseation or necrosis. So although we interchangeably use the term granulomatous myocarditis and sarcoidosis very commonly, but these are not actually synonymous. And particularly in this part of our world or our country, tuberculosis is nevertheless a less common entity which can be found as a granulomatous myocarditis. Apart from tuberculosis, histoplasmosis like rheumatic heart disease, vaginal granulomatosis, and some foreign body reaction to oxalate, beryllium, silicosis also can give rise to granulomatous myocarditis, but it is definitely of less importance. In clinical presentation, there are myriad of presentation in the form of systolic dysfunction, various arrhythmia, particularly ventricular arrhythmia in the form of NSVT or VT. Supraventricular is less common, but still can happen either in the form of atrial fibrillation or flutter. Conduction system disease as Mobis type 2 block or advanced AV block or fascicular block also can be seen. Pericardial involvement can coexist in the form of pericardial effusion or constrictive pericarditis with myocarditis. And although less common, sudden cardiac death and acute coronary syndrome is also reported in view of granulomatous myocarditis. So in clinical, electrocardiography characteristics, I will again give you some illustration of a case. It's a 26-year-old male presented with syncope, resuscitated with CPR and temporary pacing. His ejection fraction was found 25% and angio was done to be showing normal coronary angiography. So when he presented, there was a high-grade AV block and in the background there was LVB morphology. But if you see the LVB, it's not actually typical LVB, but rather it was so broad, QRS, so it actually denotes some myocardial disease. And from ECG itself, you can actually get the idea that it is not only a kind of simple AV block which we are dealing with, rather there is some involvement of the myocardium. The same patient which I showed, he presented with not only high-grade AV block, he presented with the very slow VT. It's around 110 beats per minute going on. And if you actually look at the ECG, there is RVV morphology with left axis deviation, which is nothing but suggesting some left-sided origin VT going on in the same patient. So we had to offer for CRT-D for that patient after the evaluation of PET scan, which again revealed the avid uptake surrogate of inflammatory cardiomyopathy. Again, there might be various presentation of VT in the given patient of inflammatory cardiomyopathy, which can be associated with granulomatous myocarditis. The upper panel is showing the structurally normal heart of 32-year female, which is who presents with this kind of inferior axis kind of RVOT VT, we often tend to address this kind of VT as idiopathic VT. But if we actually look at the ECG very carefully, we can see the subtle changes in the QRS morphology, which is addressed as pleomorphic VT. And it's not actually very common in structurally normal heart. Although echocardiographically we can see there is nothing as such, but often the MRI or PET scan can reveal some abnormality, and this is often associated with this kind of granulomatous myocarditis or inflammatory milieu. So in the baseline ECG also, if you evaluate, there might be some suggestion of some inflammatory milieu which is going on in the form of some notching or some kind of fragmented QRS. So this is the paper brought in Indian Heart Journal in 2015 by Dr. Narasimhan sir, who was my mentor also. So he published 40 cases, which actually was established case of sarcoid. And he shown there that there was a very good representation of the fragmented QRS in the baseline ECG, who actually presented initially as idiopathic VT. So how to go ahead for the management and diagnostic, evaluation for those patients? Definitely serum AC level, ESR, CRP, followed by MANTU, just to rule out whether this is clear-cut sarcoid or some tuberculosis activity is going on. PFT again can give some suggestion just to tell that whether there is some obstructive or restrictive airway disease, which is often associated with sarcoid, particularly pulmonary sarcoid. And TB quantiferon often can tell you the latent tuberculous infection. And last but not the least, ANCA, which actually may be positive in case of granulomatous, vaginal granulomatosis. So imaging remains the cornerstone of the whole evaluation, because as I will come to the part that the yield of the... Okay, so although the imaging is the cornerstone, the echocardiography is the basic tool which can often tell you the hypokinesia and the thinning in the basal part. And in the CMR, you can see the edema and inflammation, and quantify the chamber size and function, and quantification of the scar in the late gadolinium enhancement also is a very surrogate for the representation of the granulomatous myocarditis. In FDG PET also you can see the uptake, as I discussed earlier also, and in the extracardiac structure also you can get the intense PET uptake. So how to go ahead with the cardiac MRI? If it is showing the positive result, we can go for the consideration of the ICD. If there is no gadolinium enhancement, we may consider for FDG PET, which can give us the additional information. Endomyocardial biopsy, as I told, it may be a very standard approach, but it is of very low sensitivity. So expert consensus recommendation of the cardiac sarcoid remains, I'm not going to read it loud, so because it is available in any of the textbook as per the HRS consensus 2014. So for the interest of the time, I just mentioned some features of the granulomatous myocarditis, which can be a great masquerader of the Brugada syndrome, ARVC, HCM, amyloidosis, and pacing-induced cardiomyopathy. Sometimes these are the conditions which can be actually considered and give us a second thought before we address it as so. So to evaluate these patients of extracardiac sarcoid also, we need to give the insight whether they involve the cardiac structure or not, in the form of looking at the ECG, echo, and if required, we can go for CMR and FDG PET. So who are the candidates who need the treatment in terms of the immunosuppression, who are actually showing the advanced degree of AV block, frequent ventricular ectopic, or sustained ventricular arrhythmia, or LVTs? Those are the candidates for the immunosuppression treatment. And the algorithm of the treatment is remaining the prednisolone or the steroid, which is the mainstay of the treatment, it has to be given as 0.5 mg per kg per day for 2 to 3 months. Again, to evaluate the PET scan after 3 months. If there is some persistence, we can consider for the second alternative of steroid, or otherwise we can continue it for at least 9 months. And again, we can actually look at the PET scan whether the disease is relapsing or not, and based on the clinical expertise, we can take the clinical decision afterwards. So these are the main concern which has to be taken in addition to immunomodulation drugs, that is device implantation. So one important thing just to mention here, that the candidates who are requiring the pacing support in view of this sarcoid or any inflammatory cardiomyopathy or granulomatous myocarditis actually requires ICD implantation. Yeah, just 1 minute. So this comes because it has been seen that, yeah. So just to sum up, the patients who are actually having blockage in view of sarcoid and who are presenting with VT, those are having little different prognosis, and transplant consideration for sarcoid and non-sarcoid are also showing some different prognostic trend. So the patient who are actually non-sarcoid are actually showing better result or outcome. So in conclusion, clinicians should consider sarcoid or any granulomatous cardiomyopathy in patients who have acute cardiomyopathy and progressive clinical course despite usual care. And because of the risk and cost of the endomyocardial biopsy, alternative diagnostic tool as MRI or PETs to be considered. And if diagnosis is confirmed by biopsy, it is a gold standard, and tailored immunosuppression therapy has to be given in addition to device therapy or the catheter ablation therapy. Thank you.
Thank you very much, Dr. Sarkar, for excellent elaboration on the topic. As I have been informed from organizers that next speaker has just sent the presentation, recorded presentation to be you will not personally present the presentation. So I would request the team to upload his presentation, Dr. Bedivelu Ramalingam's presentation.
Technical team, please.
Yes, sir. It's happening. It will happen now.
Dipesh Agarwal is here.
Dr. Dipesh Agarwal.
Sir, good afternoon. Very much here.
Stay with us, and we'll have your inputs after the talk. So, next team, please continue with the presentation.
Yes, uploading this video in a minute.
Good afternoon to one and all. I thank Calcutta CSA Update chapter for giving me this nice opportunity to speak on tachycardiomyopathy. So I start with the case vignettes. 42-year-old gentleman presented with classical heart failure symptoms, and a clinical examination was also suggestive of same with elevated JVP, bilateral bile, pedal edema, which is showing basal RALs. And his heart rate was continuously varying between 100, sometimes it was showing 150 per minute. So this is the ECG. I think this is a very straightforward ECG showing very classical. You can see the flutter waves. It's not a sinus rhythm ECG. You can see these are undulated sawtooth waves, very classical flutter waves. You classically look into it. And so whenever a patient presents with heart failure symptoms and ECG shows, always one thing we should be very careful. We should the tachycardiomyopathy or tachycardia-mediated cardiomyopathy should come into our mind. So though tachycardia-mediated cardiomyopathy is a diagnosis of exclusion, there should be a high index of suspicion so that we will not miss this entity. And once we are going to offer a therapeutic procedure like either a DC cardioversion or a radiofrequency ablation, once we are going to terminate this arrhythmia, then the patient's LV function is going to improve. So this patient had the echo showed a mildly dilated left ventricle and the left atrium, and his ejection fraction was around 35%. So he underwent, diagnosis of tachycardiomyopathy secondary to atrial flutter was made. So he underwent radiofrequency ablation of atrial flutter. Here we can see the left side of the graph shows atrial flutter. Upon successful radiofrequency ablation, these are the sinus waves. So this is the classical cavo-tricuspid ablation, which means that from inferior vena cava to tricuspid annulus, the line is drawn from tricuspid annulus to inferior vena cava by predominantly using the radiofrequency ablation. Sometimes it can be done with cryoablation also. So we can see here. So this echo. The right side of the echo is a normal LV function, that is post RFA. You can see the sinus rhythm. Whereas if you see here, this is the pre-ablation showing a moderate LV dysfunction with underlying atrial flutter going on. So this is a pre and post ablation. These are the other common causes of tachycardiomyopathy. So in the left side of the panel, if you see, the RR interval is irregular, but if you see very carefully, there are some discrete P waves which are not sinus in nature. So very classical. So this is atrial tachycardia, which is ectopic atrial tachycardia, mimicking as atrial. Undergoes a curative therapy, either ablation or pharmacological cardioversion or DC cardioversion. This patient is going to improve, his LV function is going to improve. And what is this picture is showing? This picture is again showing one of the commonest arrhythmias we encounter in adults, that is atrial fibrillation. Atrial fibrillation is also one of the common causes for tachycardiomyopathy. So these are the things I will touch on. So due to lack of time, I will not go into much of the details. So first, it was described by Gossage in 1913. So subsequently, the other scientists and other inventors have followed, and there have been experimental models for tachycardiomyopathy. So again, the earliest described reports were frequently with atrial fibrillation, atrial flutter, and with ectopic atrial tachycardia, especially in children. So in children, it is ectopic atrial tachycardia, whereas in adults, it is atrial fibrillation. These are the very common causes of tachycardiomyopathy. I will also touch upon other types also. So in tachycardiomyopathy, usually the LV dysfunction is the most common presentation, but there is also an entity called atrial cardiomyopathy, that is tachycardia-mediated atrial cardiomyopathy. So in which here, again, there has been some confusion in terms like arrhythmia-induced cardiomyopathy and arrhythmia-mediated cardiomyopathy, but they all form into a single basket of category. So the basic thing is, it's the tachycardia that is persistent or recurrent, incessant, that is going to result in LV dysfunction and producing heart failure symptoms. So what is the definition? The definition is that the patient is going to have a rate of more than 150% for his age predicted maximum heart rate, and if this tachycardia is going to persistent for more than 24 hours duration, then they are going to be having high risk for tachycardiomyopathy. So pure type is a type in which there is underlying LV dysfunction is not there. That is, tachycardia alone purely produces LV dysfunction. It's completely a reversible type. The impure type, the patient already has some form of structural heart disease upon which superimposes the tachycardia-mediated LV dysfunction. Here, it's going to be an incomplete recovery only. So the incidence, it's going to vary depending upon the type of arrhythmia. Like in atrial fibrillation, it can vary from 10% to 50%. So it all depends upon the burden of arrhythmia, the duration of arrhythmia, and how incessant it is going to be. So in pediatric population, again, ectopic tachycardia is the most common thing, and it has been suggested that 1/3 of patients with ectopic tachycardia can have tachycardiomyopathy. And if you take PVC cardiomyopathy, in which when the PVC burden goes above 10%, then they are at very high risk for tachycardiomyopathy. So these are the common arrhythmias, like in supraventricular tachycardias, atrial tachycardia, PJRT or Kummer's typical type of accessory pathway mediated tachycardia, in which the pathway has got decremental property. So because of decremental property, that it is going to be insistent and persistent, so it's going to result in tachycardia. Whereas the other SVTs like a typical AVNRT and a typical AVRT, they are unlikely to cause tachycardiomyopathy because they are faster tachycardias and they are rapidly conducting tachycardia. So they come and they go off. Their onset is abrupt and their offset is also going to be abrupt. They are not going to be persistent. So unlike atrial tachycardia and PJRT, which are going to be persistent, so any persistent tachycardia which is relatively slower, like from any rate ranging from 100 to 150, they are the most culprits one that is going to result in tachycardiomyopathy. Like in ventricular frequent PVCs or RVOT VTs or fascicular VTs, they are also high culprits which are going to result in tachycardiomyopathy. The unlikely or uncommon arrhythmias, but which can result in tachycardiomyopathy are atrial flutter, atypical AVNRT, and atypical AVRTs like PJRT and junctional ectopic tachycardia. Sometimes, very rarely, intra-atrial reentrant tachycardias and inappropriate sinus tachycardia can also result in tachycardiomyopathy. Always when this topic comes, it is always a chicken or egg dilemma, which has come first, but Richard Wu has very clearly shown that in arrhythmia-induced cardiomyopathy, it is the arrhythmia first that is going to result in cardiomyopathy. Some of the patients with the dilated cardiomyopathy or extreme forms of end-stage heart disease can also have other form of arrhythmias like atrial fibrillation, flutter, sinus tachycardia. So it becomes very difficult to just delineate which is the first mechanism that has come. So these are the various pathophysiological changes, like initially the atrium and the ventricle, they are going to undergo dilatation, the contractility is going to reduce, the end diastolic volume and the end diastolic pressures are going to increase, and there is going to be annular dilatation mediated mitral regurgitation and tricuspid regurgitation, and also diastolic distension also undergoes. These are the various molecular, neurohormonal, pathophysiological changes which ultimately results in macroscopic changes, which are dilatation of cardiac chambers. The main pathophysiological mechanism is the dilatation of chambers, right? And which results in reduction in cardiac output and ejection fraction and elevation of systemic vascular resistance. So I don't want to go into detail due to lack of time. So these are the microscopic changes that are going to take place, like myocyte lengthening, elongation of nuclei, disruption of basement membrane, and this has been depicted here. So from a gradually reversible phase, it goes on to a partial reversible, then to a reversible phase. And we can see here enlarged nuclei, cellular hypertrophy, inflammation, fibrosis. These are the major things that are happening. And these are the molecular and neurohormonal changes that are going to result in tachycardiomyopathy. Not only that, these patients are also more prone for electrical changes like abnormal calcium channel handling and oxidative stress. The mitochondrial function is also going to change, inflammation, fibrosis, all these things are going to culminate and cause tachycardiomyopathy. So the experimental animal models have shown that within 24 hours, hemodynamic abnormalities can begin to appear. And after 1 week, the filling pressures will begin to increase, and at 5 weeks, the cardiac output, the ejection fraction continue to worsen. So when you are going to offer a curative treatment, the time to recovery is going to vary. Some of the patients will show recovery within 1 week. Quicker you diagnose, quicker you do the treatment, the rate and the duration dependent is very, very important. And the recovery is also quicker. The quicker you diagnose and quicker you're going to treat. An EF improvement post RF ablation or post treatment of arrhythmia, they may take up to 4 weeks also. Some of the patients may take a longer time, like 12 weeks. The insystolic volume and diastolic volume may still be elevated 12 weeks after cessation of tachycardia. The tachycardia culprit for responsible for tachycardiomyopathy. So as I've told, it may take 3 to 6 months for complete recovery. Sometimes the EF may not reverse completely. It may be only a partial recovery because of the irreversible stage that a patient has gone into. So till that time, all the guideline-directed medical therapy like beta blockers, ACE inhibitors, aldactone, along with diuretics, and along with the antiarrhythmic has to be continued. So whenever a patient develops a new onset LV dysfunction, and whenever there is always a tachycardia that is going on with a heart rate of more than 100 per minute, and if this tachycardia is going to be persistent for more than 15% of the 24 hours duration, and even there is no other cause for this LV dysfunction like hypertension, CKD, thyroid dysfunction, other endocrine metabolic parameters, or ischemia, all those things, then we have to suspect. So when the EF improves more than 15%, then it is more after the termination of tachycardia, then we have to think of tachycardia-induced cardiomyopathy, because in dilated cardiomyopathy, the improvement in EF is not going to be so robust. These are the things. Then cardiac MRI is going to be very, very important. All these patients should undergo to delineate any undiagnosed scar in such patients. There are other things also which are like abnormal unipolar voltage, more than 32%. If it is going to be an abnormal unipolar low voltage, then it is usually an irreversible cardiomyopathy, like either ischemic or non-ischemic cardiomyopathy. An NT-proBNP ratio more than 2.3 at 1 week, it is also suggestive of a reversible cardiomyopathy, that is arrhythmia-induced cardiomyopathy. So as I've already told, this tachycardia-induced atrial cardiomyopathy, in which all the heart failure mechanisms comes to play, hence ACE inhibitors, beta blockers, everything should be given. This very classically shows that in patients with enhanced isoproterenol-induced increase, when you increase the rate either by atrial pacing or isoproterenol, then the left atrial appendage velocity reduces. Here also the same thing. The shorter the cycle length, that is the faster the tachycardia, the worsen, the greater the affection in the LA as well as in the LV function. So this I have already told you. And this is how we have to diagnose. So sometimes you have to pick up the ECG clues like abnormal P wave. You should be able to diagnose, differentiate between the sinus P wave and the ectopic P wave. It's very important. Sometimes it may be very difficult. We may have to use some drugs like adenosine to differentiate between the sinus and the ectopic P waves. The sinus P waves are usually positive in inferior leads. They are negative in AVR, and they are biphasic in V1. They are pyramidal in shape. They will not exceed 2.5 mm in height, and they will not exceed 110 milliseconds in duration. And their axis is usually 40 to 60 degree, and it is tallest in lead 2. Is very, very important. So this is how we should able to differentiate between a sinus tachycardia and an atrial tachycardia. An atrial tachycardia usually shows a warm-up and a cool-down phenomena, whereas in sinus tachycardia it is usually not seen. So here, if you see the left half is sinus P waves, but if you see here in V1, if you see the first two P waves, they are biphasic, positive, negative. These are sinus P waves. Whereas if you see it is fully positive, and there is AV, the relationship between PQRS is varying. This is known as AV dissociation, which means that this is the atrial tachycardia and this is an atrial tachycardia ablation or by drugs. So this is the clinical course. We all know that tachycardiomyopathy is more often benign in nature, but sometimes sudden cardiac death have been reported in such patients. Hence, we have to be very careful.
Forward this presentation.
Be very cautious.
We left with no time for discussion.
This treatment profile in summary, so assess the renal burden has to be assessed, and other causes has to be ruled out using echo, MRI, thyroid, and other metabolic parameters. If need be, other special investigations like PET CT has to be done. And initially, it is either rate or rhythm control, and we have to go for a permanent form of therapy like catheter ablation, and use other agents also, and we have to wait for improvement of the LV function. This is a very beautiful slide on the left side. It is tachycardiomyopathy in a pediatric patient. After curing this tachycardia, we can see there is reverse remodeling and the LV size has dramatically reduced, and this patient is.
Yeah. Thank you very much. So we have completed the presentations. Now I would like to request Dr. Sanjeev Patra whether he has to ask anything to Dr. Bhattacharjee, like that, other moderators, Dr. Mondal, Dr. Tanmay Machi, P.C. Bagchi, and lastly Dr. Dipesh Agarwal to make any comments on tachycardia-induced myopathy. Dr. Patra, please.
Okay, Dr. Prithviraj, are you there?
Yes, I am quite there.
Okay, so what do you think should be the follow-up protocol of a relative of a proband, like the affected individual? How should he follow the first degree relative?
Yes, first degree relative.
What kind of investigation?
Yes, it's a very important question, because after a proband is diagnosed, it is important to screen all the first degree relative of that proband. And definitely an echocardiography and ECG is basic thing we should do in the first thing. Look for any abnormality in the ECG, any abnormality of inversions, any abnormal repolarization abnormalities, and any echo changes. And also, I think nowadays an MR has a very important role. If you have the facility to go for an experienced cardiac MR center, you should always go for a cardiac MRI to look for any abnormal late gadolinium enhancement showing the scars in the either RV or in the LV myocardium. So that is why that is the thing we should look for. relatives.
Okay, as we know, this is a disease which starts from the epicardium.
Exactly.
And gradually goes towards endocardium. So initial stages, the epicardium is involved, the ECG can be normal, affected individual. And those patients, do you think any role of exercise testing?
Exercise testing in the form of treadmill testing, I don't think so. I don't think so, because it is not recommended to go for exercise.
Maybe there's some role because no, I'm talking about the first degree relative with normal ECG and echo. Because you know this disease has a concealed state, then next electrical stage, then structural stage. So in concealed stage, the ECG might be normal. Sometimes we can get those changes in the during treadmill test exercise.
But
so you can see epsilon wave or the latency.
Yeah, but ultimately the prognosis will depend on the phenotypical changes. So you have to pick into the phenotypical changes in the diagnosis with the echo.
Yeah, or either we can at least.
Vartishaji and Dr. Bakro.
We can.
Yeah. Thank you. Thank you. And let us continue with other moderators. Dr. Agarwal or Dr. PC Bakshi, or anybody want to a quick, short questions or
Dr. Bhattaj, I have one question. I am Dr. Urjit Ghosh. Hello, am I audible? Hello.
Yes, yes.
I am Dr. Urjit Ghosh. I want to ask one question to Dr. Prithviraj Bhattacharya. Actually, if a patient of ARVD has to undergo an ICD implantation, do you want to place the lead in the apex, or do you want to place it somewhere else? So, because it is a progressive disease and it is going to involve the RV myocardium progressively. So, where should be the lead of the ICD to be placed ideally in these situations?
So very interesting question, because definitely this is a progressive disease. If you have placed a lead in the RV apex, in the disease, generally the disease affects mostly the basal inferior portion of the RV first, also the lateral free wall of the RV. And the apical part of the RV is probably the last part to be involved in this form of disease. So if you can place the lead in the apical part of the RV properly, and there is a chance of the patient may not have high resistance in future, or if it develops, it will be very late phase of the disease.
Is it prudent to place the ICD lead in the septum?
Actually, personally, I do not have experienced such a thing.
Yeah, you can. Septum usually not involved much in RBC. And
is usually not involved.
Apex also involved at last.
At very later stage.
Dr. Agarwal, Dr. Deepesh Agarwal, you have any short comment on tachycardiomyopathy? Dr. Agarwal, please. Very short comment, quick comment. Is he available?
No. Good afternoon. So the presentation was nice. Actually, my connection was not stable. So I have one query actually, whether paroxysmal lateral fibrillation or paroxysmal tachycardia and paroxysmal lateral fibrillation, how much they are contributing to development of tachycardia-induced cardiomyopathy? Like in previous lecture by Dr. Basavendra Chaudhary, he said that the peripartum cardiomyopathy was diagnosed and that lady had AVRT, and finally she was diagnosed as WPW syndrome. So that was actually intermittent tachycardia which was the cause of that cardiomyopathy, or peripartum cardiomyopathy per se was the cause of that heart failure. So how significant it was to have
Okay, thank you very much to everybody. Now I would like to ask our senior co-chairpersons, Dr. Ghosh and Dr. Hajita, if they have any special comments regarding this session, and conclude the session. Unmute, sir. Dr. Ghosh, please unmute yourself.
Okay, first of all, I make one issue in peripartum cardiomyopathy. If the couple wants a second issue, after complete recovery of the patient, ejection fraction going 60%, even after 5 years it is passed. is stable. And now the couple wants a second issue. Is it advisable? Hello?
Is it a question?
Yes. Question whether second issue is allowed after complete recovery from the peripartum cardiomyopathy. If the couple wants, what should be the advice?
Dr. Bashavendra Chaudhary, is he there?
No. Actually, the connection here is very unstable.
Okay.
Can we proceed further?
Okay. Then let us conclude the session. And thank you very much to everyone. And I'm handing over to Dr. Jayanta Shah for switching over to next session. Thank you very much, all speakers and co-chairs and all delegates attending the session. Thank you very much.
Hello?
We have concluded the session. Please.
Fine. So, is there any video to run, technical team? Any video suggested by Dr. Prakash Hajra?
Yeah, it's already run, sir. It's already run.
Please do that, and next we'll move on to the next session.
The video is already shared. You can go to the next session.
Oh, it's shared. Oh, so the next session is antithrombotics and antiplatelets. Our chairpersons are Dr. Shourab Mukherjee, Dr. Amal Kumar Khan, Dr. Kashinath Ghosh Hajra, Dr. Devashish Mitra, and Dr. Soumitra Rai. And our moderators are Dr. Indranil Bhatto, Dr. Spandan Bhaduri, Dr. Vishwarup Sarkar, and Dr. Soumya Patra. Dr. Shourab Mukherjee or Dr. Soumitra Rai or Dr. Kashinath Ghosh Hajra, who's ever here, please take over the mic.
So good afternoon, everybody. So it's nice to be in front of this August gathering. And what we are going to deal right now is about two very pivotal agents in the treatment of ischemic heart disease. They're the use of antithrombotics and the antiplatelets. And there's perhaps no one in the audience who has never used it. So we are really going to have a platter of some situations in which we are going to, use our judicious judgment in choosing the antithrombotics and antiplatelets. So without wasting much time, I would call upon the first speaker, Dr. Subhashish Rai Chaudhary, who is going to talk about a patient with mechanical prosthetic valve and what would be the ideal anticoagulation management, the situations of either bleeding or surgery or pregnancy. So over to Dr. Rai Chaudhary.
Okay, am I audible?
Yeah, you're audible.
Okay, and my screen is visible?
Yeah, you put it
Good
on
afternoon,
the
everyone.
slideshow view.
Good afternoon, everyone. It's great to connect with all of you. So the job entrusted to me this afternoon is to discuss anticoagulation issues in a patient with mechanical prosthetic valve, specifically in three given scenarios: bleeding, surgery, and pregnancy. And I'm sure that all of us have been called upon to see such patients and have managed them ourselves. So my job exactly will be to highlight the controversies and perhaps set right the evidence base regarding these issues before you today. To set the matter into the correct perspective, let me begin by first stating that every valve implantation is always a decision making. It's a question of fighting between putting in a mechanical or a bioprosthetic, a decision taken by the cardiologist or the cardiothoracic surgeon, depending on various factors. It's always a trade-off between reoperation, the durability, versus the need for stringent anticoagulation regimens lifelong. So this decision, this choice of valve processes in individual will be based on various things like valve durability, expected hemodynamics for the specific valve type or size, a surgical or interventional risk. For example, a surgeon operating, putting in a valve in a patient who had a prior radiotherapy will never go in with a bioprosthetic because he will never would like the patient to have reoperation, whatever be the age. Also, the potential need for long-term anticoagulation and patient values and preferences, though put in the last among these 5 points, it's the most important. In fact, it's a class 1 recommendation that the choice of the type of prosthetic heart valve should be a shared decision-making. Mark my words, it's a shared decision-making process. So however illiterate, uneducated, unaccustomed the patient and the relatives may seem to you, please make this a shared decision-making process, ensuring that you have told the patient all the pros and cons of each type of the valve. Basically, it's easy when the patient is aged less than 50 years, where we know we'll be putting in a mechanical valve, because the increased incidence of structural deterioration with the bioprosthesis depends on age. Basically, in a patient who is, let's say, 40 years of age, the 15-year risk of deterioration will be 30%, compared to an elderly person with, let's say, more than 70 years, the 15-year risk of deterioration is only 10%. So when he is less than 50 years, a mechanical; when it's more than 70 years, a bioprosthesis. So the ACC-AHA makes it a little easier for us. Always keeping in mind the other issues like the low risk of long-term anticoagulation in mechanical prosthesis, but the risk of intervention. On the other hand, going for a bioprosthesis in an elderly patient with a high risk of long-term anticoagulation. But it's basically the patient between the 50 to 70-year age where we would have to use our discretion, taking into account various factors, the most important being that randomized control trials with all the newer valves are lacking. So whatever we speak of is basically older valves, is non-randomized trials, and moreover, this new advent of transcatheter valve-in-valve is changing the scenario and perhaps would give us better or maybe different guidelines. One thing is for sure that with a mechanical valve in this 50 to 70-year age group, survival advantage has been documented only with the mechanical valve processes. Speaking of stroke risk, though the aortic position has equal stroke risk, a mitral valve mechanical, in case of mechanical, a mitral valve position has got a higher stroke risk than the bioprosthetic. However, taking all these account, we would have implanted a mechanical. Suppose we have implanted a mechanical valve in a person. So the antithrombotic follow-up, there are a few points which have to be kept in mind. The most important, I think, this is the different from the 2014. This is the update from 2014. The newer guidelines say that we should prefer a single INR target for each patient. So mention it as 2.5, mention it as 3, not as a range. We should keep in mind that we can have a range of around 0.5 on each side, but to the patient, it should be given as a single point target, because it has been found that if we give it as a range, then the patient will be maintained on a lower side or the higher side, giving rise to complications on either side. Number one. Number two, an intra-range variation. An intra-range variation has been associated with lots of complications. Within the range, the patient is in the range, but the intra-range increase in INR can cause bleeding. Secondly, and this is very difficult in the kind of practice that we do in our setups, monitoring by dedicated anticoagulation clinics has been shown to have lower complication rates. Having this introduction and first knowing the targets that we should be affecting for each of the valves, which is basically 2.5 and 3. Let us remember these two figures, 2.5 for the aortic and 3 for the mitral. So it's anticoagulation with VK to have a 2.5 for all our current generation single tilting disc AVR with no risk factors. But if there are risk factors in the aortic position, and what are the risk factors? Atrial fibrillation, a previous history of thromboembolism, LV dysfunction, or maybe hypercoagulable state, go for 3. For all older generation aortic valve positions, target is 3. For all mitral valve, target is 3. Just as a note, there are some new valves like Onyx AVR, where even in the aortic position, after the first 3 to 6 months, we can target 1.5 to 2. So there have been studies to show that 1.5 to 2 with this kind of valves are enough. So coming to the first scenario where we have a patient with anticoagulation that comes to us with bleeding, and we are faced with a lot of issues like what should be the cutoff INR levels, when we should stop, what can we do for the patient, and when to restart. That would be an important thing. There are a few things we should consider. First, that when the INR goes above 5, it greatly increases the risk of hemorrhage, but a rapid decrease in INR below the therapeutic level also increases the risk of thromboembolism. So it's a problem on either side. So until and unless it's a major bleeding, we should be holding our guns. And what is a major bleeding? Other than a fatal one, it's a symptomatic bleeding in a critical organ. An intracranial, obviously, even an intraspinal, a bleeding into a closed space like an ocular, articular, or maybe a pericardial, or retroperitoneal bleed where we can't assess, or IM bleed with the compartment syndrome is what we call a critical major bleeding, not a little bit of GI bleed, not a little bit of dental bleed, not a little bit of bleeding per rectum. A fall in hemoglobin more than 2 or requiring 2 units of transfusion is also a major bleed. And it's when we have a major bleed that we should really intervene. What can all we do? The first is obviously interrupt the VK that the patient is getting, and then give the patient vitamin K, FFP, PCC, and recombinant factor 7. Vitamin K, it should be remembered, though initially we used to give it at 10 milligram at 1 milligram per minute and then repeat at 12 hours, a lower dose is preferred, and preferably an oral dose, about 1 to 2.5 milligram. Subcutaneous vitamin K is unreliable, and never give intramuscular vitamin K because of the risks of hematoma. However, when we give vitamin K to this patient, it takes almost 12 to 24 hours for the INRs to stabilize. So that's quite a bit of time. And always remember that the extra dose of vitamin K, it will be making the patient warfarin resistant. It has an incidence of 3% at 1 week, which can be catastrophic in some situations. What about FFP? The major advantage being the time to effect is 10 minutes. And within 9 hours, you can have it reversed. And with FFP, we're giving 3 to 4 units, will reverse the anticoagulation. But at the disadvantage of giving almost 3 units with 750 ml of fluid, so that's fluid overload, transfusion-related acute lung injury, infections, and most importantly in our setup, a delay. Getting an FFP takes some time. That's the place where perhaps PCC comes in. Prothrombin complex concentrates are richer by almost 25 times compared to the FFP. It's rich in factor 9 also. A 60 ml PCC is equivalent to 1.5 liters of FFP. And it reverses the INR within 10 to 30 minutes, which makes it important that we look at the INR at 30 minutes or 6 hours and thereafter daily. Problem being its cost and its availability. There are some issues with PCC that we should keep in mind if we are using it, that the thrombotic complications have been found out to be 2.3%, maybe because to the higher concentration of factor 2 in PCC. And do not forget that if you're giving PCC to the patient, there will be an increased incidence of rebound INR increase in 12 to 24 hours. Why? Because the half-life of warfarin is much more than the half-life of PCC or even the FFP. Recombinant factor 7A is has not been much tried in mechanical heart valves, and therefore administration of FFP or PCC are what's given class 2A indications is said to be reasonable in patients with MHVs in uncontrollable bleeding who require reversal of anticoagulation. So these are the guidelines, ACCH guideline, which says that if it's between 5 to 10, you can just about withhold VKA and go for CL INRs. And when it goes more than 10 without any bleeding, then only you give oral vitamin K at a dose of 1 to 2.5. And uncontrolled bleeding, you can try out a FFP and PCC. ESC tends to differ. ESC tends to say it's that with increased INR more than 6, there's an exponential rise in bleeding. So maybe just when it goes to more than 6, we should be starting off with our oral vitamin K. So we can keep on fighting between when to start, maybe 5, 10 or whatever. But the issue is if there is no bleeding and if it's around 5, we can just withhold the VK. That's method number 1. Method number 2, if it's an uncontrolled bleeding, call for FFPs and maybe PCC also. The important question is when to restart, especially if there's an intracranial hemorrhage. So this is a very good paper about management of dilemmas in patients with mechanical heart valves and warfarin in the 2012 issue of WJC, and an ACCA paper in 2018 about a German cohort. And the relevant lines that I could find here was that in case of intracranial hemorrhage, we can start considering restarting DKs after 6 days, but preferably withhold it for 7 to 14 days, and restarting within 14 days, within 2 weeks, increase bleeding rates. So maybe to summarize, we should wait for around 2 weeks before we can start the VKA, but then individualize depending on the nature of the valve, the location of the valve, and the number of the valves. In case of extracranial bleeding, the most common scenarios that we face in our OPD, do restart within 48 to 72 hours, do not withhold the VKAs. Which would bring us to our scenario 2 of surgeries. And what to do when the patient is going for a surgery would depend on the type of surgery, on the bleeding risk of the patient, on the patient risk, and again on the type of the valve. And there are lots of controversies. The ESC and ACC fights. What does it fight about? About bridging. ESC routinely recommends bridging about in all surgeries, whereas ACC-AHA and the other newer guidelines does not recommend bridging in case of bileaflet or the newer generation tilting disc MHVs in the aortic position. The logic being basically that it has been found, and more so in AFib studies, that bridging does not decrease the thromboembolic risks, but increase the bleeding risks. So what the ACC-AHA does, it says it gives a class 1 indication to a temporary interruption of VK anticoagulation without bridging. Mark the words, without bridging. While the INR is subtherapeutic, in patients with bileaflet mechanical AVR and no other risk factors for thrombosis. So a mechanical AVR...
Please take care of the time because you have to talk about pregnancy also.
I'll finish in 10 minutes, don't worry.
10 minutes, the total time is 12 minutes.
No, that cannot be allowed.
At the end of 10 minutes. At the end of 10 minutes.
At the end of 10 minutes.
Right.
Okay.
I've timed it. So please. It is recommended in patients with bileaflet mechanical AVR with no other risk factors for thrombosis. That's a class 1 indication, only temporary interrupt. And bridging is a class 2A indication in case of ACC-AHA. How to bridge is an issue. And the ESC says that we should stop VK 5 days before the surgery and start off with UFH. UFH is the only allowed heparin. LMWH is the off-label heparin that can be allowed. And we switch, if we are using LMWH, then we should definitely switch to unfractionated heparin 1 day before, and stop all heparin 6 hours before intervention and start 12 to 24 hours after intervention. We restart our VKs at the end of 1 day, and when we reach our target of 2 or 2.5, depending on aortic and mitral, we stop the heparin and go on to VKAs. And I would this part, a very important note is that continuation of VK anticoagulation for dental extractions and cataract removal is one thing that ACC and ESC both agree upon. So do not stop the VKs for dental extractions and cataract removals. I thought I'd touch upon this also about anticoagulation and antiplatelet therapy when we are implanting a pacemaker, not exactly a surgery. And there are no guidelines. But this is one paper that I could find out which clearly gives a flowchart kind of thing. And it says that if then I'll just take 30 seconds more. That if there is a high thromboembolic risk, then we can continue OACs, but not if there's a low thromboembolic risk. Pregnancy issues, again, is very easier because the majority of the guidelines agree. What they do agree upon is that women with requiring high VKs. Okay. I'll conclude then. Taking warfarin more than 5 milligram, in those cases, class 2 indication that we should be changing to unfractionated heparin in hospital. Whereas if they're receiving less than 5 milligram, then we should be continuing on VKA. Okay. And at the end of 36 weeks, we should be bringing the patient to unfractionated heparin. And before delivery, we should be stopping this unfractionated heparin 4 to 6 hours prior to this. So these are the 3 scenarios. And just let me conclude by saying that prosthetic heart valve replacement for native valve dysfunction is akin to trading one heart disease to another, warranting a long-term follow-up and management. Thank you.
Thank you very much. I think the topic was a long one, but you have adequately covered it in time. And now I will ask Dr. Jayanto Saha, who is the scientific chairperson of this conference, to deliver his talk regarding NOACs. In fact, this was a subject that I had suggested to him, and I'm just glad that he had incorporated it into the final program. So over to Dr. Jayanto Saha.
Thanks to my seniors, my teachers, and my colleagues for giving me this responsibility to frame the scientific program. Respected Chairperson, sir, and my friends, my today's topic is which NOAC to choose in which clinical scenario and how to switch between them. Now, in non-valvular AF, NOACs are always a better choice than VKs because of the less chance of bleeding, and they do not require any regular coagulation profile monitoring. Less of drug and food interaction is there, and because of their rapid onset of action, bridging is usually not required. They are indicated in stroke prevention and management of venous thromboembolism. The direct thrombin inhibitors are dabigatran, and direct factor Xa inhibitors are rivaroxaban, apixaban, and edoxaban. Now, these drugs shouldn't be used in mechanical prosthesis, moderate to severe mitral stenosis, and bioprosthetic valves after 3 months postoperative if it is of rheumatic mitral stenosis origin, due to increased thrombin generation. Now, a few words to know about the pharmacokinetics of these drugs to better utilize them. Like rivaroxaban, more than 80% is absorbed with food, dabigatran only 3 to 7%, while apixaban 80% is excreted by the liver, and by the kidneys, dabigatran again 80%. Now, when we concomitantly use dronedarone, amiodarone, or verapamil for the atrial fibrillation or arrhythmia, these drugs may raise the level of NOACs that we are supposed to keep in mind. Now, as such, these drugs don't have any much difference between the safety and efficacy of the drugs, of the different drugs. As we gathered from these trials like RELY, ROCKET-F, and Aristotle, all of them have said that there is less bleeding risk compared to VK. And the Aristotle trial, the apixaban showed somewhat better prevention of stroke, and dabigatran, when using the dose of 150 milligram twice a day, it did something better for stroke prevention compared to warfarin, though that there was a comparatively same type of bleeding risk. In the Redual PCI, Pioneer AF, and Augustus trial in the ACS and the PCI situation, again the bleeding risks were less. and apixaban, the ischemic endpoints were same that of VK, and the major adverse cardiovascular events, including stroke, was comparable in rivaroxaban compared to the warfarin. The triple drug therapy was associated with more bleeding compared to dual therapy, but the recent ENTRA-SAFE trial with edoxaban has failed to show any bleeding benefits. Now, when to reduce the drugs, dosage, age, body weight, renal function, and high bleeding risk scores. Like dabigatran 110 milligram twice a day if age is more than 80 and creatine clearance between 30 to 50. In apixaban, any of the two, like age more than 80, body weight less than 60, and creatine more than 1.5. And rivaroxaban and edoxaban, the creatine clearance is less than 15 to 50. Now, this is a trial, this is a picture published in 2014 in Thrombohemostrat Journal, comparing the different dosage of the drugs, and what we see that apixaban did well in stroke prevention, but at the same time, the major bleeding risk, significant major bleeding risks were less compared to dabigatran when it was used in the dose of 150 twice a day. But again, to emphasize that there is no much difference between these drugs in relation to their safety and efficacy. In renal compromise, dabigatran is contraindicated below 30 as it is. It has got 80% excretion by the kidneys, and all NOACs are contraindicated below 15, and apixaban is preferred in renal compromise because 80% has got hepatic clearance. In coronary intervention, elective PCI stop NOACs 24 hours before, do the case with heparin, move on to NOACs as soon as possible. In STEMI situation, radial route should be the choice, and here we can use the heparin at an adjusted, as a standard dose, irrespective of the time of NOAC use. That is very important. And fibrinolysis is a much later option, and additional heparin is to be avoided. In STEMI, non-ST elevation MI, better to avoid and delay the case with low molecular heparin. Post-PCI situation, up to 1 month, it is preferable to go for triple therapy, go for dual therapy till 1 year, and NOAC after that. But the triple therapy can be increased to 3 to 6 months with high thrombotic risk, like in SES situations, and decreased to 7 days when there is high bleeding risk. For elective surgery, stop the drug 48 hours before when high bleeding risk is there and restart after 48 hours. While for pacing or ICD or EP study, we can stop the drug 24 to 36 hours before and start it 24 hours later. For emergency surgery, when within minutes we need a reversal, then reversal agents are to be considered. Now, routine monitoring is not required, and routine coagulation profile doesn't reflect, and this is not my subject today. I'm moving on to the next slide. When there is life-threatening bleed, again, the reversal agents have to be considered along with prothrombin complex concentrate. Now, reversal agents are idarucizumab and andexanet, and in acute ischemic stroke, the NOACs, if it is used with 24 hours, we shouldn't go for any thrombolysis. Exception is dabigatran, where idarucizumab is drug. Now, to prevent bleeding within the infarct, for mild, moderate, and severe stroke, we should delay the NOAC use by 3, 6, and 12 days at least, and for TIA, at least for 1 day. For intracranial bleed, when we want to use a NOAC, we should go for the reversal agents, reversing the factors like uncontrolled hypertension or aneurysmal bleed. If it is so, then after 4 to 8 weeks, we can add these drugs. Otherwise, we should go for a left atrial appendage closure. Now, for switching from VK to NOAC, we stop the VK, monitor the INR. If it is less than 2, start the NOAC immediately. For NOAC to VK, we start the VK along with the NOAC, monitor the INR. If INR is more than 2, stop the NOAC and continue monitoring the INR for at least 1 month. For NOAC to heparin, the heparin is to be started when the next dose of NOAC is due. And for heparin to NOAC, here for unfractionated heparin, we should make a delay for 2 to 4 hours, and for low molecular heparin for 10 to 12 hours. It also all depends on the renal clearance, the frailty of the patient, the age of the patient, number of factors are there. And finally, now some special situations like elderly more of GI bleed is there, less of ICH is there compared to VK. In more than 80 years of age, as we know, we have discussed that Epic-7 needs a dose reduction. For body weight more than 40 BMI, BMI is more than 40, VK, we don't have a large data on NOACs, so VKs are the preferred ones. For low BMI, again, the predictor of bleeding is dabigatran. Now, regarding dosing errors, for the missed dose, once we miss a dose for BID dosing, it is to be taken within 6 hours of the scheduled dose if it is possible, or for OD dosing, it should be taken within 12 hours of the scheduled dose. For double dose, if we are taken it mistakenly, for BID dose, we hold the next dose, and for OD dosing, we continue the normal daily regimen. Now, when remains an uncertainty about the dose taken or not, for BID dose, it should be, we should skip the present dose and continue the dose after 12 hours. And OD dosing, if high thrombotic risk is there, we take another dose. So the take-home messages are, NOACs are preferred over VK for bleeding risk. Safety and efficacy doesn't differ much between them. However, all NOACs need dose reduction with renal impairment, particularly in the elderly and frail patients. Primary PCI by radial route with standard dose of heparin, irrespective of the time of use of the NOAC, is of choice over fibrinolysis, followed by minimal duration of the triple therapy, preferably clopidogrel. And in ischemic CVA on NOACs, thrombolysis to be avoided within 24 hours unless reversal agents are available, and stop NOACs 24 hours before and start 24 hours after device implantation on epistatic or epistatic. Thank you.
Thank you, Dr. Saha. I think there are very important tips and tricks with reference to this NOACs, which we very frequently use. So we move on to the next speaker, Dr. Siddhartha Mani, who is going to talk about stuck valve, which is indeed a headache for anyone who has ever experienced a patient with it. So over to Dr. Mani.
Good afternoon, respected chairpersons, moderators, and all delegates. My sincere thanks for inviting me here and allowing me to talk on such an interesting topic. Now, can you see my screen? Is it visible?
Yes, sir, it's visible.
Yes,
Please go ahead.
Okay. So, regarding management of stuck valves, we had been evolving on the different types of surgical prosthetic heart valves, and with every new generation, we are trying to gain more durability, efficacy, as well as lower down our complication rates. Now, regarding stuck valves, there are mainly 4 etiologies that can cause it. Most importantly, thrombosis. There is fibrotic venous growth. There can be a degeneration of the valve, or there can be an endocarditis with vegetation formation obstructing the blood flow. Now, these entities can occur as an individual entity, or they can occur in a concert simultaneously. So there are different factors, surface factors on one hand, like incomplete endothelialization, or a leaflet damage, or a deterioration, or a stent fracture, or a malpositioning, or a mismatch in the size. There can be hemostatic or hemodynamic factors on the patient's perspective. There can be a hypercoagulable blood state. There can be a heparin-induced thrombocytopenia. Most importantly, a suboptimal anticoagulation or an increased platelet reactivity. On the other hand, there can be a low cardiac output, which is very common, leading to stasis. There can be anatomical prosthesis malpositioning, or there can be a prosthetic hemodynamic profile alteration, particularly in case of size mismatch or a hyperviscosity. So they acting in a concert ultimately can lead to a thrombosis or a fibrotic growth or a valve degeneration. And that can lead to a subclinical valve dysfunction without overt symptoms. There can be a very gradual or subtle development of symptoms with mild increase in echo gradients. And on the other hand, there can be clinically overt valve dysfunction with new onset of heart failure or a severe increase in echo gradient or a severe valve insufficiency. And ultimately, it leads to fatal complications like cerebrovascular or systemic embolism. If we look at the incidence, we know the incidence with bioprosthetic valves is quite low. It is 0.03%, but the incidence with mechanical prosthesis is quite high, 0.5 to 8%, and it is most common in tricuspid, which is around 20%. So we have to remember tricuspid followed by mitral followed by aortic is the rate of incidence of valve thrombosis, prosthetic valve thrombosis. Now these two entities, thrombosis on one hand and fibrotic pannus growth on the other hand, they are the two most common entities, as well as we face challenge in differentiating between two entities, because there is a definite treatment for one and there are altered treatment or a different type of treatment for the other. So if we look at the difference between them, thrombosis is basically a coagulation pathway activation with platelet and ultimately thrombin generation and clot formation, and fibrotic growth is a fibroblast proliferation leading to collagen deposition and new angiogenesis. If we look at the clinical features, this is very important. Thrombosis occurs earlier after valve replacement. It is usually between weeks to months after a valve replacement. There is a sudden onset of symptoms, and more commonly it is associated with suboptimal anticoagulation. On the other hand, during in pannus growth, it is usually a longer delay from the valve replacement, between months to years. There is a gradual onset and a progressive symptoms, mostly subclinical to begin with, and less commonly associated with suboptimal anticoagulation. Now we have to differentiate in imaging. In imaging, thrombosis looks as a larger mass or a larger volume with a higher lesion density. And we have to remember the site. It is usually on the atrial side for mitral and on the aortic side for the aortic prosthesis. So because the left ventricle is a high pressure chamber, it does not usually involve the ventricular side. Whereas on the other hand, pannus, it involves mostly the ventricular side, both for mitral as well as for aortic prosthesis. And there is greater leaflet motion restriction in case of thrombosis. So if you look at the specimens, these are autopsy specimens. You can look on the left-hand side is a pannus growth, on the middle it is a thrombus, and on the right side is a valve degeneration. So regarding thrombosis, because it is most important to us therapeutically and diagnostically, it is a multifactorial phenomenon. As I said, there are surface factors, hemodynamic and hemostatic factors, and the prosthesis thrombosis or thromboembolism occurs, suggests usually earlier, as I said, after the valve replacement. And extension of anticoagulation to prevent this thrombosis beyond 3 months carries in the risk of bleeding. So if we look as at a proposed classification, this is done for TAVR, but this can be applied to the other valves also. There are certain definitive valve thrombosis criteria, certain probable criteria and possible criteria. I will go into just the definitive criteria. It says there is a clinical criteria with regression of new onset heart failure symptoms after initiation of proper anticoagulation therapy. If we do a CT angiogram, we will see a reduced leaflet motion and there is hypoattenuated leaflet thickening. In echocardiography, we can directly visualize the thrombus, or there is regression of the elevated mean gradient by more than 10 millimeter after anticoagulation therapy, and pathologically we can find definitive thrombosis in autopsy specimens or surgically retrieved tissues. Diagnosis, we can rely mostly on echocardiography. Of course, chest X-ray sometimes helps us to assess the change in valve position, but mostly we rely on transthoracic and transesophageal echocardiography. Obviously, TE is much more informative. And these are some of the examples I will show you. This is, you can see a stuck aortic valve, and this is probably because of the pannus growth. You cannot see any visible thrombus, and you can see there is quite a significant turbulence both on the aortic side and the ventricular side, suggesting there is significant aortic stenosis, and as well as significant AR, which is measured in this. This is a peak gradient of 107 across the aortic valve. This is a stuck mitral valve, and you can see there is a visible large thrombus on the atrial side, as I said, on the left atrium side, and this is obstructing the leaflet motion, leading to a turbulent jet and a peak gradient across the mitral valve of 30 millimeter. We can also, this is how it looks like in transesophageal echocardiography. On the left atrial side, you can see a thrombus, and even in 3D, real-time 3D TE also, it can show the movement of the leaflets. We can take help of fluoroscopy because it is easily available. We can see the altered, motion of the leaflets in systole and diastole, but it is not useful in distinguishing between pannus and thrombus, which is important to us therapeutically. So coming to the most important part of treating. So how to treat, it depends on thrombus location and size, the patient's functional NYHA class, risk of surgery or thromboembolism, and obviously the clinician's experience. This is a busy slide, but this is not that much complicated. Remember, when a patient comes with an obstructed thrombus, we have to see the hemodynamic stability first. If the patient is hemodynamically unstable, we are initially starting a heparin and assessing the surgical risk. If the surgical risk is low, we should go for valve replacement. If the surgical risk is high, we can think of fibrinolysis. If the patient is stable, we can assess the NYHA class and we can assess whether the patient was taking optimal dose of anticoagulation. If there was a history of suboptimal anticoagulation, we can try with IV heparin, and on failure, we can shift to other modalities. If there was already optimal anticoagulation, we have to again assess the functional class and the surgical risk. If the surgical risk is high, we can think of fibrinolysis. If the risk is low, we can think of valve replacement. This is what we had been following for years. Yes, we had a slightly different approach with the obstructive thrombus and a non-obstructive thrombus. Obstructive thrombus is almost the same. If the patient is hemodynamically unstable, go for surgery or fibrinolysis. If the patient is hemodynamically stable and there is, you can try with optimal anticoagulation, and on failure of that, you can think of surgery or fibrinolysis. So, with obstructive thrombus, ESC says depend on two things: whether the size of the thrombus is more than 10 millimeters and whether there is history of thromboembolism. If both are present, we are directly going for surgery. If either of them is negative, that is, it is less than 10 millimeter or there is no thromboembolism, we can again optimize the anticoagulation and follow up. And if we see a disappearance or decrease in the thrombus size, then it is okay. Otherwise, we are again going for fibrinolysis or surgery. Now, these are summed up with the class of indications, class 1 and 2A. I will not go into the details. Just to look into the bioprosthetic failure, reoperation is recommended in symptomatic patients with a significant increase in transvalvular gradient or a severe regurgitation is a class 1 indication even in case of bioprosthetic valve. And reoperation should be considered even in asymptomatic patients when there is a significant prosthetic dysfunction if the risk of operation is low. So that is again a class 2 indication even in asymptomatic patients. And obviously in case of TAVI, we have to go for a heart team approach. Now ACC in their latest update in 2017 has summed up all the different NYHA based recommended guidelines to give a class 1 recommendation for urgent initial treatment with slow infusion, mark the words, slow infusion, low dose fibrinolytics, or emergency surgery in patients with a thrombosed left-sided mechanical prosthetic valve presenting with symptoms of valve obstruction. So they say if a left-sided valve is obstructed, whatever may be the NYHA class, we should try with a slow infusion of low-dose fibrinolytics or an emergency surgery, depending on the hemodynamic stability. American College of Chest Physicians has a slightly different approach. They say a thrombus less than 0.8 square centimeter, we will go for thrombolysis. If the size is more than 0.8, we will go for surgery. If the surgical risk is high, then we will go for thrombolysis again. Now, there had been different regimens, we know, with streptokinase, with urokinase, and recently we had developed tissue plasminogen activator, and this TPA has shown remarkably low incidence of embolism and hemorrhagic complications compared with STK. But our experience is much more with STK because it had been used with for years, and there had been different regimens, there had been different formulations of bolus dosing and maintenance dosing, or slow infusion or a rapid infusion. So it is clear from studies, we have already mentioned that low-dose tissue plasminogen activator has lesser embolic complications compared to streptokinase. But remember, for NYHA class 4 patients where immediate surgery or thrombolysis is required, accelerated regimens can be of better choice. So we have to individualize depending on the patient's symptoms and urgency for intervention. Now, we have already discussed that thrombolytic therapy has certain advantages with its ease of availability, high success rate, low complications, easily treatable complications, and it improves the hemodynamics even if surgery is required. And there is no contraindication to surgery because there are reversible fibrinolytic effects, and repeat infusion can be given when there is chance of rethrombosis or a partial response. So these are the advantages. Of course, we have to keep in mind the contraindications. It is almost similar as we follow in case of myocardial infarction. Now, lastly, I will just focus on a particular case series which is published in Indian Heart Journal from India. This is very interesting. They have done a percutaneous management of prosthetic valve thrombosis on the mitral site, and all of these were done on bileaflet type of mitral prosthesis. What they have done is they had done an atrial septal puncture. They had introduced the Mullen sheath, and through the Mullens they had introduced a JR catheter, and they had crossed the prosthetic mitral valve. And in this manipulation, they had dislodged the thrombus. So obviously, we think that there is a chance of high risk of embolism, but our surprise, there was a significant reduction in gradient from 38 or 25 millimeter mercury to 12 and 6 immediately post-op, and all patients had a successful symptomatic recovery, and there had been no focal neurological deficits or embolism. Although this is a small case series only of 5 patients, and we have to remember that none of the patients had a visible thrombus on transthoracic echo, but they did not do a TE. We do not know if they had done a TE, what would have been the thrombus load in such patients. But obviously, this is a result which we should look into. And all patients have been done with a bileaflet type of mitral position. So although the classical teaching is we should not cross the prosthetic valve with a guide catheter or a guide wire, and some valves like York-Shilley cannot be crossed at all, logically or theoretically, and potential chances are there for entrapment, valve disruption, or embolism. And obviously, whether such a procedure is possible in other positions or it is truly acceptable, that needs further evaluation. So to conclude, prosthetic valve obstruction obviously is a life-threatening complication, and multimodality imaging, most importantly echocardiography, CT angiography, are essential to diagnose. And in patients with asymptomatic PANAS, periodic examination with echocardiography, follow-up, and ultimately reoperation is the option. But the management of thrombosis depends on so many factors: the location on the site, the NYHA class, the presence of embolism, and the availability of surgery. So we have to decide according to our patient's presentation. Thank you so much.
May I now call upon Dr. Sobhaschi Pal to talk on what to choose in chronic coronary syndrome, dual antiplatelet or single. Dr. Sobhaschi Pal, please.
Good evening, sir. Am I audible to everybody, sir?
Yeah.
Thank you, sir. So my topic is what to choose in chronic coronary syndrome after first year of stenting. Is it single antiplatelet or dual antiplatelet? Which one is justified? So next slide. Hello, next slide. Yes. So let me first go for the newer definition of chronic coronary syndrome. In this definition, there is a 6 criteria to define the CCS. The first one is patient with suspected CAD and the stable anginal syndrome and the dyspnea. It is basically the traditional chronic stable angina patients. And also they have now divided the asymptomatic and the symptomatic patient with stabilized symptom, that is more than 1 year after any acute coronary syndrome, or patient with recent revascularization. The asymptomatic and symptomatic patients more than 1 year after the initial diagnosis of revascularization. And there are other, that is patients with angina with suspected vasospastic microvascular diseases, or the asymptomatic subjects in whose coronary artery disease is detected as clinic. So out of these 6 different classifications or groups of CCS, after the intervention, we will get either the patients who are being presented with a chronic stable angina and who requires the stenting, or the patient who presented with ACS after the STEMI or the NSTEMI, and after more than 1 year when the patient comes in the definition group of the CCS. So these two or three groups of patients will be our target group of patients to be discussed. So now, next slides. So now let me go further. What is latest ESC guidelines is telling us about the patients who meets the criteria of chronic stable angina who undergoes the PCI. And if you minorly see these guidelines, they are actually recommending to go for the aspirin and clopidogrel, and very few situations they are actually advising the prasugrel and ticagrelor. And if you go by the line by line, after the aspirin, the clopidogrel 75 mg per day, after the appropriate loading dose, it is recommended in addition to aspirin for 6 months following the coronary stenting, irrespective of stent time, unless a shorter duration, this 1 to 3 months is indicated due to the risk of occurrence of life-threatening bleeding. In the next things, that clopidogrel 75 is recommended for 3 months if there is higher risk of life-threatening bleeding. And the clopidogrel 75 mg following the PCI is considered for 1 month if there is a very high risk of life-threatening bleeding. So a patient who is undergoing PCI in a after a newer definition of chronic stable angina and CCS in sinus rhythm, so our only the dual antiplatelet is indicated, that is max to max, that is the 6 months, not more than up to the 12 months also. Next we go to the next slide. Let me discuss about what is present in the STEMI patient. In the STEMI patient, the single antiplatelet, that is aspirin, is justified, and in case of dual antiplatelet, DAPD, it is now the ticagrelor and the prasugrel is the first priority, and it is recommended for the 12 months after the PCI, unless there is a contraindication such as excessive risk of bleeding. Now, in the same guidelines, in the class 2 indications, it is a very high ischemic risk patients who have tolerated dual antiplatelet without any bleeding complication. The treatment of DAPD in the form of ticagrelor 60 mg twice daily, along with the aspirin, for longer than 12 months may be considered up to the 3 years. So in case of STEMI, after 1 year, who become a candidate for the CCS definitions, so up to 3 years, DAPD could be considered, and that becomes a class 2B indications. Now, later on, we'll discuss what are the group of patients who falls into this criteria. Next slide, please. Now we discuss about the NSTEMI. Now in the NSTEMI, there is no direct recommendations of continuation of DAPT more than 12 months in this typical guidelines of slide sets, but later they discussed. Even if this aspirin, that is 75 to 100 mg to be continued maintenance dose, and the P2Y12 receptor inhibitors, mostly the options will be prasugrel, ticagrelor, and the clopidogrel. And in this slide set and in this guideline, the straightforward, they are recommending up to the 12 months. Later on, in the next slides, we'll discuss in which group of non-STEMI patients it will be required to continue more than 12 months. Next slide, please. And as soon as there will be ACS who is patients of atrial fibrillations, after the 12 months, straightforward, there is a indications of NOACs only to be continued. So there is no questions of any of the antiplatelet after 12 months of patients post-PCI who is having AF. So in this group of patients, after the 1 year, there is straightforward, there is no indications of duopathy after the 12 months. Next slide, please. And the post-intervention, the maintenance treatment in case of NSTEMI. And in this, it is a class 1 indication to continue the duopathy for up to 1 year. That is a class 1 indication, 12 months. Next slide, please. But prolonging the antithrombotic treatment duration, that is the antiplatelet, there are 3 situations. The adding a second antithrombotic agent to aspirin for an extended long-term secondary prevention, it should be considered in a very high risk of ischemic events and without any increased risk of major or life-threatening bleeding. So the prolonging of the antithrombotic treatment duration more than 12 months, it will be decided by the balance between the ischemic load of the patients and there is a high life-threatening bleeding risk load. So that is the addition of second antithrombotic agent to aspirin for the extended long-term secondary prevention, it is maybe considered in a moderately increasing ischemic events without any increased risk of major life-threatening bleeding. So in the high risk and the moderate risks of increased ischemic risk, it is justified to continue the prolonging antithrombotic treatment duration. This prolonging antithrombotic treatment duration post-NSTEMI, in some trial it has been prolonged up to the 24 months, up to 30 months, and some trials up to the 36 months. Next slide, please. Now the shortening of the antithrombotic duration, this shortening of the antithrombotic durations after the stent implantation with the high risks of bleeding when the precise DAPT score more than 25 or the academic research consortium high bleeding risk criteria is more, the discontinuations of the P2Y12 receptor inhibitor after 12 months would be considered. And in some cases, the stopping of the aspirin might be considered after 3 to 6 months. Next slide, please. So now we should understand and we should remember, or we should go through what are the risk criteria that give rise to major and minor risks prone of the patient. The major risks, there is a multiples of criteria, but if we go by the very simply, anticipated use of long-term oral anticoagulant agents, there is a severe or end-stage CKD, there is hemoglobin below 11, spontaneous bleeding, that is recurring hospitalizations and or transfusions in the past 6 months, moderate to severe baseline thrombocytopenia, chronic bleeding diathesis, liver cirrhosis, active malignancy, previous spontaneous ICH, or any previous traumatic ICH in the past 12 months. And in this group of patients, any elderly who is having subdural hematoma, they comes in this group. And the presence of naturally the brain AV malformations, moderate to severe ischemic stroke in the past 6 months, and recent major surgery and major trauma in the last 30 days, and non-deferrable major surgery in DAPT. If you concise, if a patient needs to continuation of the oral anticoagulant, patient having the creatinine more than 2, or the patient having liver cirrhosis, or the patient having anemic, if the patient having past history of ICH, probably they become the patients with a high bleeding risk. Now let you consider what is called high thrombotic risk. Next slide. For the high thrombotic risk, it is the complex CAD or at least one criteria, and the moderate thrombotic risk, that is the other criteria, the risk enhancer and the technical aspects. So in the risk enhancer group, it is the diabetes mellitus, that is requiring the medications, the history of recurrent myocardial infarction, any multivessel coronary artery disease, any polyvascular disease, that is coronary artery disease plus the peripheral artery disease, or the past history of stroke, any premature, that is the below 45 years, or patient accelerated new lesion that presented within the 2 years from the time of onset of CAD, the concomitant systemic inflammatory disease, the HIV, SLE, or the chronic arthritis, or the eGFR between the 15 to 16. And the technical aspects, when at least the 3 stents is implanted, at least the 3 lesions is treated, and the total stent length of more than 60 millimeter. And the complex revascularization, when we are treating with the left main, the bifurcation with more than 2 stents, and it is the CTO or the stenting of the last patent vessels, or there is a history of stent thrombosis or the on antiplatelet treatment. So these are the few situations which consider as a high thrombotic risk, and we should consider this group of patients to continue the dual antiplatelet for the longer period. And if you summarize and if you think of the things, that we will get good many of subjects who is presenting below 45 years of age as a coronary artery disease. He might be having diabetes, or even eventually in the STEMI in the primary or after the NSTEMI, he might be having more double vessel disease. So this group of patients eventually becomes the candidate for long-term dual antiplatelet therapy. But it will very difficult to remember all these 2 criteria, the high bleeding risk and the, sorry?
Please summarize.
The high bleeding risk and for the thrombotic risk. So there is a risk calculator is there. for this precise DAPT score and the DSPD score. This precise DAPT score should be used at the time of coronary stenting. If there is a high DAPT score, that is more than 25, there is short DAPT is needed, that is the 3 to 6 months. And in case of precise DAPT score, if it is a score is below 25, the standard or long up to the 24 months DAPT is justified. This precise DAPT score is easily available, is a Google calculator. And if the patient, we are continuing up to the 12 months of the DAPT, next, after 12 months of the uneventful DAPT continuation, we should calculate the DAPT score. And if this DAPT score, if the score is more than 2, we should continue the long-term DAPT up to the 30 months. And if the DAPT score is less than 2, then we should stop the DAPT after the 12 months. So this precise DAPT score at the time of coronary stenting, it will guide us about whether we have to continue the DAPT up to the 12 months or shorter. And if the patient tolerates the DAPT up to the 12 months, at the age of 1 year, after the 1 year, we have to calculate the DAPT score, and depending on the DAPT score, we have to either stop the DAPT up to the 12 months or we can continue up to the 30 months. So if you summarize, so after the newer guidelines, the chronic stable angina patients in the ESC, next slide, in the ESC, they do not advocate to continue the dual antiplatelet in a patient with a chronic stable angina who is requiring the PCI. No need for continuing of the dual antiplatelet beyond 12 months. And they are recommending for 6 months only. And the DAPT of the choice, along with the aspirin, the second one is clopidogrel. And in case of NSTEMI and the STEMI patients, when they are reaching more than 12 months, we should calculate the DAPT score. If the DAPT score is high, we should continue. There is more chance of ischemic burden, and we should continue the dual antiplatelet up to the 30 months for the patients. And in this case, after the ACS, our choice should be the ticagrelor 60 mg twice daily up to the 30 months. Thank you.
Sure. So now I think I can have a little time for discussions. So may I call the speaker who had talked about stuck valves, Dr. Mani. So Dr. Mani, please, are you there? Dr. Mani? So there's a very important question that over the internet you can find there are a number of papers on bioprosthetic valve thrombosis. So how does this bioprosthetic valve thrombosis differ from the mechanical prosthetic valve thrombosis? And what is the difference in your treatment of prosthetic valve thrombosis? Dr. Mani, please, if you're there.
Yeah, yes, sir. Sir, actually, in the difference between bioprosthetic valve thrombosis is number one, the incidence is very low. And the other, the mechanical factors of the leaflet restricted motion or particularly in the older generation valves, there were certain mechanical factors which is not present in case of bioprosthetic valve. So it is basically a thrombosis, and we have to treat the thrombosis. In case of bioprosthetic valve thrombosis, the guidelines differ in their approach a little bit, that we should try with optimal anticoagulation first rather than jumping into a surgical approach or a reoperation. So that is where they say that try with before considering a reoperation, you should try for optimal anticoagulation with heparin, and then if there is a failure, you have to go for a reoperation depending on the symptoms or follow-up. But remember that if the patient is really hemodynamically unstable, and if the patient is having NYHA class 4 symptoms, or there is not enough time to delay, then surgery is an option which we have to consider also in those patients.
Very good. I think it's a very nice way to answer the question. So one question to Dr. Jayanto Saha. So just you have given very beautiful tips and tricks about the subject that you talked about. Now, in case a patient or a physician wants to switch from one NOAC to another NOAC, because the patient is changing his physician and supposing because of his own preference, he wants to switch to another NOAC. So what exactly he is going to do in such situation?
He has to, the next drug that he wants to use should be used at the end of action of the first drug. That means that when the first drug's action ends, he will give the next drug whatever he wants. That is the recommendation.
Okay, thank you.
Dr. Jayanto Shah, may I ask one question, please?
Yes.
Unqualified, normal renal function, normal LV, taking into consideration regarding the bleeding risk versus the ischemic risk, which one would you prefer? What is your first take of the NOAC? Which one would you prefer?
So as per the recommendations, there is no specific difference between these drugs. They have not specified that this has got a specific advantage.
Do you have any preference for that?
For myself, as it seems from the articles or from the different trials, Apixaban may have a small edge over the others, but all are equally efficacious, and efficacy and side effect wise, more or less same thing happens with all of them. And dabigatran has got a definitely renal part is a problem for it.
So another very important question to Dr. Shah is a very practical one. See, I have been recently discharged from the hospital after a COVID infection, and I was given heparin in the hospital. After coming back home, so the physician had advised me to take dabigatran. First of all, is it at all necessary to take dabigatran, or can I take warfarin in that case? And
no, why should you take an anticoagulant after coming back to home in COVID situation? Is there a specific recommendation for that? I don't know. Really, I do not know if during the hospital stay, it is required. But once you have recovered, I do not think there is any recommendation for in the present COVID situation of continuing anticoagulation.
Now, your D-dimer during discharge is still raised, then it is a question of giving and continuing for 2-3 weeks.
Just come back home.
Now, after coming back home also, baseline D-dimer is very high, and during discharge also the D-dimer is above the normal level.
D-dimer raise and coming back home is not very usual.
No, sir. We are seeing delayed complication like small pulmonary embolism and etc. Now, with such kind of patient, if patient is stable and D-dimer is okay, then it is okay. Otherwise, I will prefer to continue with this group of patient oral anticoagulation post-COVID.
Okay, so any other question from Dr. Kashida?
I have a question to Dr. Siddharth Mani, if time permits.
Yeah, sure.
Siddharth, thank you for your nice presentation. So, do you think this valve replacement, the clinical scenario is also important, because a patient having MS, if undergo MVR, vis-a-vis a patient of MR having MVR, do you think this MS patient had more chance of having stuck valve? Number one question. Second is, during stuck valve, partial or complete, we often see the INR is more than normal because of hepatic congestion. So what precaution you take before doing thrombolysis in this group of patients? Next, how long will you continue your thrombolysis with streptokinase to consider when it is a failed and you switch over to a surgical therapy?
Yes, thank you, Kuntalda. Number one, after you have a successful mitral valve replacement, whether you have done it for MS or MR, I don't think there will be any difference in the hemodynamic profile, because if you have successfully replaced the valve, that should function as physiological as possible. So the stasis part or the jet part, the already gone. So the LV function rather will have some influence on whether there is a hyperviscosity, stasis and all those. But MR and MS, I think, will not differ too much in the incidence of thrombosis after a successful mitral valve replacement. Number yes, there is hepatic congestion, as you said. So that part has to be taken care of. If there is really altered P time INR or APTT values, then maybe we cannot go for fibrinolysis. We have to go rather for a emergency surgery if that is really altered. So everything is depending on, as you have seen, different guidelines. It depends on the NYHA class, the hemodynamic stability, and obviously the availability of surgery, risk of surgery. So accordingly, you have to decide. It is not a fixed protocol that every patient will go fibrinolysis and then we will follow up and then we will go for surgery. So in your practical experience, also in many such cases, we go for an emergency surgery rather than thinking of fibrinolysis. And regarding how long to wait, there is no cutoff, as you know, that we should wait for 1 day, 2 weeks. Rather again, we have to see, we have to do follow-up imaging, regular imaging, and we have to see whether the thrombus is decreasing in size or disappearing. If we find on serial imaging there is a decrease in size and the patient is maintaining hemodynamic profile, then we can wait a little bit longer. Otherwise, we have to do a fibrinolysis. We can always re-administer the dose of fibrinolysis, and if time permits or if the clinical situation permits, or go for surgery.
Any of the moderators, anything to say? Is there any
we are running short of time, and we can end this session. I think
I have one
done a wonderful job, and I
just a minute.
Thank you, everybody.
Yeah, I have one question to.
Indranil, want to put in a any interesting
I was
question?
just wondering about Subro, whether Dr. Raichuri is there. In a pregnant female, especially there are recommendations. What they say is that you can maintain with a low INR in early months of pregnancy with your VK, because what they say is once organogenesis is done, you can restart your warfarin and continue it for a few weeks prior to your delivery. What are your take on that? Because
the guidelines are very clear that if the requirement of VK is less than 5, then we can continue on VK even in the first trimester. However, if it's more than 5, then it would be preferable, it's a class 2A indication, not 1, preferable to shift to unfractionated heparin. And as far as the risk of embryopathy and fetopathy go, the risks are very low.
Yes, I think this is a newer development, and people are following this for a few last few years or so. Previously, we used to change to heparin straight away, the early months of pregnancy. This is something which is can be remembered. Thank you.
Okay, thank you, everybody. I think it's an excellent session. I once again thank all the speakers who have done a wonderful job. And I also thank the scientific chairperson for inviting me to preside over. Thank you, everybody.
Thank you.
Can we start? Go over to the next session, Raghu? Technical team, can we go over to the next session? So our next session is on imaging in cardiology. We have three guest speakers here, and our chairpersons are Dr. Shivananda Datta, Dr. Shantanu Guha, and Dr. Pranab Kumari Vishwas. And our moderators are Dr. Devdatta Bhattacharya, Dr. Sumit Banerjee, Dr. Prakash Kumar Hajra. So, switching over to the session, please start the session.
So we'll just share one more video in just 40 seconds. Please allow us to share one more video from the back end. Can we go ahead, sir? Dr. Jayanta Saha, can we go ahead with one more video?
One more video. Oh, sure. Yeah.
Yeah, right.
Torrential video.
Thank you.
So we can start the session. Dr.
Thank you, sir. Please go ahead.
Whoever is there.
Yeah, I am here. Yeah, I will
start the session.
Yes, thank you, Dr. Shah. So this is a 1 hour session on imaging, and the first talk is going to be on late presentations in STEMI, imaging modalities for viability assessment. And the speaker is Dr. Johan Christopher, who is consultant cardiologist and director of cardiac imaging at Care Hospitals, Hyderabad. So the talk is for 15 minutes. If the talk finishes by 12 minutes, we'll have 3 minutes for discussion. If not, questions will be taken at the end. So Dr. Johan Christopher, the screen is yours.
Thank you very much, sir. I hope I'm audible.
Yes, you are audible.
Greetings from Hyderabad, and thank you very much for the invitation and for, I'm missing Calcutta this year, but nonetheless, maybe next year. Late presenters, we define them as a symptom duration more than 12 hours after the initial onset of chest pain. The world literature is in the range of anything between 9 to 40%, and that was presented in the European Society meeting. In India, it's approximately 30% of our patients are late presenters, and this is based on the CREATE registry, which was published in 2008. Why the 12-hour limit? Now, data from 2006 and the late 1990s have shown no mortality benefit and rather increased harm, especially intracerebral hemorrhage by fibrinolysis. Late presenters are also not included in trials showing superiority of primary PCI over fibrinolysis. And if you look at the myocardial percentage rate from 1 to 2 hours after presentation, the light green being PCI and the blue being thrombolysis, as the golden hour moves away, you see the PCI percentage, which starts at a very strong 20%, and the thrombolysis at 10% starts tapering off. And by the 12th hour, you have no benefit with thrombolysis, and that is why the 12-hour ranges come in. But you seem to have a continual around 8 to 10% benefit if you do PCI. And who are those patients who benefit? We are here to see today. So among the factors related to no perfusion, in about a third of patients who are overall presenters, apart from age and prior comorbidities, delayed presentation is a very important factor for no perfusion. And if you look at this curve between mortality reduction on the y-axis and the time from symptom onset, you can see that the great amount of mortality reduction happens in the first 4 hours. It is also the time when a critical time-dependent period of myocardial salvage happens. Once you cross the 4 to 6 hours, up to the 12th hour, it is the time-independent open infarct-related artery, or OAT, and we will just talk about this phenomena a little later. So max benefit is in the first 4 hours, and that is where either thrombolysis or PCI can really do a good job. When the duration of occlusion is less than 3 months, in the early presenters, that is about 12 hours time, all patients get primary PCI with good outcomes and good mortality reduction. Once you cross the 12th hour up to the 3rd month, it's all based on the open artery hypothesis. And as I said, we will just look at it a few slides later. Once you cross the 3-month period, when we call it a CTO, it is all about symptoms, ischemia, and viability demonstration, and that's something that I'm going to be showing you today. Now, the OAT, or the open artery theory, is basically based on what Eugene Braunwald enamored in 1989 in a Circulation article, where he described an open infarct-related artery as being very beneficial because of mechanisms such as prevention of adverse modeling, electrical stability, and collaterals to remaining viable myocardium. Now, what does the evidence have to say for the post-12-hour presenters, and what do the guidelines say about the same? The evidence, there is no level A evidence, and the guidelines are extremely unclear. So this is what most of us would do. When patients present more than 12 hours, we generally move them away from the cath lab. I'm going to tell you 2 stories, and we will see how we do it in our current practice. The first story is about Mrs. B. She's a 65-year-old lady, diabetic, hypertensive, and hypothyroid, had prolonged chest pain a day prior to admission, no heart failure or angina at admission, with QS complexes in V1 to V3 with a residual ST elevation in V5, V6, moderate LV dysfunction on the echo, and RWMA in the LED territory. She was sent to the cath lab, and this is what we saw. An occluded osteoproximal LAD with near normal circ and ramus, and a near normal RCA. Now, what are we going to do for this patient? In our center, because she was a late presenter and because she was more or less asymptomatic, we went ahead with the cardiac MRI, which is the norm for our institute. And this is the cine image of the MR showing the thinning of the mid and distal anterior septum, the mild dilatation of the left atrium and the left ventricle, and obviously the akinesia of the LAD segment. The post-gadolinium images show a near transmural scar in the mid and distal anterior septum with an ejection fraction of 30%. Now, this is the data that we got from the MRI. The IVS thickness was less than 6 mm. It's an akinetic anterior septum. Tagging showed a less than 1 mm systolic contractile reserve. There was decreased perfusion in the anterior septum on perfusion, and there was a transmural scar in about 25% of the LV myocardium. Based on this data and Kim's seminal data published in 2001, our patient is an orange who would not get any benefit even at 3 months compared to another patient in blue who had a scar of less than 25%, who would get an incremental benefit in ejection fraction. Based on this data and based on no level A evidence and a varying guideline, a viability approach provides a way out for this patient. And hence this patient did not get a PCI to LAD. She got an optimal medical therapy, the big 5 drugs, including ARNI, SGLT2 because she was diabetic, MRAs and beta blockers, and she was prepared and counseled for an ICD once she completed her mandatory 30 days of optimal medical therapy. Moving on to story number 2 is Mr. A, 55-year-old gentleman. He's a chronic smoker, had an ongoing stuttering chest pain for 15 hours with no heart failure, QS complexes in V1, V2 with an ST elevation ongoing in V3 to V6, moderate LV dysfunction with regional wall in the LAD. And when we sent him for an angiogram, this is what we found. A critical lesion in the proximal LAD and a long tubular lesion in the mid-LAD with a borderline disease in the RCA, the TIMI2 flow. The MR again was done, showed akinesia with a preserved LV size with moderate LV dysfunction. But when we did the delayed enhancement, we could find that most of the LV was clear and there was a small area in the distal anterior septum with a 50% scar. So again, based on Kim's data and based on the current evidence of somebody having an ongoing angina, the patient underwent a PCI and stent to LAD, also added on medical management, did not have any other additional viability testing, and was not considered for ICD therapy. And the patient's 6 months proof of the pitting showed an improvement of ejection fraction from 30 to 40% with a markedly improved regional wall in the LAD. So based on the above 2 cases, the questions that we should answer in late presenters are, do we revascularize without stress testing? Are all stable late presenters the same? Are there someone called early or late presenters? And what about silent ischemia? And can we or can we not do viability testing? So the BRAVE2 study, which looked at PCI in patients who had crossed more than 12 hours, this was in about 365 patients without significant symptoms, and they were randomized to PCI and medical treatment. And this is what we looked at as a primary endpoint, LV infarct size on a SPECT image. And also, we looked at the clinical parameters of these patients. And what we did find was there was a significant decrease in LV size with the PCI group of 8% compared to 13% in the medical arm, and 44% of the area at risk, which you saw on the SPECT scan, was salvageable by PCI versus only 23% by medical treatment. And in the same study, there was a mortality reduction of up to 45% in the invasive arm over a 4-year period. Another Polish study looked at revascularization after the 12-hour period. It was an observational study, and again found when you used a viability approach, the invasive arm had a 15% benefit over the medical arm. The New England Journal published in 2006 coronary intervention after PCI, and here again about 2,000 odd patients with a very strictly monitored ejection fraction of less than 50% in patients, and they looked at the primary endpoints. And these are all the tools that are used for ejection fraction. Stress may be MOGA scan, LV angiograms, echo, and MRI. And here, while there was no mortality reduction in this study, what clearly was shown was that there was a significant reduction in angina at the end of 7 years, and a repeat revascularization also was decreased at the end of 7 years. So, ladies and gentlemen, can we really salvage a myocardium beyond 12 hours, or do we just open the artery and keep it? So the first thing is we need to look at the salvage index, which is defined as on the stress maybe. You can see that this is the large area at risk, and this is the area at risk in the rest scan after nitroglycerin use. And here in white hatch is where we find that the salvage index is clearly seen, which is about 29% in the LAD and 34% in the RCA territory, showing that there is a significant salvage that can be happened. So in this study from the Netherlands and Denmark, it clearly showed that infarct size and myocardial salvage are very important when you cross the 12 hours. And in this particular study, again, SPECT MPI was done after about 30 days, and they clearly showed that the infarct size was larger in late presenters after 12 hours, that was as expected, but the area salvaged by PCI was 53% versus 66% in the early presenter, that is before 12 hours. What is important is that even in the occluded arteries, if they had a salvageable score which was adequate on MIP, there was a 40% increase in the salvageable area versus almost 71% increase when the artery was open. So yes, you can open the artery which is occluded after 12 hours, provided you have a salvageable index on a SPECT scan, which is positive. And again, in a meta-analysis for late PCI in a totally occluded infarct-related artery, clearly it was seen that in the right patient, PCI can really improve the angina and also the target vessel revascularization. What about reduction of MACE beyond 12 hours? Can we do it? Yes, if you look at Allman's data, you can clearly see cardium. 8% reduction in MACE events, and there's a 158% increase in MACE events if you keep a patient on medical therapy who is having viable myocardium. So as a gatekeeper, we need to use the tools of dobutamine, PET, and MRI before we send these patients for revascularization. And there is a class 2A indication in the guidelines of heart failure to do the same. What imaging tool you have to use? Well, you need to have a tool which looks at LV size, function, etiology, viability, perfusion, density, and also neighboring wall thickness and contractile reserve. The thallium and the MIDI scan looked at cellular integrity and perfusion. The PET scans look at metabolism and perfusion, but the MRI looks at all of them. Now, if you look at the echocardiogram, it's accessible, it's bedside, and it is cost effective. However, it has only moderate sensitivity, good specificity, but it uses stress to establish viability, and the reproducibility is poor. More or less, it cannot be used if the wall thickness is less than 5 mm. And this is how we do a dobutamine echo at the rest, low dose, high dose, and recovery. And what we really look for is a biphasic response to dobutamine, an initial improvement when you give a low dose dobutamine, which means there's recruitment of myocardium, and when the dobutamine dose increases, there is again a fall in the thickening, clearly showing that there is ischemia as well. And that seems to have a good specificity. The SPECT scan, again,
2 minutes, Dr. Christopher.
The specialist setup.
2 minutes
Sure,
left.
finishing. But the problem is radiation. Yes, it has radiation and limited use when there's less than 5 mm. What is also important is that you get the viability at rest and also the ischemia at stress, therefore being a fairly complete examination. While less than 30% uptake is clearly non-viable, more than 50% is viable. It is the gray zone where the nuclear scan really doesn't do well. And for that, you need to have what is known as a PET scan, which is extremely limited in accessibility, very specialized setup, extremely sensitive, and it also has radiation. But what the PET scan can really do is you can use a hybrid imaging and use both CT and PET, so therefore you get anatomy and viability and ischemia. And also the FDG seems to be much more sensitive in terms of viability and also gives you the absolute myocardial blood flow both in stress and rest, which is very good in balanced ischemia. Lastly, the MRI is expensive. It has limited accessibility, but there is no stress required for MRI with very good sensitivity and specificity and absolutely no radiation. And this is data sets of MRI showing cine, scar in the short axis, in the forced chamber view, in the 2C view, very good for our cardiologists to evaluate. And what is more important is when you have no scar, you have an 80% improvement in function compared to transmural scar where there is less than 4% of improvement, clearly helping us. When we have to decide between MRI and PET, clearly, even if there is FDG uptake here in the infralateral wall, if the size is less than 4.5 mm thickness, the recovery is very poor, even with FDG. However, in the same patient, if you have FDG uptake in the anterior septum and the thickness is more than 4.5, you have an 85% recovery showing that MR is the way to go. MRI is also good because of its easy availability in India compared to the paucity of PET scans. So finally, ladies and gentlemen, the sensitivity of all the tests are extremely good, but there is only one skyscraper which stands tall in all parameters, and the yellow skyscraper is the MRI with a very good sensitivity and specificity. So both the American guidelines and the European guidelines are unanimous in that it's a class 2A/B criteria if there is a significant lesion and there is only a class 3 or no benefit in a totally occluded artery late presenter unless you're able to show ischemia. And that seems to be a very, very important thing in these presentations. So unless you show ischemia on any study, then the benefit is not going to be there. So substantial myocardial salvage, gentlemen, is possible even in occluded IRA. You don't have to look at the 12-hour limit, provided you have a tool to look at the ischemia on the viability. So the practical approach as a take-home point is a stable patient presenting more than 72 hours. Please do a stress or viability testing. If it is positive, angiogram with revascularization. If it is a significant region, revascularize. If it is occluded, still open up the artery for whatever the benefit. But please use stress and viability before you go ahead. Thank you very much.
Thank you, Dr. Christopher. It was a wonderful lecture, but unfortunately, you have crossed your 15 minutes, so we will have the questions at the end. So we'll go on to the next presentation.
Yeah, Dr. Prashant Sahu. I am inviting him for his lecture. Good evening.
Good evening, good evening. Can you see my slides?
Yes, we can see your slide. You are going to enlighten on intravascular ultrasound high density, not high density, high definition, and optical coherence tomography. Please go ahead.
Anyway, good evening, everybody. And I thank the W West Bengal chapter of CSI for inviting me to give a talk. In fact, it's a very difficult subject for me because choosing between HD IVUS and an OCT. Now, basically, I have not come here to debate on which is good, which is bad, because the topic given to me is something like this, whether I have to choose between a wife and the mother. But the mother is the intravascular ultrasound from which it started, and the colorful wife is the OCT. And I am standing in between. Of course, I don't have such a beautiful wife. The whole problem is that. And now I have to debate whether which is good and which has to be taken into consideration. This thing that is survey was taken by the EAPC and the CVIT. They all had the idea that definitely any form of imaging does help. Almost 48% of the responders did say that some form of intracoronary imaging is helpful. I'd like to discuss on 3 issues. How is the HD IVUS, the 60 megahertz course over the 40 megahertz? Can we compare the HT-IVUS with the OCT? And third, which to use when? This will be my personal view. Now let us see HT-IVUS. It always gives us a sharper, better and precise view. You can see that HT-IVUS clearly delineates all the 3 layers. And of course, we use the 60 megahertz catheter is almost comparable to the OCT. You can see a good lateral and an axial view. And compared to the 40 megahertz, the 60 megahertz gives a much better view of the stent and also the other features. Now, when you use an HT-IVUS, 3 questions come. Is there a difference in the quality of imaging, how it helps in complex PCI, and how helpful is it in PAMI? Now let us see the first point. I'm taking a diabetic single vessel disease where there is a RCA lesion. The stenting has been done. Now, if you try to see what has been, the images were both done on 40 megahertz and the 60 megahertz. You can see that it is very clear in the 60 megahertz compared to the 40 megahertz, but the depth is definitely lost when we do with the 60 megahertz. Now, how it helps in complex PCI? Let us take this case of a bifurcation stenting to be done. The bifurcation stenting has been done with a decay crush technology. And after the bifurcation stenting, you can clearly see with the 60 megahertz, both the LED pullback and the diagonal pullback, how clearly LED stent is seen and the diagonal stent is seen, and the carina has been very well built. In fact, these 60 megahertz catheters are almost comparable to your OCTs, where we get a very close view of whatever we have to see. Now, this is just to show you how the carina looks like. Let me see how it helps in PAMI. We all know that when primary angioplasty is done, when you do an angio, you have to basically differentiate with whether it's a plaque erosion or a plaque rupture, because the management is different. A plaque rupture is something like this, where you get an artery where the intima is, of course, is broken. But here in a plaque, erosion, there is some amount of clot. These patients can be managed only with medications, but these are patients where you have to think of stenting. Now, anything in color looks good when the black and white films are there, but after the colored films came, we were very much attracted to them. Now, this is a simple case of a plaque rupture. You see something looking very normal, but this has been done with an IVUS and an OCT. This is an HT-IVUS. Just if you closely see the images, whatever you see on the OCT, you can see the lumen. The lumen here, there is a gap, and you can see that the rupture has taken place, which is very much visible on an HT-IVUS. So I'll not say that an HT-IVUS is something inferior, but definitely the images with your OCT are much better. But definitely, if you have this thing that is HT-IVUS, you can also definitely see everything. Now, if you see plaque erosion, what you can see over here in this picture is a plaque erosion. See the OCT picture, you can see a chunk of red thrombus. You cannot see anything beyond this thrombus. If you carefully see the HT-IVUS, the same case has been done with both these modalities. And if you see here, you can see the thrombus very well, and you can see it. That is, if I go further, you can even outline the thrombus. So an HT-IVUS definitely has a lot of benefits and is almost comparable to an OCT. So when you have to see both far and near, remember that 40 megahertz is also required, 60 megahertz is also required. When you want to see very close like an OCT, a 60 megahertz is helpful. So 40 megahertz is helpful when you have to see far. And it gives you a confidence level. So initially I had a 40 megahertz, I had the iLab. Then in fact, I went for the HT-IVUS because I know this is something which is an additional benefit to the cath lab that we have. Now let us come to the second point of comparing the HT-IVUS with the OCT. I've already compared in ACS situations. We all know the HT-IVUS advantage is that if it is a more than 5 millimeter artery, you have to use an IVUS. OCT does not help. Most importantly, all LMC data have been validated in IVUS studies only. For ostial LMC, IVUS is good. Contrast limitation is there because in large vessels, you have to push a lot of contrast and take multiple shoots. Now, this is just a simple case of an ostial left main where you can clearly, a pre-view with HT-IVUS can clearly show you where the lesion is and how much is the plaque burden. And after that, a cutting balloon has been used. And after then, this is the final results where the stent has been put at the ostium of the LMCA. And then you can see that your stent has been well opened up, and you can clearly find that the struts are very well opposed. So especially for osteal LMCA cases, it is very ideal that one should go for IVUS rather than an OCT. Of course, you can inject with this thing that is your small catheter inside your major catheter and then know it, but definitely it is better with an IVUS. Now let us come to LMCA bifurcations where IVUS or OCT is helpful. This is a case where there is a bifurcation. You can see there is a LMCA, there is a mid-LAD, there is a circ lesion, and all calcific. So you first can go for a rota and out to both the arteries, the LAD and the circumflex. And after the rota, you see there is a ring calcium which has been debulked, and you can know what is the size of the stent. And this has been done, and this is the final result. This was the pre, and this is the final of the LMCA bifurcation done by DK Crush. And you can see the IVUS images were comparing the this thing that is OCT images. They're almost comparable. It is not that the IVUS is anything inferior than an OCT. Now, the same case we have done a pullback, and I've seen how the carina looks like. The carina also looks like very well, and you can see some struts are malopposed, and this is how it has been done. This is another case of 62 years old with LMCA bifurcation, coming chronic stemmal angina. The circumflex is not visible. There is LMCA disease, and a DK Crush has been done. And then you can see what the IVUS shows. The HT IVUS clearly shows a very nice view of both the LAD, the LCX, and the LMCA. In fact, one should remember that all values are validated in IVUS studies only, and we cannot extrapolate them to the OCTs. We can know the Kang's formula of 5, 6, 7, 8, or whatever is the larger population formula which has been given. Now, where does OCT have an edge? It is in two situations. One is calcification and in-stent stenosis. Now, we know that in calcification, if you do not detect, it has a lot of disaster, like the ship hitting a big iceberg. There's a lot of muck in bit below. Now, let us compare your IVUS with OCT. You will see, so far as detection and localization is concerned, they're both same. It is only the quantification of calcium which is very important, which is in OCT, and that is how it has helped us. Now, let us see how we quantify. We know that to quantify it, you can know the length, whether it is more than 5 millimeters, whether the arc is more than 50%, and whether what is the depth of the lesion. This is something which is not very practical on an IVUS, but is very much practical on OCT. And based on this, there's an algorithm giving them various points, and we can know whether what is a strategy to be followed, whether NC balloon, a lithotripsy, or a rota ablation has to be done. Now, this is a case of calcium where you can see a very clearly a ring calcium, and it definitely mandates that if you do an IVUS, you can see almost more than 180 degrees, there is calcium. And if you also do the OCT in this case, you will see that there has been calcium at various ends. And so the main aim was to just debulk it with the rota. And then after doing the debulking, we can go for this thing that is stent. It was given 2 stents are put, and finally this was the result. And if you do an OCT, you'll try to see and be very sure that your stent has not opened, although it is opposed. There's a stent apposition index, but here you see the stent has to open more. Even on the fluoroscopy, on deep fluoroscopy, you can see that these 2 stents, the stents where it has been has not opened properly. So the next thing is to do is to take an OPN-NC and dilate it, and finally you get a good results. And this is very much visible at the point 50, where we saw that it was constricted. It is no more constricted, and we have got the adequate areas that are necessary for a good result. Now let us come to in-stent restenosis. We know OCT has a better resolution. It identifies the stent stress properly and quantifies the relationship with the vessel wall and evaluates the stent coverage, strut coverage, apposition, neointimal hyperplasia. Not only that, based on the OCT, the strategy can be planned whether it's a POBA, a laser, or a DS, a brachytherapy, a scoring balloon, OPN, whatever has to be used has to be decided based on the characteristics. But it might be so that in some cases you might have to require both. It is not a single study that can help you. For example, you see this is a 68-year male who had chronic stable angina in 2011. The LAD is occluded totally. The circ has got the OM has got a tight lesion. And this is the LAD, intervention where a 3 millimeter stent has been put. This is a Cypher stent done way back in 2011. And this is the everolimus implanting stent which was then put in the circumflex. The results was good and the patient was sent off. And then in 9 years later, you can see what has happened. The LAD has totally got an instant restenosis, and so has the OM. So here we have to see what can be done. With the LAD, we saw that there was a lot of new intimal hyperplasia, as could be seen on the OCT. And then this was a cutting balloon was used, and after the cutting balloon was used, then again the stent, another stent was put, and then when you do the OCT, you can see that the stent has opposed very well, all struts are opened up, and you can see the diagonal is also very much well opened up, and so the results was good. So instant restenosis is another area where there is definitely a bigger role of OCT to play. Now you come to see the OM. The OM is one where we cannot take an OCT catheter here. So here you might have to take, you have to use a IVUS catheter and have to do this OM. And that is what we did with the pre-imaging with a HT IVUS. And after the pre-imaging HT IVUS, we did put another stent over here. And finally, these are the HT IVUS images where it is looks good. But sometimes at the end, where the lesion is very much towards the end, it is difficult to take an OCT catheter. Now then, who walks the red carpet?
Here, because then we can have.
Yes. I am just over. This is the last slide. Who walks the red carpet then? Because you'll see sooner or later we'll all quote our mothers, because after all, if you compare your wife with your mother, then you'll see that ultimately they're almost similar. Then so far as the imaging is concerned. So this is my final slide to have the take-home message that my personal views on LMCA disease or vessels more than 5 millimeter for exact positioning of ostial stent and CKD, where you want to do a minimal contrast angioplasty, to identifying the true and false lumen, do a CTO where you puncture the cap, or do especially in patients with LV dysfunction where you don't want to use much of contrast, and HT IVUS is better. Of course, for calcifications, the only advantage is quantification, ISR, bifurcation where you want to do a strut crossing, dissection. Does it need an intervention? Here OCT really helps. But overall, you can manage the HT IVUS, and for better imaging, and OCT is there. Now, this is something from the same study where it was shown that if the value of IVUS and OCT was almost shown by 56% of the respondents that if definitely they require. And if you see, this was from European, Japanese, and all countries, they showed that almost an 13 to 12, almost 13% population has same view, that some said OCT is superior, some said that IVUS is superior. A quotation goes, no man succeeds without a good woman behind him, wife or mother. If it is both, he is twice blessed indeed. In fact, I'm twice blessed having the OCT with me and the HT IVUS with me, and whenever required, both are interchangeably used, and you can get all the images, whatever you need. Thank you very much for the patient hearing.
Great. Big thank you to you.
Thank you.
So we move on to the next session and then take up the questions as decided earlier. So Prashant is ready. Is the next presenter is ready?
Sharath Reddy, Dr. Sharath Reddy.
Dr. Sharath is ready. Yeah.
Prakash Hajra, Dr. Prakash Hajra is here.
Sharath, welcome, and please go ahead with your presentation.
Yeah. First of all, I thank CSI West Bengal for inviting me for this talk on intracardiac echography. When this is the imaging, which is much less penetrated and much less used in our country. As per the availability is concerned, we have two types of catheters, ICE catheters. One is rotational, that is mechanical catheters, just like our intravascular. Another is phase direct catheters. So phase direct catheters, wherein multiple piezoelectric crystals are used with a wedge-shaped imaging, which is available with the two companies, that is Siemens and Abbott Vascular. So, but as of now, we have only one catheter available, that is Ultra ICE catheter from Boston Scientific, which is used in few cases of ASD closures and septal punctures in our center. So our experience is also limited. It's not wide. I mean, we have not used it in structural interventions yet. So coming back to the catheter, this is the rotational catheter or mechanical catheter, and this is phased array catheter. See how the rotational catheter imaging happens. So it's basically 360 degrees imaging like our coronary IVUS with a single piezoelectric crystal. And we need 9 to 10 French catheter for this. It's a 9 to 10 French catheter. You need usually around 9.5 to 10 French sheath to introduce it. And this is not steerable. It's a straight catheter which you have to place in SVC, pull it down to IVC and imaging heart. So this is not a non-steerable catheter, and it allows near-field imaging up to 5 centimeters. Usual imaging frequencies is between 9 to 12 megahertz. So, and this provides an excellent imaging of interatrial septum, so which I'll show you subsequently, and it aids in transseptal punctures in left-sided EP procedures. And only thing is familiarity with images is very, very important while using this catheter. So it is quite cost-effective when compared to phased array devices, which are almost 3 to 4 times the cost of this device. And phased array devices are available. I don't know, as of now, it's not available in our country. So this is a multiple piezoelectric crystal device with a 64 element transducer and generally 8 to 10 French catheter. So we have 4 deflections which can be used in imaging heart with this catheter. It's a wedge-shaped imaging, the way we do echocardiogram with our probe. So we have an anterior, posterior, and right and left deflections. The way we use our transesophageal echo, the same way we can cause deflection, and we can image heart in a wedge shape. So but these devices, phased array devices, have wide applications when compared to rotational device. It offers far field imaging and it is steerable, and but the only thing is it's very expensive when compared to rotational devices. Coming to the applications of intracardiac echo, so we have been using this in ASD device closures. In complex ASDs where rims are not well visible and where we can't do with the TTE plus fluoroscopy. So in those cases, we used a couple of cases, we used this. The advantage is it's a single operator approach, so you don't need a second operator to show transesophageal echo and interpret transesophageal echo. So one operator can do himself positioning of device as well as eyes. And visualization is definitely better visualization of rims and device position. So this is, you can see, the catheter is in right atrium. This is right atrium. So this is left atrium. You can see this is atrial septal defect, and this is aorta here, and this is a right ventricle. Sorry, this is a left ventricle and mitral valve, and this is a right ventricle. So this is a tricuspid valve. So this is how you can use rotational catheter in ASD. See, catheter is exactly sitting on the interatrial septum. So you have we can use a pre-shaped sheath like Agilis sheath, which is used in electrophysiological interventions to bend the eyes catheter and to get few better images. So otherwise it's not steerable. We can use a sheath and we can bend it a little bit, and we can do. So you can see in this is SD device closure, wherein we kept ICE catheter from left femoral vein. See, this is the ICE catheter, which is exactly sitting on the septum. You can see this is, and from left pulmonary vein, I am deploying the device. So, and you can clearly see the device and device position. Yeah. So you can see the device and how device is positioned. So you can see this is a device, and this is a septum, and this is the aorta. You can see the device is holding the septum here, but at the aorta, there is a prolapse. So the device is prolapsing. So we had to again replace the device. Despite repeated attempts, there was a device prolapse at aorta. You can also see in the fluoro. So this is a notching, fluoroscopic notching, which coincides. This is the ICE catheter, which showed prolapse. Yeah. So, and despite repeated attempts, it was prolapsing. So we had to do a balloon supported closure in that case. So other application is a transeptal puncture. This is the most common use of ICE catheter. The rotational ICE provides a clear visualization of fossa ovalis and tenting of the transeptal catheters and presence of saline bubbles in LA once penetrated by broken Brunel. This is the rotational catheter usage in transeptal puncture. See, this is the right atrium, this is the left atrium, and this is a septum, and this is aorta. So, and this is your transeptal needle, which is coming down. So once needle comes down onto septum, and when it shows a tenting in the septum, then you can start puncturing it. And so, yeah, then you can puncture. So this is similar transeptal puncture with phased array device. You can see the wedge-shaped imaging, which is quite different from the 360 degrees imaging of a rotational device. So in this, as we can steer the catheter, we can exactly see the transeptal needle, and we can see clearly the tenting on intraatrial septum, and then you can see the while perforating intraatrial septum, you can keep tip in your vision, and then you can cross with sheath. So obviously, phased array device helps you better than a rotational ICE catheter. So, and its usage in electrophysiology is in atrial fibrillation ablations, where you can use septal puncture as well as direct visualization of pulmonary vein, venal junction, and ablation catheter tip location, and continuous monitoring of RF energy delivery during ablation, and also hemodynamic performance of myocardium and pericardial space monitoring. So this is something good indication where it is very useful, and AV-NRT mechanisms understanding. So there is a association of coronary sinus dilatation with slow pathway, so which can be made out in ICE, and it provides real-time visualization of ablation catheter tip and the structure and the catheter tip to contact, and also continuous contact while ablating. So it also helps in optimizing CRT to assess dysynchrony, and during implant of coronary sinus, LV pacing leads to assess the effects of pacing on ventricular valve motion and resynchrony effects, and it helps in accurate placement of array pacing lead above the fossa ovalis to shorten the P-wave duration. Other emerging roles of intracardiac echo are mitral valvuloplasty, diaphragm valve replacement, left atrial appendage closure, and quite recently, 3D volumetric ICE systems has also been developed, which yet to come into practice, which may expand indications of intracardiac echo. So in mitral valvuloplasty, how it helps is basically for septal puncture, and then placement of balloon into the mitral valve, accurate placement of balloon into mitral valve, and you can see the balloon position and balloon inflation, and also you can assess the valve before and after valvuloplasty. So, and completely by single operator. So, and its application in transaortic transcatheter aortic valve replacement is quite phenomenal. And you have 4 views, and this is mainly by phased array catheters. So you have 4 views: home view, longitudinal view, and short axis view, and transventricular view for different purposes. This is the first view in which you see right atrium and mainly tricuspid valve and tricuspid regurgitation to catch your pulmonary artery pressure. So and then followed by the longitudinal view. So in this longitudinal view, so it is obtained by advancing the transducer to the junction of the SVC and RA with counterclockwise rotation and anti-reflection of the catheter. It provides a longitudinal imaging of the LV outflow tract, aortic valve, aortic root, and sinotubular junction. And is the main ICE view to maintain throughout the procedure, especially for valve positioning. So this is an important view, so which is used for positioning a valve. You can see this is a valve, and once the device reaches here, so you can always see your depth of implantation with ICE quite clearly. So then is the short axis view, and this is mainly to assess once the valve is implanted. So you can see the short axis view of the valve to understand paravalvular leak and overall expansion of valve and need of further expansions and stuff like that. So the next view is the transventricular view, and this view is mainly to see the LV wire which we place in TAVR procedure, and also to see whether we have caused any damage to the LV or RV. Most important is the presence of pericardial effusion. So you can continuously monitor presence of any pericardial effusion and any lacerations in ventricular wall because of the wire, LV wire. So monitoring complications is very easy with intracardiac echo. So as you can see continuously the pericardial space, and if any patient goes into sudden hypotension while doing procedure, so you can differentiate the cause for hypotension also, whether it is a pericardial effusion or acute MR. So you can see in this case, so this is a pericardial effusion, so which clearly says the hypotension is because of this, and you can align your next activity, in saving the patient. And here it is the acute mitral regurgitation, so which is observed in ICE, while doing procedure. So understanding complications and strategizing next therapy to the patient is quite easy with intracardiac echo, and it is continuous by single operator. And thrombus formation, fluid occlusion, fluid accumulation usually first starts in inferior RV or posterior RA, and then slowly seeps onto apical region, and then follows complete surrounding of the heart. So thrombus formation on sheaths and catheters can also be detected by ICE, prompting interventions before embolism has taken place. So the key points of cardiac echo and key take home is it has limited but definitive application and interventions. Advantages of using ICE catheter: general anesthesia can be avoided to the patient. A single operator can assess and do the procedure, and high resolution images gives better understanding of interventional progress. And complication monitoring is always live, and understanding complication and analyzing next strategy is easy with ICE. But the limitations of eyes are cost, operator learning curve, and limited 3D capability. What could be the future of this device? If frequency tunable catheter and 3D volumetric imaging and reconstruction and cost-effective analysis, growing feasibility and efficacy data. Once these things are available, probably the eyes indications might expand further, and it may come into our regular practice more and more. Thank you.
Thank you, Sharath. That is a wonderful presentations. But since the time is, you have exhausted the time, the small queries. What about the dimensions, measurements, length and diameter, eyes versus T versus CT scan versus angiography versus the glass view of the new Philips machine? I mean, what is 1 millimeter in T? Is it overestimating 1 millimeter, underestimating 1 millimeter? Because this is very important in LA closure. I have used only one case of eyes for LA closure out of 40 cases, but there is a difference between the length and the diameter measurement between T and the eyes. What is your view? Short answer.
Yeah, I think, see, eyes, basically you overestimate a little bit when compared to transesophageal echo.
Right. Okay. May I invite the next speaker? Next chairperson, please. Welcome the next speaker.
The next speaker is Dr. Kuntal Bhattacharya. He will talk on IFR, FFR. Is there Dr. Kuntal Bhattacharya?
Yes, sir, I'm there. Please allow me to share my screen.
Yes, sir, please go ahead.
Thank you, organizers of West Bengal CSI chapter. I personally thank Dr. Jayanta Shah to take this pain to organize this webinar and inviting all the faculty personally. So after the excellent presentations by the Dr. Sahu and Dr. Sattar regarding all this imaging, all high modalities imaging, now my job is to talk about the physiology, which is most likely helpful for choosing your patient whether you will do or not. Your imaging will help you to do the case more meticulously. So what we see in coronary angiogram. In coronary angiogram, we actually see only 5% of the coronary anatomy. The rest 95% is actually the microcirculation, which is not seen in coronary and provisional coronary angiography. So these are the conductance artery, which is size is more than 500 microns. And the lesser size vessel is the microvasculature. Both the micro and microvasculature usually handle this entire coronary flow and give the distal perfusion. So what happens during rest, there is a resting blood flow, and during exercise, there is maximum blood flow at the cost of increased epicardial arterial dilatation as well as the microvascular dilatation. But whenever there is a constriction at the epicardial artery, during exercise, the vasodilatation occurs at peripheral levels, that at the level of microcirculation, and the pressure drops. That is the concept of reduced coronary blood flow during exercise and FFR measurement. So these are the picture which shows at a particular level of stenosis, maybe at around 90% stenosis, the resting blood flow is diminished. And during exercise, probably between 75 to 80% stenosis, the flow starts diminishing at maximum exercise. So this is the flow pressure relationship. Whenever there is a reduction in flow, there is reduction in pressure in the distal. That is the basis of FFR measurement. So if you see the coronary anatomy from proximal to distal vessel, the pressure remains equal, but the flow diminishes from proximal to distal part because the resistance in the microvasculature and the distal circuit increases. Because the surface area and the perfusion area increases proportionately. So this actually happens when there is a focal stenosis. There is less amount of macro as well as microcirculation. When we put a stent in that focal stenosis, the macrovasculation and microcirculation both are restored. When there is a focal stenosis, along with there is diffuse atherosclerosis down the lane, even after putting the stent at focal stenosis area, we cannot achieve the full microcirculatory flow. That is the problem of diffuse atherosclerosis. So the FFR account for size of perfusion area. If a same stenotic area perfuse a large perfusion area, then FFR could be significant. But if it perfuses a smaller perfusion area, the less amount of myocardium it perfuses, then the FFR could be less. So this is the slide which shows 60% that is borderline stenosis. The FFR in the upper panel shows 0.6 because it perfuses more than larger area, and the smaller area, the FFR is not significant. Similarly, if after post-myocardial infarction, a significant amount of myocardium is scarred tissue, then FFR could be false negative, that is less significant, whereas in a normal perfused myocardium, the FFR could be significant. Then it depends on the collateral circulation. If the collaterals are not well developed, that is poorly developed collaterals, then FFR in the distal stream could be significant. But when there is a well developed collateral from the opposite side of the coronary circulation, it could be false negative. So these are the pitfalls of measuring FFR in different area of perfusion and at the setting of different collaterals. Now this FFR is well correlated with the thallium scan and stress echo. The sensitivity and specificity is very high in the range of 88% and 100% respectively. So the FFR decision making is helpful in guiding diagnostic procedure, in guiding PCI procedure, and evaluate the PCI procedure post stenting. So what is the cutoff value of FFR? The FFR cutoff value is, if we take it is as 0.75, the sensitivity of 88%, and where the ischemia is very unlikely. Whereas if you take a FFR cutoff value of less than 0.75, the specificity is 100%. So a normal artery is having FFR of 1, and at less than 0.75, it is a significant ischemia down the lane. So in all the studies, the FFR cutoff value is taken as 0.80 to take care of your coronary anatomy. That patient maybe have benefit with coronary angioplasty. Now this fourth slide, which shows visually almost equal 50 to 60% stenosis, but down the lane, if you see the FFR value in this LAD lesion is 0.71. The RCA this lesion shows 0.91, so you can leave this artery. This LAD which shows around 70% stenosis, the FFR is significant again. This artery which is a tubular lesion which is around 75% stenosis, but FFR is more than 0.8, that is 0.84, so you can leave this artery. So if you see the functional physiological assessment vis-a-vis, we compare the angiographic mismatch, we can see even in intermediate lesion, that is between 70 to 80% stenosis during angiogram, 20% of the patient did not show any physiological coronary blood flow jeopardy. So 20% less PCI can be done when you consider all these intermediate lesions should undergo physiological study in the form of FFR assessment. So FFR can be useful in guiding revascularization decision and even in more severe angiographic stenosis. Even in that 80% or 90% stenosis, 20% population does not show any physiological compromise in the coronary circulation. The safety of differing PCI based on this DEFER study, which shows if you consider FFR negative patient to continue medical management, there will be no difference in the hard outcome or outcome in long term. Assessing the result of intervention, so the FFR after stenting, it is studied on bare metal stenting. If you achieve a FFR of more than 9, then the restenosis chance is very less, in the range of 4 to 9%, whereas below 8, it is in the range of 20%, which is very high. Now, if you compare all these studies of FFR, DEFER, FAME, and FAME2, you can see if you consider physiological assessment in all the intermediate lesion, the medical management was better than PCI in case of less FFR. And if in FAME study, if FFR guided PCI is more beneficial than medical treatment, in considering the repeat revascularization or urgent revascularization. These are the Dynamic multi-study and FM2 result. All these studies shows that the PCI, if guided by FFR, is more beneficial and there will be less mess in long-term outcome. Coming to now the resting index. These are actually IFR is with the Volcano and RFR is with Abbott. So this is actually a resting index and it is a non-hyperemic index. So it reduces the time of your procedure. The IFR actually based on the principle of wave-free period pressure measurement, that is PD by PA. When there is less noise, there is constant pressure and there is maximal flow in the coronary artery. So these are the complete cycle flow in the left panel, which averages around 19 centimeter per second in the coronary. The diastolic flow is higher. We know in the coronaries, it is in the range of 29 centimeter per second. So during this diastolic flow, this PDA and PA is measured at rest. And that is the essence of measuring IFR with the Volcano or Philips. The cutoff of IFR is taken as 0.89 in more of the studies. This is the defined flare studies, which shows if we consider IFR along with FFR and almost 2,500 patients were studied, they are almost comparable. And the incidences of death, MI, and unplanned revascularization is equal whether you measure FFR or IFR. The another study, that is IFR Sweden study, it is almost taking the population of 2,000. The similar IFR and FFR are comparable. The event set is both in case of 6 to 7% in long-term follow-up. This is the another resting index, that is resting full cycle ratio. It is the copyrighted by Abbott. It is actually the entire cycle was studied and the minimal PDPA ratio was taken. So it is not considering the systole or diastolic phase. It is considering the entire cycle length and the minimal PDPA ratio was taken for measurement. Similarly, in RFR, the cutoff value was taken as 0.89 like IFR. The advantage of IFR over FFR is when you have a serial lesion or a tandem lesion, you can assess the individual lesion severity by pullback method, which is not possible with FFR at present. The ILUMEN 1 and predict analysis shows the RFR is 79% accurate versus FFR with a cutoff value of 0.89 with the sensitivity and specificity both scoring in the tune of 80%. And several studies which compares both IFR and RFR with FFR, they are almost comparable in the term of accuracy, sensitivity, and specificity in the range of 80%. This slide shows the comparison of RFR versus IFR, and you can see these are very much comparable, both these resting parameter, and the accuracy is almost 97%. Now I'm showing a particular case. This is the case with osteal RCA stenosis, which showing a 60% stenosis in the ostium of RCA. The FFR measurement shows it was 0.66, but the IFR measurement shows it is 0.890. That means it is a non-significant lesion. But why it is so? So if you see the actual coronary perfusion during systole, there is less perfusion in left coronary artery, but in diastole, left coronary artery perfusion is maximum. But in case of RCA, the systolic flow is higher than the diastolic flow. So in those cases, you may get a wrong IFR. And in this particular case, the RFR correlates better with FFR. So I will consider to do RFR over IFR in case of borderline stenosis in RCA. So this is the guideline where you choose FFR after your RFR measurement. So measure RFR in the intermediate lesion. If it is less than 8.6, you go ahead with angioplasty. If it is more than 0.93, you can defer and continue medical management. And the window is if between these two, then this chance of false positive is more with FFR. So in those gray zone, you consider doing FFR measurement after your RFR value between 0.86 to 0.93. These are the comparable value of IFR with FFR along with RFR. Both are comparable in all the studies that is advised to verify to and contrast. This is the case, which is an elderly lady presented with angina post-PTCA. You see this RCA stent is well pattern. There is a distal PDA stenosis. You can leave it medically. This is another stent in the LAD, which is also patent, and there is another stenosis from the diagonal just after stenting. So which artery is causing angina? You cannot tell. So the IFR or FFR or RFR will help. So the IFR measurement was done in the diagonal branch. It is 0.96. Same IFR was measured in this PLP branch with 0.26. So probably this is the culprit artery. And it is far away from the stent, so better you deal with this artery with angioplasty. The diagonal angioplasty will be really difficult in this situation because it already stented LAD segment. So this is the post-PCI result in RCA. And the post-PCI IFR is 1. It's an excellent result. So this is my conclusion. The strong randomized clinical trial evidence that physiology-based coronary revascularization by FFR guidance improves clinical outcome. This is primarily achieved by avoiding revascularization of hemodynamically non-significant stenosis, which have been shown to be associated with very low adverse event rates when treated with OMT, when all the studies have taken 5 to 7 years follow-up. IFR-guided revascularization appears to be non-inferior to FFR. Similarly, the RFR is near identical with regarding the diagnostic accuracy, sensitivity, specificity, if we compare with IFR. And compare directly to the authentic Volcano IFR, the Abbott RFR is highly correlated and has a high agreement with an identical cutoff value. Thank you.
Okay, thank you, Kuntal. That was very good. Excellent presentation. Cleared off a lot of doubts regarding the 3 modalities. We are at the end of 1 hour. Unfortunately, we have crossed our 1 hour limit. But with the permission of Dr. Shah, I think we will take 1 question for each session, except the ICE session where Dr. Hajra has already asked a question. So my question to Dr. Johan. Are you still there, Dr. Christopher?
Yes, sir. Yes.
Okay. So if you have a patient who is 12 hours down the line, and you see that the proximal LAD is occluded, there are no other stenosis in any other vessel, but you see that there are collaterals from the RCA into the mid and distal LAD via the septum. And you are not absolutely sure whether the LAD territory is viable or not. Will you defer the procedure, go for a viability assessment, or having looked at the collaterals, you would go ahead and revascularize it?
Yes, sir. And this is just based on data and our own data that collaterals are helpful, but they are not the true indicators of viability. They definitely will assist, they definitely will help you. But what really will make a difference is if the patient, as we showed you the guidelines and the data that is there, the patient
you would go for a viability assessment. Yes. Yeah. So let me just ask you a short follow-up question. So those patients who have collaterals, what is the chance of them having viability compared to those who do not have it?
Yes, definitely. If there are collaterals, the chance of viability is higher than those who do not have viability, but it is not a linear correlation. That's the important thing. And when we talk about viability, we are not talking about a yes or no, and that's the beauty of MRI. We're not talking about yes or no anymore. We are talking about a graded quintile or quartile form of viability. So for example, I'll just give an example for the same patient. If the same patient has an LAD ostial occlusion, and I have a 50% scar in the mid and distal anterior septum, I will tell the interventionist, or I will go ahead with the procedure. I will open and get that. Now, if the same patient has a near transmural scar, and if the IVS thickness is less than 6 mm, and if the perfusion and MRI is near absent, and I find microvascular obstruction in the anterior septum. This is a patient, whether collaterals or no collaterals, I'm not going to touch this patient because no recurrence will be very high in this patient.
Very good. Very good. Thank you very much. Okay, that clears it up very nicely. Okay, so one question, Dr. Banerjee, if you are still there, would you like to ask one question to Dr. P.K. Shahu?
No, he has answered everything. I think
maybe you have then one question for Dr. Kuntal Bhattacharya.
Yeah, Kuntal, the issue is non-hyperemic FFR is probably the future.
Yes, sir.
But my issue is that suppose a patient who has a left ventricular hypertrophy and a coronary artery disease, or a left ventricular hypertrophy with a myocardial bridge along with coronary artery disease, we really sometimes find that the FFR is still not coming down after you have done angioplasty, and you feel bad about it. So I don't know what will be the outcome of those cases where the FFR is still not to the desirable range, and but you have done a successful angioplasty by imaging wise. So this is really the future, probably.
Is it?
Yes, sir. The microvascular architecture, if is at jeopardy or distal down the lane, if there is a muscle bridge, then we are expected that the FFR will not come down. So that is the problem.
Yeah.
Okay, so thank you very much, all the speakers and the moderators. And in the interest of time, I think we will have to end here.
Thank you, sir.
And over to Dr. Shah to carry on the next session. Dr. Shah.
So it was a nice session for us. So now we move over to our next session, that is coronary artery disease. And coronary artery disease, we have my okay.
Yes, sir. Yes, sir. Yes, sir. Please go ahead.
So our chairpersons are my teachers, my Dr. Monotosh Paja, Dr. S.S. Chatterjee, Dr. Kahali, and the moderators are Dr. Arnob Rai, Dr. Ranjan Sharma, Dr. Shubhra Banerjee, Dr. P.S. Mondal, Dr. Jayanarayan Naik, and Dr. Anil Mishra. So please start the session.
Okay, thank you, Janta. Am I audible to you?
Yes, sir.
Yes, sir. Yeah. Okay, thank you very much. So, Dr. Kahali with me, I think Dr. Chatterjee may be available. So, first speaker, Dr. Manojit Lodha, he will speak on the STMI equivalent. Dr. Lodha is, yes, Dr. Chatterjee, please welcome.
Yes.
Dr. Lodha is there?
Yes, sir. Yes, sir. Can you hear me, sir?
Yeah, clear. Please start it.
Okay, sir. Thank you, sir. Yeah. Good evening, sir. Can you see my slide, sir?
Yes, everything fine. Go ahead.
Okay, sir. Thank you. Good evening, sir. Today we are going to speak about the STEMI equivalents and opportunity to save myocardium. So we know the ST elevation MI is defined as ST elevation of more than 1 millimeter in the limb leads, and in precordial leads it is more than 2 millimeter in at least 2 consecutive leads. We know it is a ST elevation MI, and we all know what to do with these patients. But standard STEMI criteria sometimes do miss a significant number of patients who have obstructive lesions and who could benefit from primary angioplasty. So making recognition of these high-risk STEMI equivalents becomes all more necessary because we can identify the high-risk patients and we can early intervene and save them. So STEMI equivalents include the patients who have critical left main disease but who doesn't have ST elevation MI, who doesn't fit into the criteria of ST elevation MI, who there are patients who presented with associated posterior wall MI, who have Whelan syndrome, or who have De Winter sign on the ECG, or who meet with Garbosa's criteria and presence of left bundle branch block. So we will deal with one by one in next slides. Critical left main artery disease is defined by Whelan as who have ST segment depression in more than 8 leads with ST segment elevation in lead AVR and V1. Specifically, if the elevation in lead AVR is more than V1, then we consider it as critical left main artery disease, and these patients require early intervention. Basically, what happens is the first perforator of the LAD artery supplies the basal septum. So whenever there is a lesion proximal to this first perforator, the ST segment in the AVR will get elevated, and there will be a reciprocal ST depression in the inferior and the lateral leads. So we get diffuse ST depression in the leads, diffuse ST depression in the precordial as well as the limb leads, except AVR and V1 where there will be ST elevation. So in this ECG, we can see that there is a ST depression in all the limb leads and the precordial leads except AVR where there is an ST elevation. This suggests the patient may have a critical left main disease, and this patient requires urgent revascularization. Next slide. So another patient who have presented with chest pain, and in this ECG we see there is a diffuse ST segment depression along with ST elevation in lead V1 and AVR. And if we see the ST elevation in V1 is more than the lead AVR. So this suggests critical left main disease, and this patient again require urgent revascularization. So this was another ECG where there is a slight ST elevation in V1 and AVR with ST depressing in all other leads, and in lead AVR, the ST elevation is more than the lead V1 elevation. So this again suggests left main disease. So when this patient was taken for angiography, this suggests critical left main disease, and this patient requires early revascularization. Inadvertent delay can be fatal to this patient. So we should identify these ECG patterns. Next. So isolated posterior wall MI. Posterior wall MI usually present in about 20% patients of MI, but isolated posterior wall MI will be present in approximately 5% patients with MI. So in this isolated posterior wall MI, there will be ST depression in lead V1 to V3 with if metastasis is associated with upright T-waves in V1 to V3, or if there are tall T-waves in V1 to V1 and V2, then it suggests posterior wall MI. So, posterior wall MI, the culprit lesion is mostly in RCL in 90% patients. In 10% patients, the ST elevation, the culprit lesion may be in LCX. And most of the time, the ST depression is horizontal rather than the downsloping or upsloping. And their R waves are prominent in V1, V2. R wave may be more than the S wave, and there were upright T waves. This combination of horizontal ST depression in V1, V2, along with tall T wave, with upright T wave, and presence of R wave indicates isolated posterior wall MI, and this should be treated as ST elevation MI with either urgent revascularization. So, how to identify this posterior wall MI? Apart from the 12 lead ECG, if we take the 15 lead ECG with a lead placement on the V7 to V9 in the posterior wall, on the back, then we can identify there is a ST elevation like ST elevation MI. So this is where we should place the leads in V7, V8, and V9, and in these leads, posterior wall MI will suggest ST elevation of more than 1 millimeter, and this should be treated urgently with revascularization. So this is another case where ECG where there is a posterior wall MI associated with inferior wall MI. There is an ST depression in V1, V2, and V3 along with upright T waves. It suggests there is an inferior wall along with the posterior wall MI. This is a patient where there is just take ST depression in V1, V2, and V3 with upright T waves. So this is basically a posterior wall MI. If we flip the ECG, then we will find that it looks like an ST elevation MI with a probing of the ST waves. So we can just flip the ECG in V1, V2, V3 and look for the posterior wall MI in this patient. So this is another patient where we can see there is a horizontal ST depression in V1, V2, and V3 with upright T wave, and there is a prominent R wave in V2 and V3. This suggests the patient has a posterior wall MI, and this is an indication for urgent revascularization. So now coming another is Whelan sign. Whelan sign is very important because it indicates there is a critical left anterior descending artery occlusion in the proximal part. It is associated with changes in V2 to V4. There will be two types of Whelan signs are present. One where there is a deeply inverted T waves, and another is where there is maybe biphasic T waves may be present in V1 to V3. And initially the ECG may be normal, but the unpresentation, but subsequently the ECG, there might be ECG changes of Valen sign. The enzymes level, the more important point is the patient may have a normal enzyme level. So even with normal enzyme levels, if we get the ECG changes, this is an indication that the patient may have critical left anterior descending artery disease, and it requires early revascularization. So there are two types of Valen sign. One is where there is a deep T-wave inversion in V1 to V3, and there is biphasic type 2 where there is biphasic T-waves are present in V2 and V3. Type 1 is present in about 80% of the 75 to 80% of the valence total sign, and type 2 is present in approximately 25% of the patients. So this is the patients where there is a type 2 type of valence sign present, because so type 2 where there are biphasic T-waves are present in V2 to V3. Next is in approximately 18% of the patients who present with unstable angina may have the Valence sign in the Valence syndrome. Initial ECG maybe 50% maybe have initial ECG changes, but 50% of the patient the ECG may be normal. Subsequently, in next 24 hours, the ECG changes may appear. So these patients have normal enzymes, the normal ECG pattern, but the subsequent ECG changes will be there, and this suggests LAD or severe LAD obstruction. If not revascularized early, then these patients, 75% of these patients develop acute anterior wall MI within next 1 week. And if taken for revascularization, even 20% of these patients show LAD occlusion with some collateral blood flow. So this is an acute emergency, and patients require early revascularization. So this was one patient who presented with a chest pain earlier. When he presented, he doesn't have any chest pain, and there was subtle ECG changes. If we see V1 to V3, there are subtle T-wave, biphasic T-waves are present, but this may be missed. If we compare with this his old ECG, the earlier ECG which was done 1 month back, it was completely absolutely normal. So previous ECG was normal. In the next ECG when he presented, there were biphasic T-waves in V2 to V3. There were subtle changes, and these changes were actually missed when he presented the patient. And 1 month later, the patient presented with frank acute anterior wall MI. So we can carefully observe the ECGs, and there may be subtle ECG changes which indicate that the patient may have impending MI. And early intervention in this patient can save myocardium. So another ECG pattern which is very important is De Winter pattern, which suggests proximal, again this suggests proximal LAD lesion. There are precordial ST segment depression at the J point. If we see to V2 to V6, there will be J point depression, but there will be an elevated tall thick T-waves in these precordial leads. And most of the cases, around 75 to 80% cases, again, maybe there is a ST elevation in the lead AVR. There may be subtle ST elevation. So this suggests a proximal LAD lesion, and this patient requires early revascularization. So this was a patient who presented with chest pain. If we see there is a J point depression in V2, V3, and there are tall symmetrical T-waves present in the precordial leads. This patient was taken for angiography, and in angiography it was found that the patient has proximal LAD lesion. Patient was revascularized, and MI was averted. So De Winter sign is present with persistent hyperacute T-waves with ST segment depression. It suggests proximal LAD lesion, and in prior to anterior wall MI, approximately 5% of the patients do have De Winter sign. So early recognition of this can identify the patients and can be sent for early revascularization. So this is the patient who presented with chest pain. If we see there is in lead V4 to V6, there is a J point depression with tall symmetrical T-waves. So this again suggests proximal LAD lesion. This was another patient where there was a J point depression along with tall T-waves in V3 to V6, and the patient was taken for cath lab, and it was suggestive of proximal LAD lesion. Patient was revascularized and saved. So next, coming to one more important aspect is the Garbosa's criteria, where there is presence of LBBB. In presence of LBBB, if there is a ST elevation of more than 1 millimeter in V5, V6, then it has been given 5 points. Whereas if there is an ST depression in V1 and V2, of more than 1 millimeter, it is given 3 points. And if there is ST elevation in V1, V3 more than 5 millimeter, it is given 2 points. And if the patient has 3 or more points, then the probability of interval MI is more than 98%. Smith has made one changes in this Gagoras criteria. He has made the ST deviation more than 25% of the previous QRS complex. If we apply the Smith's criteria, the sensitivity of detecting interval MI increases from 50 to 90%, whereas though with some compromise with the specificity, which decreases from 98% to 90%. So even in presence of LBB, where there may not be ST elevation, we can identify the patients with STEMI. So to conclude my seminar, I would like to say the STEMI equivalents are the ECG changes are present when there are large area of myocardium in jeopardy. The patient may not have characteristic ST elevation as in ST elevation MI, but as the area of myocardium jeopardized is very large, so these patients' early diagnosis, activation of cath lab, and timely intervention can save the day. Thank you. Thank you. Stay safe and stay positive. Yes, sir. Sir, your mic is, sir, you are muted. Sir, you are muted. You can unmute yourself, sir, please.
Hello.
Hello, Panja sir. You are muted, sir.
Dr. Panja. Sir, we will discuss at the end of the session, sir.
Yeah. Discuss at the end of the session.
Sir,
now is okay?
Next speaker.
You go.
Yeah. Yeah. Could we move to the next session? I think we'll take the questions at the end. Otherwise, we will have time. So the next speaker is Dr. Debobrata Roy, and he's going to talk on spontaneous coronary artery dissection, issues in management. So over to you, Dr. Roy. He's already shared his screen.
Okay, Dr. Rai is a dynamic intervention cardiologist at TIA Hospital, and he is the executive committee member of the CSI. So, Dr. Rai, please go ahead. Your subject is spontaneous dissection.
Thank you, sir, for your kind introduction, and good evening to you all. Today, I'll be talking on spontaneous coronary artery dissection, which is fraught with diagnostic dilemma and therapeutic controversies. Next slide, please. Next slide, please. So it is a disease basically of middle-aged women. Initially, it was thought to be very rare, but of late, it is seen to be the cause of acute coronary syndrome in approximately 4% of the women population. And if you consider young to middle-aged women, it accounts for almost 24 to 35% of cases of acute MI. For SCAD to occur, you must have some predisposing factors, and of that, fibromuscular dysplasia is most common, and there may be other conditions like connective tissue disorders, systemic inflammatory conditions, and of course, the pregnancy status. On these patients, you need to have some precipitating factors. In fact, in about 57% cases, you can identify precipitating factors, of which majority are emotional stressors and some are physical stressors like violent exercise or vasovagal, valsalva strain. Pregnancy-associated SCAD is a dangerous entity in this disease group. They are more likely to present with STEMI. They have more left main and multivessel disease. They have a lower ejection fraction to start with. It is surprising that they have a very lower incidence of fibromuscular dysplasia, and they're related with multiparity and previous fertility treatments. Why they're important is because medical therapy is more likely to fail in them, and they will require subsequent revascularization. Next slide. So the main method of diagnosing SCAD is angiography, and there are three types of classical angiographic findings that tells you that this patient is having SCAD. In type 1, you have multiple translucencies because of this sections. In type 2, there will be a healthy proximal and distal zone, and in 2B, there won't be any healthy distal zone. And type 3, where the lesion will be discrete. Next slide. Of course, there will be other angiographic characteristics. The most significant is that there should be absence of athidoma on other arteries. There can be presence of radiolucent flaps. There can be contrast staining, as you can see here, in the false lumen. And there can be some ambiguities near the side branches. And there can be narrowing of the lumen caliber. Next slide, please. Next slide, please. Mottreff et al. Has described another two characteristic appearance. One is stick insect appearance, as you can see here in the above panel, and a radish appearance, as you can see in panel B. Apart from this, there can be development of sharp angles in a otherwise tortuous but smooth coronary artery segment. SCAD is maybe associated with segments of myocardial bridging. Next slide. Next slide, please. Now, what is the role of intracoronary imaging? Of course, intracoronary imaging has its advantages, but there are great disadvantages too. The coronary anatomy in SCAD, it actually reduces the safety of performing an intracoronary imaging. Like they have severe tortuosity, they have a small lumen size, and they have a distal lesion. So doing an intracoronary imaging procedure may be harmful. And if we really need to do it, we should limit it to the most proximal segment of an intramural hematoma. So intracoronary imaging should be performed only in cases of diagnostic uncertainty like type 3 lesions, which should be differentiated from atherosclerotic coronary artery disease, or while you are performing PCI, particularly to see whether you are the wire is in the true lumen or not. OCT is, of course, preferred over IVUS because of better spatial resolution, and it can be used to detect healing in follow-up. But it has limitations too, because the contrast injection, it can potentially lead to expansion of intramural hematoma by hydraulic pressure. And of course, in flow-limiting lesions, it will be difficult to assess the lesion. If you consider CT coronary angiogram, it is of limited value because the spatial resolution is insufficient to detect such lesions. Next slide. So this is the algorithm, how you go. If you have typical SCAD appearance, it's in type 1, so your diagnosis is confirmed. If you have a type 2, then you can give some intracoronary nitroglycerin, and if the diagnosis is not clear, you may perform an imaging study or repeat angiogram after another 4 to 6 weeks. And if it is a type 3 SCAD, which mimics atherosclerosis, you need to perform an imaging study to clinch your diagnosis. Next slide. Next slide, please. So these are SCAD should be differentiated from other diseases like atherosclerotic acute coronary syndrome, which usually occurs in male and have a high prevalence of standard cardiovascular risk factors. Then the Takotsubo cardiomyopathies, which usually occurs in more older patients and they don't have any diagnostic findings on coronary angiography. Then coronary embolism, again, there will be presence of high-risk conditions of systemic aneurysm in such patients. And lastly, it should be differentiated from coronary spasm. Again, the difference in clinical profile and male sex predominance differentiates it from SCAD. Next slide, please. So the initial treatment of SCAD is medical management. As you can see from the left-hand side, the conservative management scores over revascularization as per the occurrence of recurrent SCAD or recurrent MI. It is in fact considered as a treatment of choice. It is better to avoid thrombolysis because most of these lesions, they have intramural hematoma. The use of antiplatelets and its duration of therapy is still controversial. If you perform a PCI, of course, you have to give DAPT for 12 months. It has come into ESC guidelines, but you should avoid potent P2Y12 blockers like ticagrelor or prasugrel, and clopidogrel is preferred. Anticoagulants should be discontinued once you have confirmed your diagnosis of SCAD. Statin is indicated only if it is indicated for primary prevention. Controlling hypertension is very important because it reduces the chance of recurrent SCAD, and long-term therapy of beta blocker is recommended as per this recent trial, which has shown better survival free of recurrent SCAD with beta blocker treatment. Next slide. Next slide, please. Now, which patients of SCAD should be considered for revascularizing? Of course, if you have a patient with recurrent or ongoing ischemia despite medical management, if they have a high-risk anatomy, total vessel occlusion, or hemodynamic or electrical instability, cardiogenic shock, you have to take up these patients for revascularization. But you have to keep in mind that in 30 to 50% of cases, you will have a procedural failure. Current generation of DACE is preferred, and there are some small trials that have shown that BRS may be effective. However, we don't have this BRS now. There are some suggestions to avoid complications while performing PCI. You should not use, you should try to avoid using ampullus guiding catheters, or you should avoid deep throttling of the catheters. You should avoid using non-hydrophilic guide wires. The side range should always be wired. And intracoronary imaging, as I have discussed already, should be used very cautiously. In flow-limiting lesions, the main objective should be restore flow and not to achieve any aesthetic percutaneous result, intervention result. So better is the enemy of good as SCAD is concerned, as far as SCAD is concerned. The dilatation, if you need to post-dilate or pedalate, it should be done gently. You should avoid high pressure inflation. Sometimes cutting or scoring balloons are used to produce fenestrations in the intramural hematomas to relieve the intramural pressure and to relieve obstruction. Certain novel techniques has been described while stenting, like sandwich stenting, where you first stent the proximal and distal edges and then you stent the middle portion. And if feasible, after stenting, you should avoid post-dilatation. CFBG is indicated for if you have left main lesions or multifocal disease, but you should keep in mind again, there is a chance of 70% lead graft occlusion, presumably due to competitive flow from the healed native coronary vessel. Next slide, please. Now, are we happy with the initial medical management? The answer is no, because a considerable number of patients, in fact, maybe 1 in 6 have a hazard of suffering from a recurrent event, and this can occur within 6 days, of the index event. The risk of recurrence is higher in those who have an isolated intramural hematoma and no intimal dissection at baseline, who have a multivessel involvement with a baseline stenosis of more than 80%, who have tortuosity in the arteries, and who have an uncontrolled hypertension or are not using beta blockers. These are the patient segments who are more likely to have a recurrence of SCAD. Next slide. So in most of these patients, they present with recurrent chest discomfort, which is similar to the index event. And there will be new ischemic changes, new biomarker rise, and there can be ventricular arrhythmias in a very small percent of cases. So the angiographic, when you do angiography in such patients, you will see that the LAD is the most commonly involved artery, and there may be either longitudinal expansion of the hematoma in both proximal and distal areas, or there can be axial compression due to increase of the hematoma size. In some cases, there will be intimal tear, which we feel that is good because it relieves the intramural tension. OCTA should be performed in cases of angiographic ambiguity, like when you have an isolated intramural hematoma without any visible tear. In such patients, conservative management is still possible in 43% cases. But what is important to note is that in 65% of the cases, there won't be any change, or there may be even improvement in the initial coronary angiographic findings. So this is important because you should keep in mind the other potential non-ischemic mechanisms for recurrent chest pain in such cases, which are the neurosensory effect of the dissection, for example, the intramural hematoma causing adventitial stretch, secondary vasospasm, and presence of dysfunctional or dissected microvasculature. So you have to consider these factors before proceeding with revascularization, because in SCAD, the ultimate result of revascularization is quite unsatisfactory. Next slide. Cardiac rehabilitation plays a very important role in the management of SCAD, and this is the first cardiac rehabilitation trial done with SCAD patients from Canada. It has to be a multidisciplinary approach and includes exercise rehabilitation, which comprises of isometric exercise and can be done in weekly sessions. It includes psychosocial counseling, and with involvement of social workers and psychiatrists. There should be dietary and cardiovascular disease education, and you need a peer group support. So it has been shown with this cardiac rehabilitation, you can reduce the MACE rate to 4.3% by 4.3%. And always remember, pregnancy after SCAD is high risk. So if you have SCAD, subsequent pregnancy will be very high risk. And there is an excellent review that has been published recently in JACC in 2020, which all of you can refer to see the detailed management of such cases. Next slide, please. So this will be my last slide, which actually summarizes this whatever this management algorithms for spontaneous coronary artery dissection. If you have a stable patient without any high risk feature, you continue with conservative therapy, but you have high risk features like left main dissection, and if you have isolated left main, you can go for PCI. And if it is left main with involvement of other arteries, you have to consider CABG. If there is ongoing recurrent ischemia or chest pain or hemodynamically unstable ventricular arrhythmias, cardiogenic shock, you have to consider PCI. Again, if on angiography you have ostial LAD or multivessel SCAD, again, you may go for CABG. Of course, there is a scope for conservative therapy in other areas with optimal hemodynamic support. You can take the patient for PCI. But always, you should remember that there is a greater role of adjunctive medical therapy mainly with beta blockers, adequate control of hypertension, and probably aspirin at least for a short term. And they should be monitored in hospital for 3 to 5 days. So thank you for your patient hearing. And I am open for any question, one or two, because I am giving this deliberation from Heart House, where an important selection process is going on. So I've just taken time out of it and to deliver this lecture. Thank you.
Thank you, Dr. Roy. I think that was an excellent talk on this very interesting topic. As per the request of Dr. Roy, because he may be actually a bit involved now, so could we have a question?
I've got one question. I'm Professor Kar speaking. Hello.
Yes, Professor Kar.
Yes. the thing is that what you said that the pregnancy after SCAD is very highly risky. Yes, I agree, and we have to avoid pregnancy. But what happens? One of the common cause of acute MI in pregnant women is SCAD. Now, what are the management issues of acute MI due to SCAD in pregnant women?
Yes, sir. I think I have already described it. In acute MI, you need to avoid thrombolysis, whatever be it. If it is a MI from SCAD, it is always better to avoid thrombolysis. I understand there are issues of performing PCI in pregnancy, but it depends on what is the duration of the pregnancy, and depending on that, you can proceed with PCI.
Dr. Rai, it is a controversial subject. In the acute phase, actually, if you do the angioplasty, the stenting failure, intervention failure rate is very high. In that case, a conservative medical therapy is better. Of course, if the patient shock and other complications, arrhythmia, you have to do the intervention with the great difficulty, though the failure rate is high. My one question,
that's exactly,
the one of the important question, there is a relation of the estrogen use and hypertension, one of the important cause of the spontaneous dissection. But pregnancy is the continuation of the progesterone phase. Progesterone phase, why it is there dissection?
Actually, sir, all these are theories. Nothing has been proved. There have been many theories. Sudden withdrawal after just and if you remember, in pregnant patients, the maximum incidence of SCAD occurs in the immediate postpartum period, and the cause is due to sudden withdrawal of the estrogen level.
Okay, thank you, Dr. Roy. I think we have to move on to the next session now. It's revascularization in stable ischemic heart disease, and it's digging holes in current trials. And the speaker is Dr. Bapaditya Kumar, who is a consultant interventional cardiologist in Nightingale Hospital. So over to you, Dr. Kumar.
Thank you, sir. Are my slides visible?
Yes, it's visible.
My slides are visible?
Yes, they are visible, very much.
And I am audible?
Yes, you are.
Thank you. Good afternoon, my respected seniors and colleagues. At the onset, I would like to thank Dr. Jayanta Saha for the opportunity. I will be presenting revascularization in stable ischemic heart disease, digging holes in the current trials. Important in stable ischemic heart disease. First of all, to improve quality of life, it is a soft endpoint, and the hard endpoint to improve prognosis, prevent AMI and death. Recent evidences regarding PCI versus medical therapy for symptom relief and quality of life. Today's trial, it showed the statistically significant difference in rates of freedom from angina was consistent the entire follow-up period of 3 years in favor of PCI group. Trial corroborated the findings. The first 3 years of follow-up was more pronounced in the PCI group. In the BARI 2D trial also, we got similar findings. At 3 years from treatment initiation, angina frequency and quality of life was main PCI group. The meta-analysis from randomized clinical trials enrolling 7,000 patients showed that for freedom of angina, there was significant improved outcome with PCI compared to OMT group. But then came the Orbiter trial. In this Orbiter trial, it was found that PCI did not increase exercise time more than the placebo procedure. So, question that PCI-induced angina, whether it is at all a placebo effect or it is a reality, it needs to be answered. More trials are required to support or refute this evidence. Now, coming to the actual hard endpoints, goal of revascularization therapy to prevent AMI and death and to improve prognosis. What are the fundamental factors for stable ischemic heart disease? First of all, anatomical and mechanism of disease and distribution of disease, the ischemic burden, and the LV ejection fraction of wall motion abnormalities. The recent evidence that the test trial showed that in patients of stable ischemic heart disease, PCI did not reduce the follow-up few years. There was also no difference in survival between the two groups, but there are some loopholes in the current trial, as all trials have. Low levels of ischemia and low mortality in groups. PCI approach was not ischemia guided. Patients were selected for angiography, so highly selected patients were there. In the group, there were few drugs and visits. and ACE was used in only 2.7% patients. Coming to the 2D group, there was no observable benefit in the revascularization therapy as revascularization group as compared to therapy. In the FAME2 trial, the primary endpoint was better in the FFR group, but it was primarily drawn by the urgent revascularization endpoint. The endpoint of death and AMI was same in both the groups. The meta-analysis of 12 trials with 7,000 participants showed that the PCI was not associated with improved mortality, cardiac death, or non-fatal AMI, and the results were consistent over the follow-up time points. Coming to the evidences of versus medicine. Over the last 2 decades, there have been lots of trials published. CSS trial, ECSS trial, and the FATS trial proved beyond doubt that CBG was beneficial in improving survival as well as in relieving angina in the CSF patients as compared to therapy. CBG was particularly helpful in high-risk stable angina patients, 3-vessel CAD, in LV function, and with patients with substantial LMC stenosis. Freedom from angina significant in the CABG at 5 after treatment initiation in the CAS study. Different other studies, the VA-CAS European studies showed that CABG was preserved cumulative mortality benefit over 10 to 12 years after treatment initiation. These trials showed that CABG was beneficial to medical therapy in patients with angina and reduced EF. In fact, the more down the spectrum we go in the severity of ischemic heart disease, more vessels involved, more the ischemia and reduced EF, the impact of CABG over survival is more compared to medical therapy. Now, what are the evidences of PCI versus CABG? 6 trials, cardiac, Syntax, and Freedom compared CABG with PCI. The first 3 trials used BMS. Freedom used DAS, sirolimus or paclitaxel. Syntax used 100% paclitaxel DAS. What are the evidence? What are the results? The mortality, the AMI, the repeat revascularization, and MACE all more in the PCI group. The stroke was more in the CABG group. Is it the end of the day for PCI? Not at all. And the Syntax trial. The Syntax trial was because it was the first trial that promulgated the Syntax score, and it was the first trial that involved late men and complex coronary artery disease patients. Syntax trial. In the low tertial score between 0 to 22, PCI with taxane was not related to CABG. We leave aside the high score group, but I just is that in the intermediate group, although AMIs and repeat revascularization were more in PCI group, but over death severe AMI was similar in both the groups. So we come to conclusion that selected patients when given DES favored similarly with CABG. The final interpretation of Syntax, PCI can be done in non-diabetics up to score 3, diabetic score less than 22. Late men is up to 33, especially osteal and trunk lesions. CABG with patients complex lesions diabetes with scores more into CABG is preferred. The importance of heart team approach was first came from this trial. Now coming to the Freedom trial, in diabetic patients CABG was much better than PCI when primary endpoints and death were CABG group. But there are some loopholes in the Freedom trial. The mean Syntax score was high in this group. The Syntax mean was 26 plus 8. ACS and PES were used. We have not used EES in this trial. LMCA were excluded, and so on group PCI and pledlets are there. Now the interesting thing, the Syntax 2 study. What we have done, the critical say that cardiology to put the goal. But is it really so? Here we have beyond Syntax, we have included variants like age, creatine clearance, LVS, vessel disease, CVD or LA, gender, COPD, and PVD. And then we have assessed the total group, patients were selected by heart team confirmation, and the Syntax score 454 patients were selected. Over a period of 1 year, this cohort was compared to the PCI cohort and the previous Syntax CABG cohort. What we got is that the MACE was much lesser in the Syntax 2 cohort compared to the Syntax 1 cohort. Similarly, the Syntax 2 MACE events were almost similar to the CABG of Syntax. This we could to conclusion after 1 year of the Syntax 2 study that improved PCI clinical outcomes at 1 year was the Syntax 2 strategy, and non-inferiority of PCI was as compared to CABG where the Syntax 2 strategy is followed. Coming to an interesting trial, the ischemia trial. Some critics will say this is the last nail in the coffin of PCI for stable ischemic heart disease. Is it really so? In this trial, it was proven that the cardiovascular death for angina and heart failure was not prevented by intervention. Look at this red line over here. The red line was above the blue line because there were more incidents of procedural LMI. As we go ahead at 4 years, the red line comes much below the blue line. In fact, we will have to wait for another 4 to 5 years to study the ischemia cohort or refute our findings. There are some limitations of the ischemia. LMCS stenosis excluded recruitment, limit enrollment of more symptomatic patients were there. 35 patients did not have angina, 26% crossover in the OMT group, and unacceptable angina at baseline were excluded. So the recent evidences of late intervention. First, coming to Excel trial. Excel trial involved patients with Leadman coronary disease with low and intermediate Syntax score, and they treated the patients with colchicolium-based everolimus routine stent. What we found is the similar rates of primary endpoint of death, stroke, years observed, which was compared to CABG. And so PCI may be considered an acceptable if selected patients with left hand. But what happened is that a few years the Nobel published showed except for in both the groups, the incidence of non-procedural revascularization and MACE were more in PCI. There are some subtle differences between the Excel and the Nobel trial. Whereas Excel trial included with low and intermediate Syntax score, Nobel trial included all the patients. So basically, they had also included high-risk LMCA patients as well. Another one was that they used bioluminescent eluting stent in the Nobel trial, as everolimus eluting stents were used in the Excel trial. So, how do we approach our patients? Because it is for CCHA criteria in specific disease. Basically, 3 groups. Appropriate care score is between 7 to 9. Appropriate care when the score is between 4 to 6. And rarely appropriate, the score is between 1 to 3. The variables are symptoms, whether the patient is asymptomatic, it is class 1 or class 2, or it is class 3 and class 4. And then we do non-invasive risk assessment, whether the risk has been low, intermediate, or high, whether it is getting medical therapy or not, on anti-anginal, whether the patient is anti-anginal, and coronary anatomy findings. I'm not going into details of this. Just I want to stress that high-risk patients are those who have severe LV dysfunction less than 35%, than 10%. Findings including more than 2 mm depression and TNT, induced LV dysfunction of more than 10%, and stress-induced LV dilatation. Not going into the disease, just one share is that is appropriate score. Whether the patient is symptomatic, whether the patient is having ischemic symptoms, then whether the patient is on anti-anginal medication, whether it is on 1 anti-anginal or on 2 anti-anginal. Then we paired the low in the risk findings with the low risk, intermediate risk, and high risk. And based on the artery involvement, we get a score. This is the appropriate score.
Hello.
Okay. Dr. Bapatya, sir, lost his connection.
Okay. I think, so should we move on to the next one because it may take time?
He joined back, sir. He joined back.
Great.
Okay. He joined back.
Just 1 minute. Wait a minute.
Also, his internet connectivity is very poor from doctor's side.
Well,
Raghu, please technical support, please.
Yes, sir. Yes, sir.
Yes.
We can see the slides.
Yeah.
But we can't hear him.
Sir, actually, the internet on his side is very poor. That's the whole problem.
If he turns off his video, the internet connectivity will be better.
Yes, sir.
Okay,
We did already.
Am I visible?
Yes, yes. Please go ahead.
Okay. So this is how we can select the patients appropriate or inappropriate. Now coming to just no presentation is complete without the guidelines. Just I would like to stress a few lines about the guidelines. What does the ESC guidelines say? As per ESC guidelines, the patients with 1 or 2 vessel disease without proximal LAD stenosis, PCI is a class 1 recommendation and scores ahead over CABG. For patients with 1 or 2 vessel disease with proximal LAD, PCI and CABG scores same. Lead-main disease with syntax score less than 22 and 3 vessel disease with syntax score less than 22, PCI and CABG scores same. For other patients, CABG scores over PCI. But the ACC/AHA guideline is somewhat stringent over PCI. As per ACC/AHA, the CABG should be preferred in all patients of left main. We can go for PCI when the syntax score is less than 22, or we can go for ostial or trunk left main LMCA. And where the STS mortality is more than 5%. One interesting point here is that when there is 1 vessel disease without proximal area involvement, the ACC/AHA guideline states that CABG or PCI is class 3 indication. In conclusion, I would like to state that myocardial revascularization in stable ischemic heart disease is a thoughtful, transparent discussion of all potential treatment options. Full disclosure of the anticipated benefits and potential risk of each procedure should be explained to the patient. Heart team involvement should be done in selective cases, and the patient preference should be taken in all cases. Individualizing the treatment option is the only possible point. Thank you.
Okay.
Great. Yeah.
Okay. Thank you very much, Dr. Kumar. Now, please stay here. We will discuss at the end. Yeah. Can I request Dr. Prakash Hajra talk on the cardiological point of view, that limb-men's arena role of intervention. I think he will speak on the how to overcome the complex LMC by intervention. Dr. Hajra, please.
Yes. Thank you, sir. And
he's our organist secretary and the head of the Department of Cardiology, Amrita Kuria.
Right. Thank you, sir. Can you see my screen and audible?
Yes, yes.
So, friends, this is the timeline of left-main science. So far, we know from 2008, Lehman's, 2009, Isar left-main syntax came, almost 11 years ago. Then Goodyear came, pre-combat, Isar left-main 2, Bestral, excellent novel came in 2016, and DK Cross came in 2017. And probably we will be seeing EBC left-main in 2020. The recruitment has been completed. In the last talk, we have learned about different trials and recommendations. This is my view on different trials on left-main. Syntax originated from US and Europe, 2009. And it's a trial between the horrible stent, the Taxus, and it's obsolete now. And the randomization was done between a horrible stent and a good surgery. The number of stents, 4.6, and the length was 86 millimeter. And the 2 stents data are not available. Then Isar Lettman from German Heart Center, cell from different countries, almost 17 countries. The change was in the stent technology. The DK Cross, etc., came much later on. But the intervention has improved, but the surgery has improved a little bit, not to that extent. And the number of stents has come down from 4.6 to 2.4, and the length has also come down to 49. And number of 2 stents data are not available, and the I was used was 75%, unlike very rarely used in syntax. EBC left main, and they have used 6 millimeter criteria, and they have included FFR. Second, Onyx versus provisional stenting And in the pre-combat-based Irishman DK Cross, Giants versus the Chinese stent, Firebird, Resolute, and I was used only 43%. So those kind of deficiencies has been overcome in optimal UK, but because of the COVID, the recruitment was a problem. So ideal left main or EBC left main will answer this lacuna of each trial, each trend, each strategy. And the novel trial, biometrics, 89%, sorry, you cannot see this. And all these trials are based on very faulty classifications, outdated classifications of left main in 2005 by Alfonso Medina. He proposed in 2005 in Budo, and the size is not considered, whereas the ABCD classification, new classification, the size is considered. You get A and B. If it is more than 3.5, you get capital A. If the LED, left main is usually not less than 3.5, you always get A, capital A, and small circumflex, you get small a, B, or C, and trifurcation and quadrification very often come across in day-to-day practice where this has not been classified in Medina, but this has been considered in ABCD. The dominant sometimes is a large circumflex and small LED, unlike the conventional angiography, is not considered in Medina and Syntrax trial, but it is being considered in the ABCD. There are 7 possibilities here. There are many possibilities in newer classifications. So it raises some questions. Do you think that the left main guideline is recommendation is based on a large randomized clinical trial? No, never. It was based on subsets of subsets. So it is hypothesis generative only. Do you think Syntrax trial is a pure left main trial like Excel and Novent? Never. It was a trial for left main and triple vessel disease. And as I mentioned, it was ugly stent, and the good stent is your Resolute, Excel trial Giants, and maybe for ultra-thin stents in your future. Do you think there is a transatlantic alignment of left main recommendations in the guideline? No, never going to happen ever, because every patient is different. Every country has their socio-political inclinations of guideline or influence on the guideline. And Syntrax trial in 2009 crossed very easy margin, easy hurdle of 6.6% non-inferiority. So easier to prove that one way of therapy is superior than the other way of therapy. So if I'm asked to redesign left main strategy in 2021, I will consider lower inferiority margin from origin of 6.6%. And I randomize each patient on the Syntrax score, low and high. I will also reclassify them on CT-FFR, IFS, OCT, or IFR and FFR, rather than on angiographic classification in Syntrax trial. I will have 2 into 2 factorial design. The 4 factors will be high and low Syntrax score, 30 and more than 30, PCI versus CABG. I use 4th generation stent, hot, final kissing balloon, non-neck branch entry is mandatory. I will also include all comer patients and remove the controversial Excel Nobel debate, surgery PCI. The MI endpoint, the definition of MI is the bone of contention in the debate. Replacement of another mesh point like TVR with myocardial ischemia, because TVR cannot be put in the same page with a hard event like death. So that is actually diluter. And this is Syntrax 2 2020. We look for newer design of the stent. This is Megatron. So these newer stent can be inflated up to 6 millimeter. Onyx 4 can be inflated up to 6 millimeter, has been published last week and has been mentioned by all the authority that it can go up to 6 millimeter without any problem. And we also come to know that DK Cross is the best thing to do in left main bifurcations. But it could not cross class 1 recommendations in the European guideline for provisional 2 stent or provisional 1 stent. So it originated from one country 6 operators, 7 centers. Still, it enjoys class 2A recommendations, much inferior recommendations. Though it is much more complicated to do than the provisional stenting, still holds ground because of long-term efficacy and safety and the myocardial infarction rate and TLR. Sometimes we come across kind of trifurcations. You have to understand that each and every branch is very important. You have to protect by putting it where it may be quadrifurcation sometimes. So any branch more than 2.5 millimeter, 73 millimeter in length has to be preserved because it supplies more than 10% of myocardium. Now, definitions of side branch, length of the side branch also varies from trial to trial, and you'll be surprised in the DK class or definition trial, the side branch length is to the tune of 16 to 20 millimeter, unlike many earlier trials. So these flow dynamics are important. You can go for any kind of technology or strategy, but this flow, newer thoughts of flow dynamics is very important because most of the time, the restenosis comes at the circumflex ostia. So this is a zone, a Bermuda Triangle. You try to avoid this Bermuda Triangle, a stent in the circumflex, as long as possible, as far as possible, by using these POVA, by FFR, IFR, OCT, IVUS, by interrogating these lesions. And in 2020, if you really want to do a good left-main stenting, if you want to compete with surgery, you have to go for distal crossing and you have to go for this link-free type of stent, the cell at the side branch. And you can push this link to the other side by having 3D OCT in your lab. So link-free crossing is very important for TLR. So TLR is the dampener in most of the trials in circumflex left main. It is the circumflex which is usually a dampener because most of the time the restenosis comes at circumflex. So you have to go for link-free type and you have to have this kind of technology in your lab. So this 3D OCT in our lab, we have crossed after putting wires and we have replaced or repositioned the distal crossing. And sometimes the left vein ostia is a difficult one. And left vein ostia also can be imaged by newer technology, newer tips. Now, if you have the guide liner, the tip of the guide liner is transparent in last 2 millimeter. So you have to use a guide liner if you're contemplating to do OCT in left vein ostia. Otherwise, you can go for the IVUS intravascular ultrasound. So this tip you can use for imaging of the left vein ostia. Now the bone of contention is this difference. And this 4% difference is based on some long-term result of syntax trial. But based on the average treatment effect, should you send all patients to surgery? The answer is of course no in my lab. Now what does that mean, 4% difference to a patient? As per the 10-year death from 28% to 24% in all this trial, the delta of 0.4% per year means NNT 250 to save 1 life at 1 year, NNT 25 to save 1 life at 10 years. So out of 25 patients, you have 1 patient which is outlier, but 24 patients, there is hardly any difference. So ladies and gentlemen, to conclude that PCI or CABG should be a precision medicine and a discussion between patient, doctors, surgeon, and the cardiologist. And most of the time, one of the contender don't think about the patient. It can be cardiologist, it can be surgeon, and it can be yourself. So it is a team approach, but do the right thing, do always the right thing, always do right. This will gratify some people and astonish the rest. Thank you.
Thank you, Dr. Hajra. You have brilliant exposition of what you feel on MN STEM. Please stay here. We discuss at the end of the session. Next speaker, Dr. Akhtar Khan. He talk on revascularization strategy, elderly frail patient. Dr. Akhtar Khan is the dynamic interventional cardiology, Apollo Hospital, Calcutta. Dr. Khan, please.
Yeah, thank you, sir, for your kind words of encouragement. Can you see my slide, sir?
Yes.
Okay. So I've been basically told to talk about the revascularization strategies in the elderly frail patients. And after the last two talks by my esteemed colleagues, but things are a little bit easier, but I'll try to be a little quick over this talk. We all know that we are all facing a growing population of elderly patients. And I think this happens not only in the US, but also in our clinical practice. The only problem is that how do you define an elderly? Well, the WHO calls it more than 60. Most of the US classifications call it more than 65 plus. And the Grace ACS registry of the acute coronary syndrome that had considered more than 70 as an elderly patient. But I think we all are agree that whatever, whether it's 60, 65, 70, we all know that elderly patients have certain problems, and this includes the coronaries as well as the peripheral arteries. And the coronaries, we know they have calcium and they have tortuosities and they have impaired endothelial function. And there's also ventricular dysfunction or stiffness of the ventricle with increased LVEDP and diastolic dysfunction that sets in, when you're treating these elderly patients. And not only to the coronaries or the heart, but there's also a problem when you're giving polytherapy to these patients, because we know that they have often renal problems. They often have this polytherapy, which affects the liver, and the liver functions may not be the best. They often have GI problems. And also we know about this increase in the lean body mass, or the reduction in the lean body mass that could affect the dosages of drugs that we use in these group of patients. When it comes to coronary artery disease and the issues of management of elderly patients, we also tend to have a lot of underutilization of diagnostic tests. We tend to believe that these patients are not going to benefit. Drug therapy also tends to be a little skewed, because we tend to more worry about the side effects of the drugs. We worry about the cost of the drugs, and overall, these patients are subjected to less of invasive therapies as compared to the young patients. So when it comes to considerations of coronary artery disease in adults, I think we all agree that when it comes to presentation, the presentation is often atypical. They may not have the typical chest pain. Nausea, vomiting, weakness could be the presenting symptoms in these patients. The management of ACS is also very different. Invasive procedures are often not given to these elderly patients with the concern that they may be not able to tolerate these procedures, or they may have more side effects, though we know that from the various trials that we'll be discussing, this may not be necessarily true. Drug stents are often not given to these patients with the concern that they may not be able to take a dual antiplatelet, but there's no data to say that DS should not be given. And in fact, it is preferred over the BMS in this group. There is definitely a concern about concomitant DAPT or even triple antiplatelets when these patients have atrial fibrillation. And we'll also talk in brief about aortic stenosis, which often coexists with these patients with coronary artery disease. And another important factor is the frailty that happens in these patients. So having an elderly patient is one thing, and having a frail patient is another thing. And frailty does tend to affect the outcomes. There are certain frailty stratification scores that one often uses, such as the Fright class score. But again, in-hospital mortality or in-hospital procedural outcomes are not really different. So when you look at the frailty also, there is similar to complication rates as compared to non-frail persons. It's only when you talk about an invasive procedure, which includes surgery, whether it's a valvular heart disease or a CABG, one is important to consider that the frailty index is also considered. So this is one of the classifications of the Fright criteria that is often used, where you talk about one of those 5 parameters, either weight loss, reduced grip strength, difficulty in initiating motion or movement, or a walking speed which is slow, or fatigue, and then you classify them into whether they are fit or they are very frail. And this sometimes is often used when you are treating patients with sending patients for surgical interventions. This is one good paper which was published in 2018, which looked at coronary artery disease in elderly patients more than 80 years. And again, something that we've already discussed, we often classify risk factors based on the conventional CAD risk factors. But what we are not able to manage or to classify or look at, assess, is often the oxidative stress or the dysfunction, endothelial dysfunctions that these patients may have. Again, we look at other things. We look at structural heart disease. We look at acute coronary syndrome or stable ischemic heart disease. But sometimes these other factors, such as dementia, frailty, social support, these are often not assessed. And again, we know that we have problems in elderly when you're treating either with the guideline-directed medical therapy. Their adherence may be less. They may not be having support system at home to give them the drugs. When it comes to PCI, we already discussed contrast nephropathy, bleeding complications are higher. And when it comes to CAB, it goes without saying, recovery, post-operative procedures, as well as intraoperative procedures tend to be a little more difficult in this group of patients. Another interesting observation that we've observed is that when you look at STEMI versus non-STEMI and unstable angina, The younger age group tend to have more of a STEMI. When it comes to the elderly age group, rather than the STEMI, they tend to have more of unstable angina and non-STEMI, which again indicates that these patients often probably develop collaterals over a period of time. When it comes to STEMI in elderly, the common feature, as we said again in the beginning, is that they have atypical presentations. Their baseline ECGs may sometimes make it difficult for us to understand what's happening. Left bundle branch, which is pre-existing, may sometimes mask an acute myocardial infarction. They tend to receive late treatment because they're often, based on the frailty and presentation, they often do not get either thrombolized or they do not undergo primary PCI especially. And we know that invasive cardiac therapy, which is known to benefit, in fact, that's one of the only therapies which is known to have a mortality benefit in an intervention. Well, we know that these patients are often denied this therapy. We had this data from the earlier group, and this was the Netherlands group, which has looked at the elderly reperfusion therapy. And when this compared the streptokinase versus angioplasty, recurrent MI was much more significantly commoner when thrombolysis was used. And even the overall survival, whether it's at 2 years, was much better when patients underwent primary PCI rather than being subject to thrombolysis again. And again, the survival free of reinfarction was again over a 2-year period, much better in the elderly also when primary PCI was done. Well, doing the procedure also, I think all of us have realized that there are certain problems. Transradial is definitely preferable to a transfemoral approach because the risk of having hematomas and pseudoaneurysms in these often elderly patients. But again, even a transradial approach has problems. We know that the tortuosity of the arms, getting the patients to help us to take deep breath and all can be a little difficult. But again, you have these procedures. You can use a balloon-assisted tracking to get your balloons and wires across even the tortuous forearm arteries. Complex PCI, again, because of the fact that we are on antiplatelets, anticoagulants, in an elderly, it's always better to use a femoral, a radial approach. But even though that we know that the radial approach has certain technical sort of problems in elderly, the radial arteries tends to be the forearm arteries tend to be more tortuous and calcified. But again, this is something that has been conclusively proved that a radial approach definitely is preferable. What type of stent? Well, again, old age should not just be the sole reason for preferring a BMS over a DS. One needs to look at other risk factors of bleeding to decide whether one goes for a BM metal stent rather than a DS. But old age alone should not be a reason for us to deny a patient from getting a drug-eluting stent. We also agree that, well, dosages of anticoagulants and drugs need to be properly modified, especially when you're using a GP2B3A also. And many patients in this the trial that we talked about in the CRUSADE trial, in fact, got an excess dose, especially when they were in the elderly age group. Coming to antiplatelets, well, we know that the Triton 38 had shown an improvement of benefit of prasugrel, but then again, this benefit is restricted to the younger age group. So in the elderly age group or patients who are less body weight, one stays away from prasugrel and still sticks to clopidogrel. There has been a concern whether we can use ticagrelor in this group of patients, and a large meta-analysis has shown that yes, ticagrelor can still be given in the elderly age group with the additional benefit that we get without the risk of the bleeding, and therefore just the age itself should not be a reason for withholding a potent P2Y12 inhibitor such as ticagrelor when you think that the ischemic burden is going to be high. There's another paper, which is the Popular Age trial, which has said that we have looked at plateau to say that ticagrelor should be used over clopidogrel and ACS. But the Popular Age trial, which has basically looked at more of the 75%, more than the 75 years age group, has still said that in patients who are frail, for example, even if they're elderly and they're frail, clopidogrel still remains a good choice. So I don't think so we should throw clopidogrel out of the basket when just because you have ticagrelor. And in a patient who has a low ischemic burden with a high bleeding risk, we still could go with clopidogrel. So finally, it comes down to being the benefit versus the risk of bleeding versus the risk of thrombosis. Unfortunately, most of this would have an advanced stage, both as a bleeding risk profile as well as a thrombotic profile. So both of this would be there in the advanced age group. We have these scoring systems, the DAPT scores, for example. A score of less than 2 would mean that you would probably give a shorter duration of dual antiplatelet, whereas a score of more than 2 would mean that you would continue or do DAPT for a longer period of time. And you have these other bleeding risk scores. For example, this is the CRUSADE risk bleeding score, and you have the precise DAPT score. So all these scores, for example, for us, they are online, available on the apps also. So you could download them on a mobile, or you could do an online scoring system and decide whether a patient has a high bleeding score. Unfortunately, most of these bleeding scores look at the bleeding aspect of it, and they not look at the ischemic aspect so much. Cardiogenic shock in an acute coronary syndrome, again, we know that elderly patients have the high risk of being withheld a PCI, and many of them, they are not subjected to a primary PCI, especially if they are in cardiogenic shock. But we had this Melbourne group, which had reported this, this almost a decade old. And when you look at the survival, in fact, the elderly group had a freedom from death or a survival, which was as good as the young people when you had a primary PCI done in patients with cardiogenic shock. The shock trial did not really involve a lot of elderly age group patients. The other problem is that when this elderly age group patients with primary in cardiogenic shock, access of balloon pumps could sometimes be a difficulty. So even the Impella and all can be a difficulty because you have tortuous femorals. You have these alternative routes. You could go probably from the axilla, and this is one artery that is often spared the atherosclerotic process, or you could also go from the brachial approach. So these alternative approaches need to be sort of looked at when you're putting in a support system. ECMO is often a contraindication for elderly age group, but this is a relative contraindication. And we now have sort of data to say that this should not be one of the reasons to deny a patient an ECMO. But of course, as I said, we don't have dedicated trials in elderly age group for primary PCI, and one needs to make a decision based on the clinical subject. Non-STEMIs, of course, we had the GRACE registry, which was the largest trial. Again, when it looked at young age group patients less than 70, well, in this trial, young was classified as less than 70. Intervention, without an intervention, patients who did not undergo an intervention had a worse outcomes, whether it was the young age group or whether it was the intermediate 70 to 80 or it was the elderly age group. In all the groups, intervention had a better outcome as compared to no intervention. And this is the in-hospital outcomes. When you went to the out of or a 6 months outcome benefits, again, 70 years, 80 years, or more than 80 years, intervention or an invasive approach for a non-STEMI had a better outcome as compared to a conservative approach for a non-ST-ACS. Again, the FRIS2 trial also told us the same thing. When you looked at an elderly age group patients, conservative versus invasive, the invasive arm had a lower outcome in terms of events as compared to the conservative arm. Again, this is one more paper which looked at, this was the Norway paper. They looked at 30 days and 7 year survival periods, and they said that revascularized periods, patients had a superior long-term outcomes. So coming back to PCI for non-STEMI and unstable angina, an invasive approach still remains a better approach in elderly patients, and they should not be denied this approach. This is a little busy slide, but I just got this here to decide about the approaches in patients with invasion. And when you look over the years, 2001 to 2017, the last ones, and we look at the age of the patient, these are all 80 plus patients, and this the mean group of the age of the patient was 80 plus. Again, with this group of patients, what has been found is that invasive approach had reduced mortality, fewer major events with invasive approach, and older patients also had a mortality benefits with revascularizations. So non-STEMIs, we still have a benefit which goes in favor of an invasive approach. Coming back to CABG versus PCI, we've had a lot of discussions already in the last two talks. Just to finish it off to say that when you look at the last recent two trials, the Nobel and the Excel, he's already spoken about this in the last talk also. Dr. Hazard had already spoken about this. The Nobel and the Excel, well, we had two divergent things. Nobel, which told us that there's a little benefit of CABG over PCI. Excel, which said that there were similar outcomes. So again, this was the Excel trial, and they again suggest that we should have a heart team approach. But it just suggests that age need not be a factor in deliberations while selecting CABG, and one should not just exclude a patient from a bypass surgery just on the basis of a CABG. This is what it is. These are two elderly patients, and both may look equally old. But again, I think we all realize we need to look at the frailty index. We need to look at their comorbidities to decide to subject which one to an intervention and the other one to a non-intervention. This lady may look very thin, but she may not be as frail. And this lady who looks apparently healthy may have more comorbidities. So it is not an eyeballing, but I think we need to look at more parameters. Again,
I'm sorry.
So this is the last slide. Yeah. So
last slide.
Yeah. So what we need to understand is that we need to look at future things towards looking at the non-invasive imaging data. We still need to look at the optimal dosing and duration. Medical therapies, we need to still look at the use and safety of the various drugs that we are using. And again, as I said, we need still to look at more trials, which especially in the elderly age group, to decide which of these would be more favorable for this group. And thank you for your patient hearing there. Yeah.
Okay. Thank Dr. Khan for excellent presentation, making the difficult cases treated the very simple way, and we'll discuss it then. Please stay back with us. And then next, the last speaker, I think, the session, Dr. Sumanand Rai, he talked treating the severely calcified coronary disease. He discussed the technique, how to resolve the problem of calcium. Dr. Rai is there?
Yes, sir. Doctor is there.
Yes.
Sorry, sir. Sorry, sir.
Is my slides audible, sir?
Yes.
Yes, sir. Yes, sir.
Yeah.
Kindly change to slideshow.
Doing that.
Yes. Perfect.
Thank you. And at the outset, it gives me a lot of pleasure to see all my seniors and teachers of DM course is still running safely and kicking now nicely. Dr. Monotosh Paja, Dr. S.S. Chatterjee, and Dr. A.K. Kaur, and Dr. Kahali, and all my friends. And also, I express my gratitude for giving me a chance to talk before you to Dr. Jayanta Shah, who is an excellent cardiologist and an excellent human being. So, my topic is how to optimize results in calcified coronary arteries. And you know that all of us who are doing intervention, we know that coronary calcium is a predictor of worse prognosis even after PCI with DES, because the coronary calcium is, when there is a severe coronary calcium, then it is very difficult to track the device to the right place. And sometimes during the push and pull, the damage of the device can occur. The polymers can be damaged. And also, if it is very difficult to expand the stent nicely in a calcified lesion, and most of the cases which are not quite expanded, the stent is not quite expanded, the results are really bad. So it is seen in this slide, it is seen in the 7 DES trials, it is seen that when there is a severe calcium, about 1/3 of the patients come with MAC, and MACE or MAC, whatever you call it. And so it is a very important prognostic factor for a PCI with DES. So next, also, it is not only in stable coronary artery disease. If you look at the ACS population, where we need to do something very fast in the wake of an angina or a primary angioplasty, there also, if you look at the MACE and the presence of severe calcium in the coronary arteries is responsible for a MACE of around 20%. So calcium, in one time when POBA was there, and one time when the initial stents were there, calcium was a contraindication to angioplasties. But still, in the era of DES and PCI in full bloom, still coronary calcification is a main prognostic factor for betterment of the therapy. And also, as we are tackling increasing amount of complex coronary artery disease, and we see that we are getting more amount of calcified lesions, and it is seen in when we started in 1999 or something in the first of millennium to 2018, we will see that around 1/3 of the patients, maybe no more, 1/3 of the patients are getting complex coronary calcification. So with that in mind, we need to see that how we can diagnose and how we can assess these calcified lesions. We all know that when there is a calcium, our routine armamentarium, there is a coronary angiography, slightly underrated. So we always need an imaging, and of the imaging, the newer imaging modality, which is called OCT, it's better than the older modality, that is IVUS, to diagnose calcium. Why? The OCT can give you an extension of the calcium and how much the length of the calcium, and also the width of the calcium, whether it is deep, whether it is superficial, or whether it is nodular, and also the width of the calcium. So calcium, the best modality, if I am asked that what is the best modality to diagnose calcium and best modality to fix whatever device is required, whatever strategy is required, OCT would be the best device. And depending on that, we see that in OCT, we can diagnose superficial calcium. If it is a severe superficial calcium, we need an ablative therapy, as well as nodular calcium, which is protruding inside the lumen of the coronary arteries, needs an ablative therapy definitely. But in otherwise, you can use a lot of conventional devices like LC balloons, like Scorin balloons, and other things. So this is a picture which shows a deep calcium. There is a significant fibrotic lesion in the coronary arteries, but along with it, there is a say around 90 to 120 degree calcium, which is in the media, and also that there is a very thick calcium. So all of them can be assessed by OCT. And this is non-luminal calcium, and this type of calcium, when it is present in the media, even it is all over the media, it is just like a Monckeberg sclerosis. And if it is not associated with any superficial narrowing of the coronary arteries or narrowing of the lumens, you can leave it as such. Or if there is a significant lumen obstruction by a fibrotic lesion, by other things, you can go for normal devices like NC balloons and scoring balloons, cutting balloons, and you can optimize your plaque modification and can go ahead with stenting. But if there is a calcium which is protruding inside the lumen, and as you see, there is a calcium promontory, just like a hill. It is protruding inside the lumen. It is really a difficult subset, and you need an ablative procedure to, cut the calcium and remove some part of it so that the stent can be expanded nicely without any optical and without any asymmetrical expansion. Next is a superficial calcium, and the length and width of the superficial calcium again can be assessed nicely by OCT. And if it is seen it is a very thick calcium, you need to crack with a ablative procedure like either rotational atherectomy or the newer device which is called orbital atherectomy. And after that, you need to see again by imaging that how much of calcium it has cracked, and whether it is possible to open with a balloon, or whether you go for another device to crack the calcium and open the area nicely. So next is the main and how we start then. Should we go for imaging in all cases? No, it's not possible. Why? Because initially you need to assess from the coronary angiography, which is the main data and which is the main tool in all of us and all cath labs. And it is seen that if you have a mild coronary calcium, which is often missed by angioplasty, which is often missed by coronary angiography, non-atherectomy strategy would be sufficient. But when there is a moderate calcium, we need an imaging, and then you can go ahead and do your procedure. But in severe calcification, you need something. And how you know that whether it is a severe calcium or a moderate calcium or a mild calcium? If you see that there is a very good paper which was published in 1995 by Gary Means and others, and they have shown that if there is a significant calcium on both sides of the arteries, which we call tram track calcification, and it is evident both in systole and diastole and irrespective of the cardiac motion, and this is severe calcium, and there is a 93% sensitivity and specificity to imaging. But when this type of calcification is only found during cardiac motion, not found without cardiac motion, these are moderate calcification, and there you need to image. And if your imaging catheter goes, and then you can image it, and you can have your decision. And mild calcification is usually not demand an urgent IVAS or OCT or any imaging modality. You can go straight away in. But we have already said that the mild calcification is often missed, so it is better to go with a balloon and see whether the balloon can go nicely to the lesion, and at moderate pressure whether it opens. If it doesn't open, and if there is if it doesn't go, then you must be needing a device like ablative device to pave the pathway. So what are the options you have to prepare the bed? Because the bed preparation is absolutely important. The most important is NC balloons and cutting balloons or scoring balloons. And they are they can expand, and in the cutting balloons and the angiosperm plus scoring balloons, they can score and they can crack the calcium, where the NC balloon during high inflation pressure, they can crack the calcium too. And besides these, there are two ablative procedures, the rotational atherectomy and orbital atherectomy, and laser which is used in 1%, and we do not have any experience of laser here. And also the newer device, which is called IVL or intravascular lithotripsy. So I can go to a angiogram, and you see that there is no doubt the arteries are calcified, and particularly the area beyond the lesion. This is an acute coronary syndrome. So we thought that we could be access the lesion with a NC balloon, and probably would be enough to do the procedure. So we started doing the procedure. Firstly, we used an NC balloon to open the LED, then the LCX, then we used a scoring balloon to open the LED, and ultimately we could finish the case with 2 stents, and it is a pristine result. So again, then what is a rotational atherectomy? And this is a very naive presentation, because everyone probably knows by the time that what a rotational atherectomy is. And you know that the rotational atherectomy is there is a rotawire on which a rotabar is placed in the coronary arteries, and it is a metal bullet which is studded with diamond chips in its distal end. And when it rotates in a very high speed, and then these are diamond chips, pulverizes the calcium, and the calcium dust, which goes to the distal vessels, is collected by the macrophages later on, and by the time it moves in and out the calcified area, it can crack the calcium, and then it becomes, the artery becomes amenable to dilatation by balloon. So this is the console, which is connected with the electrical current and also connected to a pneumatic drill, and the high air pressure or nitrogen is necessary to remove the bar in a very high speed. And also, but the mechanism of action is very unique. So it has got a differential cutting system, just like a shaving blade. When we shave, the blades cut the beard, but not the skin. That is the reason why the tough and calcified areas are cut, but the bar is pushed out towards the tough segments by the normal elastic vascular tissue. And when the bar moves in a very high rotation, there the friction, which is faced by a balloon. When you push a balloon, the friction is faced, but when the bar rotates, it can minimize the frictional forces and can go in. So the bar movement should be very slow, and it should be slow picking movements, as we call it. It will go, touch the area and come back, and gradually by that it will move a very slow fashion and cross the lesion. And initially, when rotational atherectomy came in 1990s, there was total debulking of the calcified area, and which we used to have by a larger bar. Now that the technical considerations came of plaque modification, where we use a bar much smaller and in the tune of 0.5 to 0.6 bar to artery ratio, and with this rotational speed much less, from 180 to less than 160, and by that, using a single bar, you can score the calcium or crack the calcium. Then you use probably an NC balloon, or in some cases a scoring balloon or a cutting balloon to prepare the bed. So in that way, we could have reduced the complication of rotational atherectomy, as well as the long-term MACE and long-term benefits were much. And it is seen that initial trials, like Rotaxas trial, there was a restenosis rate of around 30%, which has come down to less than 10% in the recent trials. So it is all with the concept of plaque modification and use of BAR as a cracking agent, and then using something to complement the results. So we can go to a case. Here there is an artery which has got a acute coronary syndrome and showing there is a total occlusion of the circumference, which was done. And then it was also seen that there was a very significant lesion in the RCA. And this RCA, if you see that it is almost a stent-like calcium, and there is no doubt it is a very severe calcium, and no balloon could pass. And so you put a rotational rota wear, and on top of that you do a rotational atherectomy, and you see the movement. It is called slow picking movement. We are touching the area and going back, very slow, touching the area and going back is called slow picking movement. And with that, we could cross, and also there is a lesion below. We could cross the lower lesion too. We could cross the lower lesion too, and then with a small balloon, we could open both the areas and put 2 stents, and finally there is a stent, or there is a result just like this. So it is not a very difficult procedure. It is an easy procedure, and also if you are slightly cautious, you can avoid complications, and you will have a good result. The next kid on the block is called orbital atherectomy. There was 2 problems of rotational atherectomy. As you know, that the rota wear is very thin, and it's a non-torqueable wear, and it is a stainless steel wear. Whereas, while it is very difficult to manage the wear sometimes because it is liable to be kinked, and also the rota bar, as I shown you, that the rota bar is just like a metal bullet, and it has got a diamond coating only on the distal end. So sometimes it can go in and cannot come back, and we call it a stuck bar. And once there is a stuck bar, it is almost a difficult procedure, and sometimes it goes to the operating rooms for CABG. So for the reason they came with another device which is called orbital atherectomy. And what is the orbital atherectomy? The wear is different. It is not an unforgiving wear like rotational atherectomy. Its wear is much high, robust. And also it is just like your ring finger having a diamond ring on it. So it is a diamond ring, and the whole of the ring is studded with diamonds, and it moves. So that when you move your ring finger within a ring, you see that there will be always an oblique motion and elliptical motion. And for that, this is an elliptical motion in the coronary arteries, and always it cracks the coronary in a jackhammer fashion, as if is a jackhammer is placed on the corners of the calcified plaque. And if you see the device, it is just like that. I told you that is the ring. It is your ring finger on a ring on it, and when it moves, it is an elliptical motion. So it can have an asymmetric opening. So once, and also there is a very important point that you need not, in rota, you need to sometimes upsize the bar. One bar is not enough sometimes to give you a good pristine result. But here is only one device, one bar you can call it, and this bar can be placed in higher. If you place it in higher rotation, there will be higher lumen enlargement. So if you try it in 80,000 and you see that there is not much of good lumen in the artery, you increase it to 120 and you see that you have a good lumen. But also you have to remember that this is an asymmetric movement, and for that, if there is a asymmetric calcium, if it is not in concentric calcium, there is a high chance of perforation. And you see this device, it is almost like this, and when it rotates, it can hammer the calcium and crack the calcium. And again, the setup is very, it is not like rota. It is a very simple device. It is just like this, and it is only have a knob, and your duty is to move the knob up and down. So it is very easy to set up. So what are the differences between rotational atherectomy and orbital atherectomy? As I already said, that it is a orbital atherectomy is a very quick setup, and is usually there is a less slow flow and no reflow, because always the calcium ducts are very thin, and there is less need of pacemaker, and a single device is okay for all the lesions, and it is excellent for the larger vessels with heavy concentric calcium. But rotational atherectomy is important in some of the areas, as for example, aortosteal lesions where the orbital atherectomy does not work, and also very angulated lesions, the orbital atherectomy will not work. There you have to depend on your rotational atherectomy. And in lengthy lesions, again, rotational atherectomy is a better choice. So we can go to a...
if you just can be a bit faster, because it's already 5 minutes beyond time.
Slides. I just finished. So this is a lesion you see at the aortosteal lesion of the left main. And here is the option is only rotational atherectomy, and the orbital atherectomy does not work. And I'm not going into it. And I'm going into another lesion. So the next kid in the block is another vessel, and you see the vessel, and there is a calcified RCM with a very tortuous, distal end. Here there is a chance if you use rotational atherectomy, there is a chance of bar stuck in the calcified portion, tortuous portion. So you need another device which is called shockwave lithotripsy, and this is a balloon on top of that, which can emit sound waves and produce very high pressure inside the coronary arteries, even 50 atmosphere. And this can be done for sometimes for 80 shocks you can given, and after that you can have normal dilatation of the artery, and ultimately you can have a result just like this. So this is the last case, and also these are another case where there is a CTO. You see, this is a CTO where there is a very calcified CTO, and you could cross with the wire, and you cannot cross with the balloon. Sometimes the balloons are not crossing, even the smallest balloon. So you put the microcatheter in, and then you pass the rotational rotawire inside, and then you rotate rotablade, and you see that it's a very difficult rotational atherectomy because it's a long lesion. And after that, I'm not going into it. After that, you have a picture like this, and you open with the balloon, stent it, and this is the final result. So this is a final result. So in conclusion, calcification is a major cause of under-deployment of the stent, and calcification is often underdiagnosed in angiography, needs imaging to assess. In most of the cases, intravascular imaging is difficult to perform because of the severely calcified vessel. Angiographic suspicion will lead to device selection sometimes. If balloon could cross, try with a balloon at nominal or moderate pressure. If the balloon does not open or balloon does not cross, you select one atherectomy device. Larger vessels may require additional scoring or NC balloon or IVL. Thank you very much for patient hearing.
Thank you, Dr. Rai. Excellent presentation. I think, Subra, there is give a 1 minute time to each speaker.
Yeah. We will have 5 minutes time.
Yeah, 5 minutes time. So first speaker, Dr. Manojit Lodha. So any question to Lodha for the STMI equivalent? So he done by simple ECG at the bedside, how to predict the marked infarction and what the scope of the early detection as well as the early intervention is very important to save the life of the patient. If there is no question, Dr. Chatterjee, Dr. Kahali, any question?
No.
Okay. Dr. Chatterjee, any?
No.
Okay. Second speaker, that is the spontaneous dissection, we have already discussed. And third speaker, the revascularization, the stable ischemic heart disease. Any question, Dr. Chatterjee? Dr. Kahali? Stable ischemic heart disease. Subra? So really it is a complex situation, no? Stable coronary artery may be associated with calcium, diabetes, peripheral disease, and renal stenosis, and as well as the carotid. So that case is very difficult difficult situation, whether it is PCI or whether there is the CABG to be done. It's a very controversial subject. So many trials prove that is not be the medical therapy is sufficient. That was particularly Carriage trial. Again, Bari 2, Bari 2D, everything the medical therapy is there is no difference from the medical therapy versus intervention. Of course, all the cases, complex situation, CABG is better. Third speaker, Dr. P.K. Hajra, he rightly point out, any question to him? Yes. Sora, any question? Dr. Hajra has done that.
I have enjoyed the whole thing.
Okay, very good. Here you will explain everything. Next speaker, there is Dr. Khan is presented particularly revascularization tragedy in the elderly frail. He also very difficult subject. So any question? So I think everybody.
I would just have one question. I mean, age. I think if you look at the ARC criteria for high bleeding risk, age is a minor criteria. So if just a patient maybe a patient is 90-year-old and doesn't have any other risk factor for bleeding. What would your sort of strategy for dual antiplatelet therapy be after the procedure?
Yeah, can I take that? This is Aftab here. Yeah. So I think, as you said, during the acute procedure, I think at the time of the procedure, we really don't look at the age as a criteria, and you go ahead and do what was the best possible in terms of use of DAPT. And as you said, it's only the prasugrel that we probably stay away from based on the age that we have. Ticagrelor versus clopidogrel, I don't think so there's any choice that we have there. I think it's, say, down the line, say whether it's 7 days down the line or 1 month down the line or 3 months or 6 months or a year, that you reassess your assessment of your bleeding risks and then take a choice whether you want to continue with a dual antiplatelet and you want to switch over to based on whether you have a atrial fibrillation, whether you have a triple sort of anticoagulant along with an antiplatelet, that you decide whether you want to continue with aspirin or you want to continue with your choice of anticoagulants. So index procedure, I don't think so there's much to choose between clopidogrel and the ticagrelor, except for the fact that prasugrel probably you'd stay away from in the elderly age group. So on this 80 years old, I would still say that I would not shy away from ticagrelor if the indications still say that the ischemic burden is going to be higher.
But how long should your dual antiplatelet therapy be?
Yes, I think if you look at guidelines, then the last guidelines have told us that if you're doing it for a stable ischemic heart disease, it is 6 months of dual antiplatelet, which you could stretch to 1 year if you have a ischemic burden that is high. We put in more long stents, complex procedures, and low bleeding risks. Or you could stop at 3 months in a stable ischemic heart disease if you have a high bleeding risk. For an ACS situation, then the guidelines usually talk of a DAPT for 1 year, which you could continue beyond 1 year if you have a high ischemic burden and a low ischemic bleeding risk, or you could shorten to 6 months if you have a high bleeding risk. So I think it's the clinical profile based along with the ischemic bleeding, with the bleeding risks, along with the ischemic burden. I think one needs to take a decision based on that.
Okay, Dr. Khan, actually you are meant to say the modification of drugs in the LR is very highly well appreciated. Otherwise, very difficult to treat the patient. The one question that is when the elderly patient associated so many comorbid conditions, particularly diabetes, renal failure, perivascular disease, multiple vessel disease, carotid artery disease, you have to appropriate decision. But in spite of that high risk scores, now how much role of the PCI with so much comorbid condition? Though the guidelines avoid it, but still in the all practical experience, there's some presence of multiple vessels and the culprit lesion to be dilated and stented. What is your opinion?
Yeah, again, when it comes to stable ischemic heart disease, as you said earlier, the guidelines are pretty, we don't have enough guidelines or enough data to say whether we treat these patients aggressively or we try medical management alone. So we don't have the elderly age group enough patients treated in the stable ischemic heart disease. But when it comes to acute coronary syndrome, that is a STEMI or a non-STEMI talking about, we still have enough data to say that probably the interventional approach is better off than a conservative approach. Well, again, whether it comes to a culprit versus a non-culprit, I think we have the data coming from the other trials to say that probably staging a procedure, the non-culprit artery would make it procedure safer in terms of a long-term approach, whereas doing only the culprit and deferring the non-culprit to a later stage probably increases the risk profile.
Okay, thank you, Dr. Khan. And the last speaker, Dr. Subarna Rai, any question? He rightly point out how to manage the plaque modification of calcium. He has rightly done, and the different intervention is really how to resolve the problem. Any question on the severe calcium?
Yeah, I have just one question. If you had a scoring balloon and a cutting balloon to use for a lesion, which one would you prefer?
There's no data that which one is better. Perhaps in the PPR calcium, if you see that they used scoring balloons. And there is another study which I've seen recently that they use cutting balloons. Both are used simultaneously. I mean, equally. Perhaps there are some small points, and in cutting balloon, if you see the cutting balloon architecture, if you inflate beyond 15 atmosphere, it behaves like a semi-compliant balloon. So suddenly the size may increase and there may be perforation. So in cutting balloon, you cannot go to a very high pressure. But whereas in scoring balloons, particularly in Scoreflex balloons, and they are mounted on a very high NC balloon, so that their increase in size is usually less than whatever cutting balloon shows. So basically, if you use cutting balloon, you cannot go to a very high pressure. And there is if you go to a high pressure, there you have to assess the size. Otherwise, there will be perforation. But in scoring balloon, you can go to a very high pressure. If
Dr. Rai, the scoring balloon that is angioscalp, no, is very important, and chance of dissection will be less. You mean to say? Another question I do you. Tell me.
Yeah, is this the last question? Because we are running 15 minutes.
Dr. Paja, one question.
Yes, please.
Do you need a large luminal diameter for use of IVL, Dr. Subarna Rai?
No, sir. It is nice to see you after a long time, Anjanda. The thing is, if it is a concentric calcium and if it is a large artery, and if the balloon goes, then probably IVL is a very good technique, because it is the chance of perforation, chance of dissection is very less with the IVL.
But do you need a larger diameter artery for that?
Yeah, larger diameter artery. Say if it is a 4 millimeter artery, IVL is the answer, because otherwise you need to take at least a 2 millimeter bar, and which is sometimes very difficult.
Dr. Rai, this last question. What are the ultra high pressure? That means OPNC balloon. That is, we can tolerate the high pressures better way. What is your opinion in that view?
Sir, OPN balloon is a nice balloon, because in NC balloons, they are prepared in such a way that there is least increase in volume when the pressure is increased. So OPN balloon it does not increase in size. That is the most important, but it increases the pressure. The point is, it is very difficult to cross the lesion. Because in OPN balloon, you need to put a extra support guide wire, first of all. And then you have to push the balloon hard, otherwise it won't cross. So if you can open the artery by any device, say rotational atherectomy, and you make a passage, and then you can go with an OPN balloon. Otherwise the balloon will never go.
You can expand the balloon at the high pressure, the adversary pressure. Okay, thank you very much. All the speakers done their duty and they make their upgradation of knowledge. We are very thankful to them. All our delegates are very thankful to them. Thank you very much. End of the session. Okay.
Thank you.
Thanks.
Our next session is atrial fibrillation. Our next session is atrial fibrillation. We have our next session is atrial fibrillation. We have a guest speaker here, and Dr. Shouro Mukherjee. And we have the moderators, Dr. Abhijit Chatterjee and Dr. David Rajario here.
So, good evening, everybody. So, we are going to have a very interesting symposium here. It's a guest lecture on atrial fibrillation, entity that we encounter day in and day out. So, what is the present status of the treatment of atrial fibrillation, starting from drug to ablation? So, this will be highlighted by none other than Dr. Neeraj Jadhav. I think he needs no introduction. And because of shortage of time, I wouldn't introduce him in a big way, but it's over to you. The slide is invited for slide sharing. Okay. Dr. Yadav, please.
Hello, good evening, everyone. Can you see my slide?
Yes, we can see now.
Yeah.
Hello.
Yeah, it's okay. You go to the slide.
So first of all, thank you very much. Okay. First of all, thank you very much for giving me this opportunity. I'm going to talk about atrial fibrillation from drugs to ablation, and will then touch upon some technical issues of atrial fibrillation ablation. So, as we all know that atrial fibrillation is one of the most common arrhythmia all across the globe. Approximately 44 million individuals had prevalent AF and atrial flutter 2016, and India is catching up to the West because of increasing population of aging population, as well as increased prevalence of disease like hypertension, diabetes, obesity, coronary artery disease. And significance of atrial fibrillation is not only in its numbers, but it also produces serious health issues. Patients with atrial fibrillation are likely to die more, almost twofold increase in death as compared to patient who has no atrial fibrillation. There is fivefold increase in risk of stroke, and 20 to 30% of all ischemic strokes are related to atrial fibrillation. 10% of cryptogenic strokes are related to AF. Patients with atrial fibrillation, 20 to 30% of them will have LV dysfunction and heart failure. Many of this because of the primary underlying cause of atrial fibrillation. These patients have serious impairment in quality of life, and not only by functional limitation, but also a lot of psychology. Still, 20% of atrial fibrillation patients are suffering from depression, and also they have increased risk of dementia because of hypoperfusion and microembolism phenomena that happens in these individuals. Ultimately, all of this reason leads to multiple hospitalization, either because of AF or because of treatment related to AF, like oral anticoagulation related bleeds or stroke. So it puts enormous burden on the healthcare system. Now, when we look at the risk factor of atrial fibrillation, there are multiple risk factors, and that is the reason why atrial fibrillation should not be looked as a primary electrical problem of the heart. It is also a structural issue when you encounter atrial fibrillation in patients having valve disease, heart failure, or hypertrophic cardiomyopathy and coronary artery disease. It is a metabolic problem in patients having diabetes, chronic kidney disease. It is a lifestyle problem in patients who are consuming alcohol, who are having dyslipidemia, obesity, smoking, and obstructive sleep apnea. It is also a problem of critical illness when it is seen in ICUs in a patient who is critically ill, has undergone a major surgery. So atrial fibrillation has a multiple facet, and just addressing the electrical disturbance is not going to improve outcomes in this group of patients. When we look at the goals of management of atrial fibrillation, primary goal of this patient is to achieve rate control or rhythm control, because that is the most important reason why patient is consulting to you. It is coming to you because the altered rate and rhythm is producing symptoms. Anticoagulation is an integral part of AF management because these patients are at very high risk of CV stroke, and particularly when CHA2DS2-VASc score is high. This has to be combined with risk factor management. Without that, the whole management would be incomplete. And this is possible only when a patient is educated and there is a constant engagement of this patient. So in today's talk, I'm going to talk more about rate and rhythm control. I'm not going to discuss about the anticoagulation or stroke prevention strategies for atrial fibrillation. Now, when we look at the aim of different strategies, aim of rate control is primarily to reduce the symptoms of patient by regulating the ventricular rate during atrial fibrillation, and thus by improving hemodynamics and preventing heart failure symptoms. So ultimately, the goal is to reduce risk of adverse cardiovascular outcomes. Aim of rhythm control is to achieve and maintain sinus rhythm, because by achieving and maintaining sinus rhythm, you achieve all of the goals of rate control. But this should be done without significant increase in adverse events. And that is very important when you are trying to achieve rhythm control in this subgroup, this atrial fibrillation patient. Let us understand this by a case. This is a case of 65-year-old female, obese, having history of hypertension, diabetes for last 10 years, who presented with history of heart failure, which progressed from NYHA class 2 to class 4 in last 3 months. She was diagnosed with atrial fibrillation 3 months back, and rate control strategy was adopted. This was the presenting ECG, and ECG shows atrial fibrillation with very rapid ventricular rate. Now, every patient of atrial fibrillation, when we look at the goals of management, in every patient, you will find different goals of managing this patient. In this patient, goal of management would be to treat her symptoms of heart failure, prevent recurrent hospitalization for heart failure symptoms in future, prevention of stroke in future, and aggressive risk factor management looking at the history of hypertension, diabetes, and obesity. Now, this patient was offered rate control strategy even when AF was detected just 3 months back. It was a new onset atrial fibrillation, but rate control strategy was adopted. The reason behind this strategy, which is often considered as an endpoint strategy for atrial fibrillation patient, are these trials. These trials are comparing drugs for rate control versus control, and the largest trial was the AFFIRM trial, which enrolled 4,000 patients. 2,000 of were enrolled in rate control strategy, and 2,000 in the rhythm control strategy. And if you look at this result of trials, surprisingly, rhythm control strategy was not superior to rate control strategy in preventing hospitalization for heart failure or in preventing mortality. Whenever we take guidance from the randomized control trials and we adopt this into our clinical practice, we should also look at the patient population that was studied and also the limitation of this trial. Only 24 to 63% of patients in rhythm control arm remained in sinus rhythm with drugs. It means that we actually compared a rate control strategy with failed rhythm control strategy. And majority of these patients were elderly without significant symptoms. Severe symptomatic patients like heart failure were underrepresented. Only 9% of patients had NYHA class 2 or greater. That means that all of these patients were very minimally symptomatic or very mildly symptomatic. And despite this fact, a post hoc analysis of the AFFIRM trial demonstrated that the presence of sinus rhythm was associated with lower risk of death. However, this benefit was offset by hazard of antiarrhythmic drugs. Now, so this means that this trial does not tell us that this strategy is superior to another strategy, but even after this results, rhythm control strategy is better to achieve in patients who are younger, less than 65 years, who are symptomatic, who have symptoms which are severe, like heart failure symptoms, or whose atrial fibrillation is recently detected. Obviously, when rate control is failed in improving symptoms, rhythm control strategy comes into the picture. Now, in this patient, because patient had a new onset AF, a new onset LV dysfunction, this is an echo image of during atrial fibrillation. And if you look at, there was severe LV dysfunction, which was responsible for her atrial fibrillation, for her symptoms of heart failure. And we thought that rhythm control strategy would be better. We did cardioversion after ruling out LA appendage clot, and patient's symptoms as well as LV function improved with sinus rhythm. To maintain sinus rhythm, we prescribed amiodarone in this patient. And patient symptom improved, heart failure improved, but this improvement came at the cost of increased interval. Patient had incredibly long QT interval and also monitored episodes of torsades. So this case is a perfect example to emphasize the fact that though rhythm control strategy can improve patient symptom as well as heart failure functional class, if you achieve it by drugs, you can have patients where there will be increased proarrhythmic risk. However, safe amiodarone can be considered, still it can produce proarrhythmia in certain number of patients in certain clinical situations. So this emphasizes whenever rhythm control strategy is adopted, this patient has to be closely monitored for any adverse outcomes related to rhythm control drugs. Now, when drugs were compared in heart failure subgroup, AF-CHF trial was a trial which compared rate control versus rhythm control strategy by drugs. And even in heart failure, rhythm control strategy did not improve mortality, stroke, and worsening of heart failure when drug was used. However, in contrast, when drug was compared with rhythm control strategy by procedure like ablation, atrial fibrillation recurrence as well as heart failure hospitalization and mortality was significantly reduced in CASTLE-AF trial. This was a very beautifully conducted trial in patient having LV dysfunction, ejection fraction less than 35, and all of these patients had actually device implanted like CRT or ICD, so all AF burden could be closely monitored. Now, interesting, this benefit of death and hospitalization, heart failure hospitalization, was driven by improvement in hospitalization for worsening heart failure, but there was also improvement in mortality. But if you look at this slide, the improvement in mortality only occurred after 3 years of follow-up. So it is very important to sustain rhythm control long enough to have an improvement in survival in this subgroup of patients. It also tells us that these patients need to follow up for long to have any clinical improvement in terms of mortality reduction. This is a meta-analysis of almost 18 randomized controlled trials of AF patients, which compared drugs for AF management versus catheter ablation for AF management. And in all patients, mortality cardiovascular hospitalization, as well as recurrence of atrial arrhythmia was significantly reduced. And this was mortality improvement was primarily driven by reduction in mortality in heart failure patients. And non-heart failure patients had a reduction in recurrence of atrial arrhythmia as well as cardiovascular hospitalization, but no significant improvement in mortality. Again, if you look at the subgroup analysis, patients who were male and who were young, less than 65 years of age, had a significant benefit of catheter ablation therapy in atrial fibrillation patients. So now in our case 1, we documented that rate control strategy is not working. Rhythm control strategy has shown improvement by improving symptoms as well as LV function, but the drugs for rhythm control strategy is riskier. So this patient underwent RF ablation for rhythm control. Pulmonary vein isolation was done in this patient, and this patient has almost 1 year of follow-up, and she is maintaining sinus rhythm with just blood and relative. Now, unlike other arrhythmias where ablation and treatment or achieving sinus rhythm remains the endpoint goal, atrial fibrillation, in atrial fibrillation, this is not the case. This is a wonderful study of ARREST-AF cohort where consecutive patients undergoing first AF ablation where BMI was more than 27 plus 1 or more modifiable cardiac risk factors were randomized to risk factor management compared to patients who refused to undergo RF risk factor management. And risk factor management group, if you see, single procedure AF-free survival and multi-procedure AF-free survival was significantly better in patients who underwent risk factor management as compared to no risk factor management. Legacy study was done in atrial fibrillation patient to study the impact of body weight reduction and in obese patient. And if you see the sustained reduction of body weight more than 10% was better in terms of freedom from AF. This is even without ablation and drugs. So weight reduction of more than 10% is as effective as one of the antiarrhythmic drugs like amiodarone. When it was added to interventions like AF ablation, again, body weight reduction patient were doing better in terms of maintenance of sinus rhythm and follow-up. Obstructive sleep apnea is again an important risk factor to screen at. So all these patients who come with atrial fibrillation, we take history, and if history is even slightly suggestive of OSA, these all patients should undergo sleep apnea screening. OSA has a very high chances of increased frequency of AF, and treatment of OSA, as simple as giving them CPAP therapy at home, reduces the recurrence rate of atrial fibrillation. So these studies actually tell us that not only a drug or ablation or any intervention procedure, risk factor management plays a significant role in maintenance of sinus rhythm. So weight management and exercise, control of dyslipidemia, screening of obstructive sleep apnea and providing CPAP therapy, control of hypertension, diabetes, smoking cessation, and alcohol abstinence is equally important and equally to be emphasized every time we encounter these patients in our clinic. Now then, there are some subgroup of patients where rhythm control strategy is not possible. This is one of them. 55-year-old female with a history of mechanical mitral valve replacement 15 years ago, presented with symptomatic atrial fibrillation and fast ventricular rate. Previous two attempts of cardioversion with antiarrhythmic drugs, with antiarrhythmic drugs were successful with recurrence of AF in 6 months and 3 months duration respectively. Ventricular rate control was not reliably achieved with combination of beta blockers, calcium channel blockers, and lanoxin. Her echocardiogram revealed enlarged atrial chambers. LA was almost aneurysmally enlarged. Now, we know that drugs for rhythm control has not worked, and in this subgroup of patients, atrial fibrillation ablation is very disappointing. With such aneurysmal enlargement of the atria, diseased rheumatic disease, result of ablation is not good. So, goal of management in this patient is a reliable rate control and lifelong oral anticoagulation because of mitral valve prosthesis and AF itself. Now, rate control in AF is there is a vague definition. It is any rate which is adequate and appropriate ventricular rate that reduces symptoms and enables exercise. If you try to achieve a very strict rate control, you have a symptomatic bradycardia or adverse effect related to drugs, and ultimately patient end up receiving pacemakers. If you not control rate, if you don't control rate, you have a risk of more symptoms of AF, increased risk of heart failure, and impaired quality of life. RACE trial showed that linear rate control was better than strict rate control. However, you need to move from strict rate control to lenient rate control if patient's symptoms persist, if LV ejection fraction deteriorates, and percentage of BiV pacing reduces if patient has undergone BiV implant. Junction ablation is the most reliable way for rate control strategy. You have ablated AV node and then you implant a pacemaker to achieve a rate control. However, there is always a fear of producing dysynchronous contraction by RV pacing in this group of patients. And this is a randomized study where rate control by drug was compared with ablation and CRT implantation. CRT was implanted to minimize the dysynchronous contraction that happens from RV apical pacing. And it showed that AV junction ablation plus pacemaker therapy or CRT therapy was superior in terms of reduction of combined endpoint of death and hospitalization for heart failure. It was primarily driven by reduction in hospitalization for heart failure. Now, though CRT can serve the purpose, still we know that when patient has a narrow QRS, CRT still leads to some dyssynchrony. It imposes dyssynchrony ejection LV function. So now there is enough data to suggest that conduction system pacing, which Dr. Shanmuga Sundaram is going to talk about in next session, conduction system pacing can be a good alternative to this subgroup of patients where AV junction ablation is followed by his bundle or left bundle pacing, and you can maintain interventricular synchrony and achieve the reliable rate control. So this patient, considering history of mitral valve replacement, failed rate control with 3 different medications, underwent AV junction ablation and left bundle pacing, and at follow-up of almost 1 year, patient is doing well. There is no medicine except warfarin for mechanical valve prosthesis. Now, coming to the ablation part of AF, there are different mechanism hypothesis, and There are multiple wavelet theories, single automatic focus driving the atrial fibrillation, focal re-entry with fibrillary wave conduction, rotors and spiral waves are various theory proposed for the mechanism of atrial fibrillation. And this is a schematic diagram showing posterior aspect of left and right atrium. These are the ganglion at a leg size, which can be responsible for atrial fibrillation, focal re-entrant mechanism, focal triggers, which are most commonly seen in pulmonary veins. However, you can have non-pulmonary vein triggers also. And the problem is that in single patient, there can be different mechanism operating. So that is one of the reasons why AF fibrillation, unlike other cardiac arrhythmia, is not associated with a very high success rate with single procedure. Now, if you look at the pathophysiology of atrial fibrillation, in paroxysmal atrial fibrillation, majority of atrial fibrillation cases are trigger driven, and these triggers are coming from the pulmonary vein, almost 70 to 80% of cases. As you go from paroxysmal to persistent atrial fibrillation, substrate comes into the picture. It is more maintained by the abnormal substrate that occurs in the left atrium. So in cases of persistent atrial fibrillation, trigger ablation by pulmonary vein isolation was compared with pulmonary vein isolation plus substrate-based ablation strategy in form of additional linear ablation lesion as well as ablation of regions of complex fragmented atrial electrograms in the atria. And surprisingly, only substrate-based ablation did not improve any outcomes or freedom from atrial fibrillation compared to pulmonary vein isolation alone. So that has made us and left us with pulmonary vein isolation as the mainstay of ablation for atrial fibrillation. And this is again supported when we take up this patient for a redo procedure. 80% of these patients are having recurrence of pulmonary vein conduction. So that means that pulmonary vein isolation is the most critical part of AF ablation therapy. And majority of procedures now done are a wide intral circumferential ablation and by point by point. And this is what we try to look at when we ablate the atrial fibrillation. You can see the pulmonary vein signals completely dissociated from the neighboring atrial activation. The challenge with that is very high variable PV anatomy. Pulmonary vein, though most commonly have 4 different ostiums, but they can have a superior and inferior vein can have a single ostium. There can be an accessory pulmonary veins also. The single ostium on the left side can have a longer trunk or it can have a shorter trunk. So it is very important to understand the anatomy at the beginning of the procedure. And many centers do operated CT angiogram to understand the pulmonary veins. We just rely on pulmonary venography at the time of the procedure. Another technical challenge of AF ablation is to define the PV antrum inside the pulmonary vein. If you are inside the pulmonary vein, there will be risk of pulmonary vein stenosis, which is a very big complication of AF ablation. So how you define the pulmonary vein antrum? You can do a pulmonary venography, use 3D mapping, or you can do a CT merge. But remember, these all are having some limitation. The best way to understand is to electrograms. As in this case, if you see the mapping catheter is having an electrogram where pulmonary vein potential is coinciding with the atrial activation. So there is fusion. When CS spacing is happening, you can see the pulmonary vein coming out. So this will not be a good site for starting ablation, as your catheter is inside the pulmonary vein. You have to pull it back, confirm the pulmonary vein potential is not there, and ablate. So these are relative technically complex issues at the time of procedure. Every lesion has to be ascertained that it is not inside the pulmonary vein. Even when you have taken care of that, if a lesion formation is important, and contact force is the most important factor. When
Dr. Jadhav, please take care of the time.
Please wind up. Okay, fine. What I'll do, I'll skip this slide. And at the end, I just want to summarize by telling that AF is not just an electrical problem. It has to be taken care by a multidisciplinary approach. You need to have electrophysiologists, cardiologists, metabolic physicians, endocrinologists, heart failure team for managing this patient. Integrated is improve outcome of patient. Thank you very much.
Thank you, Dr. Jadhav, for that excellent, elaborate lecture. It was indeed an elongated subject, but you covered it up very well and within time. And may I call upon the next speaker, Dr. Priyam Mukherjee. We are having a discussion at the end of the speech of the second, after the second person finishes.
I think this is a guest lecture and no questions can be asked.
No, this is actually a convention that if you want, you can stick to it. Or if you want to learn something from Dr. Jadhav, we can ask him a few questions, one or two if the time permits. But after the second speaker is over, okay? So may I call Dr. Priyam Mukherjee to talk about how to handle antithrombotic therapy in patients with atrial fibrillation before and after PCI. So over to Dr. Mukherjee.
Good evening. Am I audible?
Yeah, you are audible.
Yeah.
Your slides are also visible. Okay.
Yeah. Good evening, respected teachers and my colleagues. I am thankful to the organizer for giving me this opportunity to present this interesting topic, that is the antithrombotic management before and after PCI in atrial fibrillation.
Hello.
Now, atrial fibrillation increases the risk of thromboembolic complications, including strokes and extracranial systemic embolic events, which call for therapeutic prophylaxis with oral anticoagulants. It is estimated that about 20 to 40% of the patients with atrial fibrillation also present with coronary artery disease. Overall, about 5% to 10% of the patients referred to coronary angiography with or without PCI present with atrial fibrillation or other indications for chronic oral anticoagulation therapy. Now, the issue is that these antithrombotic are helpful in preventing the stroke complication in atrial fibrillation, but they actually don't effective. They are not very effective to prevent the ischemic complication after stenting, as like antiplatelets. So, but if you actually combine this triple, there is the triple antithrombotic therapy. There is a DAPT plus antithrombotic, like your NOACs or your vitamin K antagonist. So they actually increases the risk. So the debate is that whether to go for a double antithrombotic therapy, that is a DAT therapy, versus the triple antithrombotic therapy, that is a TAT. Now, before going to the discussion, it is a very, I'll just show the very common, very interesting and useful actually study, the OS study. Actually, it was the first study which showed that actually if you reduce, if you go with a double that strategy, that is a double antithrombotic strategy compared to triple antithrombotic strategy, there is actually significant reduction of the bleeding complication, and there is and it is equivalent if considering this ischemic cardiac ischemic events, such as stent thrombosis and other ischemic events. So this is the first study which give us an insight that, okay, apart from triple TAT therapy, we can actually reduce this therapy to double antithrombotic therapy so that the bleeding complication reduces. Another interesting study is the ESA triple study, which also showed that if you reduce this reduce this triple anticoagulation therapy to double anticoagulation therapy, antithrombotic therapy, then the risk of bleeding decreases significantly. Now, after that, several randomized trials have demonstrated that a regimen of DOACs plus a single antiplatelet agents, usually clopidogrel, provides better safety than a triple therapy regimen of vitamin K antagonist plus DAPT. Now, this is one of the interesting trials. There is a pioneer atrial fibrillation trial. It has 3 groups, 2 treatment arm and 1 is control arm. It's a 2 treatment arm consists of 2 different rivaroxaban based dose-based regimen. One is the rivaroxaban 15 milligram once daily and a P2Y2 inhibitor, which was mainly clopidogrel, and this was continued for 12 months. Another is triple TAT therapy, but with a reduced rivaroxaban dose, that is a 2.5 milligram twice daily, and a P2Y2 inhibitor and aspirin. And if there is a need for to omit this P2Y2 inhibitor, then the rivaroxaban dose was increased from 2.5 to 15 milligram once daily dose. And the control group, it consists of vitamin K antagonist with a P2Y2 inhibitor and aspirin. And this clearly shows that this rivaroxaban regimen showing significantly less bleeding compared to the vitamin K agents with the triple therapy. Now, then came this dual PCI therapy, which actually comprises of more than 2,500 patients, and they compared dabigatran in 2 different doses, 110 milligram twice daily and 150 milligram twice daily, with a P2Y12 inhibitor for 12 months, compared to triple therapy with the vitamin K antagonist, P2Y2 inhibitor, and aspirin. They also showed that the triple therapy has a significantly higher bleeding risk compared to this double antithrombotic therapy. Now, recently, this another interesting trial actually came. There is an Augustus trial. It was done with the APIC7, and there were 4 groups. All were receiving clopidogrel or P2Y2 inhibitor, mostly clopidogrel, and they showed that the patients who have the triple therapy with the vitamin K antagonist plus aspirin plus P2Y2 inhibitor has the highest events, around 18.7%, and mainly due to this major bleeding or non-major clinically significant bleedings. Whereas those patients having only 2 drugs, that is the APIC7 with P2Y2 inhibitor without aspirin, they actually do a far better with only 7.3% event rate. So this dual therapy, DAT therapy, is much superior than this triple therapy. With this background knowledge, we will discuss what should be our strategy before PCI, a patient who is on anticoagulation, and what should be our strategy after this stenting. Now, there is some difference in the North American perspective and the European perspective. I will discuss one by one. First, we come regarding the anticoagulation. North American, they actually suggest that a period of washout is always preferable unless it is an emergency PCI, and then bridging with heparin is unnecessary unless it is an ACS. Now, if you bridge, if you take the washout time, it is around 24 hours for the DOACs. Except dabigatran, it is quite a little bit longer, and 48 hours should be actually necessary. And if the patient is on vitamin K warfarin or azithromycin, then your INR should be less than 2 when you are choosing your radial axis, and INR should be less than 1.5 when you are choosing femoral axis. Now, regarding the vascular access, obviously we will prefer radial access because your femoral access having hematoma complication and other issues. European groups, they actually don't promote your interruption of the vitamin K anticoagulation, and they promote interruption of the DOACs, but unless it is an emergency PCI. Now, regarding the heparin use, it is administered as a routine dose, but if the patient is on VKA, then you have to reduce the dose by 50%. But for the DOACs, you need not to actually adjust your dose of heparin. Now, regarding bivalirudin, if it is an emergency case, and if you are doing from a femoral route, yes, it is a very good, because you can, because the residual effect will be gone within quickly. So it is an important issue. Now, regarding the GP2B3 inhibitor, only used to be used in the bailout situation when the patient is on anticoagulation. And regarding the loading dose of aspirin or P2Y2 inhibitor, they are almost similar. Only if the patient is on vitamin K antagonist, then we have to halve the dose of the loading dose of clopidogrel. And obviously, the new generation days to be used, because we have to reduce the duration of DAPT. Now, after procedure, we have to actually answer the 6 questions. So I have discussed one by one. First is what is the OSC we should use. I think there is, at present, there is not very much controversy regarding the issue. As far the type of the OSC drug is concerned, both the North America and the European consensus document agree with current guidelines. In the absence of contraindication, DOAC should be preferred to vitamin K antagonist due to the lower risk of bleeding previously demonstrated to be a class effect. In patient who is already on vitamin K, then switching to DOAC is a reasonable option to reduce the risk of bleeding. Now, next question comes. The second question deals with the duration of the TAT. There's a triple antithrombotic therapy. And thus, this spans from very short until after successful PCI or extended, that is the 6 months. Now, before going to the question, we have to ask ourselves we have done the procedure, whether it is a high risk in the future stent thrombosis or stent-related complications, or it is a low risk. What are the high risk criteria? There is a prior stent thrombosis on adequate antiplatelet therapy. Number 2, stenting of last remaining patent coronary artery. Number 3 is a diffuse multivessel disease, especially in the diabetic patient. Chronic kidney disease with a creatinine clearance is less than 60 ml. At least three stents implanted. The length of the stent is too long, is more than 60 millimeter. Also, you have done bifurcation of the left main stenting, and you have done a chronic total occlusion. So they are the basically important issues which actually categorize whether we are dealing with a high risk patient in future in terms of your stent thrombosis and like that. On the other hand, if there is a high bleeding tendency, like a short life expectancy, there is a poor mental status, end-stage renal failure, advanced age, previous stroke, prior hemorrhagic or bleeding manifestation, anemia. So they are basically, these patients have more chance of bleeding than stent-related issues. Now, based on this background knowledge, a North American expert consensus document is a default approach is a DAT therapy. That is a double antithrombotic therapy, and thus to keep the aspirin only in the peri-procedural period or during the hospital stay, maximum 7 days. So this is the consensus statement of the North American. However, the North American document does indicate that DAT therapy for up to 1 month can be considered in patients who have a high thrombotic risk and a low bleeding risk. Now, whereas European are more conservative, European consensus document follows this approach only for the patient in whom the bleeding risk exceeds the thrombotic risk. Whereas all the patients should receive at least 1 month of the TAT as a default approach, or longer term, up to 3 to 6 months, if there is a high thrombogenic risk exceed the bleeding risk. Now, next question to be answered, the third question deals with the specific antiplatelet drug to be discontinued in the transition from the TAT to DAT. Now, the consensus of the North American and European documents is that P2Y12 inhibitor should be used without aspirin. Clopidogrel was actually shown to be superior in reducing the ischemic events and also had a more favorable safety profile. It is more important to note that there is a synergism on the modulating thrombus formation when a P2Y12 inhibitor is coupled with an OSC. Now, our next question is that the fourth question deals with the dosing regimen of the DOAC for combination therapy in the TAT or DAT regimen.
এত রাত্রিবেলায় তো
Now, in the case of dabigatran, the North American document suggests to use a higher dose, that is the 150 milligram BID doses for patients who are at a higher thrombotic risk, which is consistent with the 2019 ACA guideline for atrial fibrillation. The European consensus document consists with the 2018 ESC guideline on myocardial revascularization suggests that 110 milligram BID doses during your TAT and 150 milligram BID dose during your double antithrombotic therapy due to concern of higher thrombotic risk with the lower dose. Now, rivaroxaban used with the 15 milligram OD dose and is considered a reasonable option by 2018 ESC guideline for myocardial revascularization according to the design of the Pioneer AF trial. In this scenario, I would like to add that in the stroke prevention, it is recommended 20 milligram, but as the Pioneer trial was actually designed with this 15 milligram dose, then it is actually recommended in the guideline. And it is important to resume the full recommended dose, that is the 20 milligram OD, once the suspension of the antiplatelet therapy. So this is another important aspect of rivaroxaban. And regarding the apixaban, it is actually in the Augustus trial. It is a 5 milligram twice daily. Unless there is contraindication, then we can actually reduce the dose. That's a very significant body weight, less body weight, and your renal dysfunction. We can reduce that dose to 2.5 milligram twice daily. Now, next question is that the fifth question deals with the choice of the P2Y2 inhibitor, whether it is a clopidogrel, whether it is a ticagrelor, or whether it's a prasugrel. Now, by default, clopidogrel should be regarded as the agent of choice. Data of prasugrel for the triple antithrombotic therapy with the vitamin K antagonists are disappointing due to an unacceptable high rate of bleeding, and the 2018 ESC guideline on the myocardial revascularization formally contraindicate the use of both prasugrel and the ticagrelor in combination with the OAC. But in the Augustus trial, around 8% of patients, they have a ACS and they use the ticagrelor with the double antithrombotic therapy. And actually the result, the subgroup analysis showing not much bleeding complication. So in the light of this finding, in patients who are at a low risk of the bleeding, particularly the young patients, and at higher risk of thrombotic event, that is the ACS, diabetes, or complex PCI, the use of ticagrelor combined with the DOAC represents a potential option. Now, next question is that what is the optimal management at the 12 months from the PCI when the patient is typically on the double antithrombotic therapy? And the answer is that ideally the patient should continue on the OAC alone based on the registry and other observational data showing that in patient with the stable CAT, the addition of antiplatelet therapy to the OAC increases the bleeding without adding ischemic protection compared to the OAC. But again, I would rather suggest that in cases should be individualized. If the operator thinks that is a very high risk case, then with the oral anticoagulation, another single antiplatelet can be used in these patients, even after 12 months. Now, in nutshell, this is the North American approach. By default approach is the dual antithrombotic therapy, aspirin only few days, like 7 days you can use. When there is a high ischemic burden, ischemic raise, then you can actually increase your triple therapy up to, there is aspirin therapy up to 1 month. And when there is a high bleeding risk, obviously the aspirin should be as low as the duration of the therapy of aspirin should be as minimum as possible, as few days. Whereas the European perspective, if there is a ischemic risk is more than the bleeding risk, then your triple therapy in the form of aspirin can be continued up to 1 month, even up to 3 and 6 months. If there is a strong ischemic, if ischemic risk is more than the bleeding risk. But if the bleeding risk is very high, then only your aspirin should be used only 1 month. Otherwise, by default, aspirin therapy should be around 1 month. It's the European perspective step.
Summarize.
Yeah. To conclude, if patients undergoing PCI is not an uncommon phenomenon, preoperative bridging is not always required. Patients should be switched to DOAC if possible. Post-procedural default choice is double antithrombotic therapy. triple antithrombotic therapy should be reserved for only high-risk patients for coronary events. Default choice of antiplatelet is clopidogrel. Ticagrelor should be reserved for high-risk patients. Dose of DOAC should be same as applied for the ischemic stroke prevention in atrial fibrillation patient. And most patients with the atrial fibrillation who undergo PCI can discontinue antiplatelet therapy 12 months following the stent placement. Thank you very much for your patient hearing.
So we have Dr. Anjanlal Datta with us and Dr. Debanu Ghosh Rai and Dr. Abhijit Chatterjee. Please summarize, sir. I also see Dr. Ullas Pandurangi with us. Dr. Datta, Anjanlal Datta, sir, please summarize the...
Yeah, thank you very much, Dr. Priyam Mukherjee, for your excellent deliberations. It was really a trade-off between ischemic event and bleeding event that determines as to what extent, what type of antiplatelet is to be continued in the background of atrial fibrillation following PCI. And you are right in assessing that, particularly in American background, they are not very much encouraged to use aspirin for a longer period, more than 1 month. But European guidelines probably comes closer to what we practice. And at the end of the day, we must individualize the patient, you have rightly pointed out. So if there is any comments from Dr. Debanu Ghosh Rai, co-chair, Dr. Debanu.
No, really, I don't have any comments. He has spoken very well. And we are already getting late into the night. I don't think I'm going to prolong this discussion.
I have only one comment to make to Dr. Neeraj Yadav about one particular comment I make. In the CASTLE-AF trial, is he here? Is he audible, Dr. Yadav?
I think he has to leave. He had some problem. He conveyed like that. He had to leave, something like that.
In any case, in CASTLE-AF trial, it is surprising that 30,000 patients were initially recruited. And out of these 30,000, only 300 were found suitable for ablation. That is a very important figure that we should remember. And all these patients had ICD and ICD or CRTD. And the company that gave the ICD and CRTD is also the company who supplied the medications and the device. So that is a very huge discussion on that matter as well, in any case. So Dr. Shapon Pal, are you there? Any comment or question or seeking clarification from audience? If there is no one, I thank both the speakers on behalf of the organizing committee for the excellent deliberations, and we hand over the mic to Jayanto for further continuation of the proceedings.
Technical support, anything about the industry, anything from industry?
At AstraZeneca, we push boundaries of science to deliver life-changing medicine. We are committed to address unmet medical needs. Over the years, we have developed a range of cardiovascular drugs, and then came Brilinta. We have invested more than 10 years of efforts to assure us most complex small molecules. It requires more than 20 synthetic steps to manufacture, and it is very difficult to replicate the process. The molecule has 6 chiral centers, isomers that differ in 3-dimensional configuration of their atoms in space. Hence, having the correct stereoisomer is the key to ensure right efficacy and safety, which has been demonstrated in 679 studies with 250,000 patients, made possible only because of high reliable drugs to over 100 markets worldwide. Above all, your experience and trust ensured Brilinta reached over 8 lakh patients in India, and together we were able to save the lives of over 11,000 patients. So, never compromise on the 7 years of winning combination. Our Brilinta is the only original ticagrelor for all your ACS patients.
Yeah, that's all, sir. Please go ahead.
Thank you. So our last session is on conduction system pacing tips and tricks. We have our chairpersons, Dr. Ashok Kaur, Dr. P.S. and we have Dr. Ullas Pandurangi with us, and Dr. Shuchit Majumdar and myself and Dr. Meera as moderators. So please take over the mic.
Thanks, Dr. Jayanta Saha. Today's last speaker is Dr. P. Shanmugasundaram, and he is going to speak on conduction system pacing tips and tricks, because we know that the conventional pacing, RV pacing, RV apical pacing has got a lot of problems like congestive heart failure, atrial fibrillation, and quality of life is not at all satisfactory. So whether you can improve the situation by doing selective pacing in his bundle or in the left bundle or right bundle, that whether it is going to help regarding the reducing the further mortality and morbidity in patients who are on pacing. And today we are going to hear from the expert, Dr. P. Shanmugasundaram. Dr. Shanmugasundaram, please.
Sir, at the outset, I'd like to thank CSI Bengal for giving me this opportunity. Hope my screen is visible there.
Yes.
Yes, sir. Please go ahead.
So without wasting much time, being the last batsman of the innings, I would go straight into the topic. We know the electrical sequence of cardiac conduction. It starts from the SA node via the three internodal pathways. It reaches the AV node. From there, the bundle of S and then the left and right bundle. Subsequently, by the Purkinje fibers, it reaches the ventricular myocardium. So if there is any problem in the sinus node, AV node, or his bundle, the patient is going to have a symptomatic bradycardia, for which we are going to put a pacemaker. The conventional site for implantation of the pacemaker is going to be the RV apex. That's what we are doing for at least 40-50 years of time. And we know the limitations and problems with RV apical pacing, which is going to produce a gradual LV dilatation, electrical as well as mechanical dysynchrony, ultimately resulting in left ventricular contractile dysfunction. This will be clinically translated into frequent heart failure hospitalizations, increased incidence of atrial arrhythmias, and obviously increase in morbidity as well as mortality. So the continuous search for the alternative sites to overcome the limitation of the right ventricular pacing. So people have started pacing the RV septum, people have started pacing the RV outflow tract, but the results were not as great to obviously limit the problem of the RV apical pacing. So even the LV endocardial pacing was not having any significant advantage over the drawbacks of placing the lead endocardially. So the continuous search ultimately resulted in what is known as conduction system pacing. So in conduction system pacing, we are going to directly capture the cardiac conduction system by a small 4.1 front size lead. So if you're going to place the lead in the His bundle, it's going to be called as a His bundle pacing. And if you're going to place the lead in the left bundle, it's going to be called as a left bundle pacing. So this is what the conduction system pacing distribution map in India. So this is based on the consumption of 3830 Medtronic leads across the country. And you can see there the West Bengal contributing to close to 140 cases, and South India is predominantly contributing to almost 40% of the cases. This is predominantly due to Dr. Ullas sir and Dr. Narasimhan sir, who was started aggressively doing His bundle pacing in the last 2 to 3 years. Of course, we need to know the anatomy for effectively doing the physiological pacing. So this is a conventional anatomical teaching. The AV node, which is in the Cox triangle, which is bounded by the coronary sinus ostium, septal tricuspid leaflet, and tender of Todaro. So from the distal of the AV node, we have the His bundle. This His bundle will be predominantly running over the membranous septum, and it pierces the fibrous skeleton of the heart. Once it reaches the crest of the IVS, it divides into right bundle and the left bundle. The left bundle will be in the subendocardial aspect of the interventricular septum on the left side, and the right bundle will be on the subendocardial aspect of the right side of the septum. So regarding His bundle pacing, here we are going to place the lead directly over the His bundle to capture it to produce a near normal QRS. So to know much about the His bundle pacing, we need to know the exact anatomy of the His bundle. The His bundle runs over the membranous septum, and we know that there are two different parts of the membranous septum, which will be divided by the tricuspid leaflet. So one is the atrioventricular component, which divides the right atrium from the left ventricle, and another one is the ventricular component, which divides the right ventricle from the left ventricle. This is very important because, see, all along this membranous septum, you have His bundle. You can place the lead anywhere along the length of the His bundle. But when you are choosing the atrioventricular aspect of the membranous septum, you'll be having a lot of A waves, so you can have atrial oversensing, a less amount of R waves, so you'll have a ventricular undersensing, and your capture threshold of capturing the His bundle is going to be high. On the other hand, if you're going to cross the tricuspid leaflet and place your lead in the ventricular component of the membranous septum, then you will be having a good R wave because your lead will be closer to the ventricle. You'll be having a less of A wave, so the problem of atrial oversensing is going to be less, and the capture threshold is going to be brilliant. So this is what is very important in knowing the anatomic course of the His bundle. So it's preferable to cross the tricuspid valve and target the ventricular component of the membranous septum to do His bundle pacing. The procedure is the same, just like doing a dual chamber pacemaker, but we need to have additional 2 gadgets to do the procedure. So one is going to be the sheath, and another one is going to be the lead. So the lead, which is otherwise known as 3830, MRA compatible Medtronic lead. So it's an open helix lead. The size is around 4.1 front size. And since it is an open helix, you cannot directly put the lead into the cardiac structure as it is going to damage the myocardium. So we need to have a special delivery sheath. There are 2 sheaths which are available. One is C315 non-deflectable sheath. Another one is C3Z4, a deflectable sheath. See, this is the only available sheath in India, and this will be solving the problem in almost 99% of the patient. So this has 2 curvatures, one for entering into the right ventricle, and another one to septal curvature, which will allow the lead to face septally towards the base bundle region. Procedure-wise, we usually assemble the sheath first, and this is the lead. It has an open helix. You have to be very careful in introducing the lead into the body. And we always tend to keep this 7-front sheath in situ and put the CS sheath over that C315 sheath over that 7-front sheath, so that in case if you need to exchange the sheath for reshaping it, or if you want to do a conventional RV pacing, you'll be having a retained access. So once you are in, so all you have to do is you have to place the lead just outside the sheath and expose the anode. So this is the anodal part of the cathode. This is the cathodal part of the lead. And this radiopaque portion is the anodal part of the sheath lead, and you just have to expose the cathode part outside the sheath to map the His bundle. So for convention and for doing an effective His bundle pacing, it's our practice to keep 2 quadripolar catheters from the femoral region in all patients. Till now, we usually place 2 catheters from the groin. So one is the His bundle region, and another one is the right ventricular apex. So this will act as a backup pacing, and this will give the fluoroscopic landmark for the His bundle zone. So what we usually do is, while placing the catheter from the groin, we'll do a quick mapping of the His bundle zone. We'll take a fluoroscopic landmark of the extent of the His bundle from the starting to the end. So this will help us in locating the His bundle, both during His bundle pacing as well as during the left bundle pacing. See here, only your cathode is exposed, your anode is still within the sheath. So whenever you are doing checking the parameters, you have to do it in a unipolar fashion. So you have to connect the black to the tip and red to the patient's body and look for the signals. So you'll be able to see 3 signals, three deflections. One is going to be the atrial deflection. The second one is going to be the His bundle deflection. And third one is going to be the ventricular deflection. So this is how an ideal His bundle lead deflection should be. So the A should be very, very small. So if you are crossing your tricuspid valve, and if you're placing the sheath and the lead in the membranous septum, ventricular component of the membranous septum, your A component will be less, and you'll have a little sharp deflection of the His bundle, and you'll have a tall R wave. Once you screw in the lead at that particular spot, a rapid rotation of the lead. So once you screw in into the membranous septum, this will produce some sort of injury over the His bundle, and this will be manifested as a ST segment elevation in the His bundle signal. So you can see the ST segment like elevation of the His bundle signal. So this confirms that you have screwed the lead into the membranous septum. This has produced some amount of injury, and it is going to give excellent stability and a better threshold as compared to those patients where the His bundle injury current is not seen. Of course, once the screwing is in, then you have to look into the ECG pattern to see whether you have captured the His bundle selectively or non-selectively. What is a selective and non-selective? So all you have to do is just look at the pacing spike. See, when you are capturing the His bundle selectively, your pacing lead will be right on the top of the His bundle. So whatever signals you are delivering, the signals will go via the His bundle, left and right bundle, Purkinje fibers, and then into the ventricular myocardium. So there will be some delay from the pacing spike to the onset of the QRS. So this is because the impulse is traveling via the cardiac conduction system. So that delay will be represented on the surface ECG as an isoelectric interval. So that will be roughly around 35 to 50 milliseconds. In case of non-selective capture, your lead will be in the His bundle zone, but it not only captures the His bundle, but also the surrounding myocardium. So in that case, you'll be seeing a delta-like wave before the onset of the QRS, immediately following the pacing artifact. So you can have either a selective capture or non-selective capture. Whatever capture is going to be there, whenever you are capturing the His bundle, the patient is going to derive the clinical benefit. Clinical implications, suppose you can use it for any varieties of bradyarrhythmia treatment, be it a sick-sinus syndrome where you can see a near-normal QRS, or even in congenital complete heart blocks where the problem will be the AV node, or even in an idiopathic old age-related CHVs where the problem will be the His bundle. So all you have to do is scan all along the His bundle, look for an area where you are having a disease-free His with a normal HV interval and screw the lead leg. See, His bundle can be used as an alternative for a CRT, cardiac resynchronization therapy. The concept of using His bundle pacing as an alternative modality of CRT comes from the longitudinal dissociation concept. See here, you can see the yellow fibers inside the His bundle are grouped together, and it predominantly reaches the right bundle. Similarly, the red fibers are grouped, and it is predestined for reaching the left bundle. So this is known as a concept of predestination, meaning that the bundles inside the His bundle will be grouped, and it will be predestined for either right bundle or left bundle. Suppose if there is any problem in the His bundle in this particular zone, so this will predominantly affect the fibers going into the left bundle. So this will be reflected on the surface ECG as left bundle branch block. So what you have to do is you have to take the lead and scan the His bundle and just bypass this disease segment. And if you place the lead bypassing this disease segment, so you'll be surprised to see a normal HV interval here. And whenever you are going to pace it from here, you'll be able to regenerate a normal narrow QRS. So this is how we usually correct a bundle branch block in patients with a non-ischemic dilated cardiomyopathy. And in almost 60 to 70% of the patients with an LBPB, the problem will be in the His bundle. It may be either in the mid or distal His bundle. So all you have to do is scan all along the His bundle and look for a normal HV interval zone and screw the lead there. You'll be able to regenerate a normal appearing QRS. So remember, in a non-ischemic dilated cardiomyopathy with an LBBB or even in RBBB, whenever you are going to narrow down the QRS and normalize the QRS, the LV function will improve dramatically, and you'll be surprised to see that by the end of 1.5 or 2 months, the patient will have almost a near normal QR, near normal ejection fraction. So the second one is a left bundle branch pacing. So we have described a beautiful benefits of this His bundle pacing, but what is the need for this left bundle branch pacing when you have a lot of advantages of this His bundle pacing? Remember, there are some limitations which you have to remember while doing His bundle pacing. In His bundle, you're aiming for a very narrow target, probably around a 4+2 millimeter of bundle, which is in the membranous septum. And you're placing the lead in the membranous septum. The lead is going to go in for just 1 to 1.5 millimeter into the septum. So that is going to carry the risk of a lead dislodgement. So if you read the articles on His bundle pacing, even the best of best article have shown that close to 5 to 7% of the time, there is a chance that lead may get dislodged, and another 10% there is a chance for lead revision. Late rising thresholds are very well documented, so you'll be programming the battery at a high output that is going to deplete the battery. And in at least 20 to 30% of the cases in conduction system disease, the problem will be distal to the His bundle, so where you will not be able to correct the conduction system problem, and the patient will be left out to have a wide QRS. So these limitations are advantages of left bundle branch pacing, where you'll be placing the lead in the proximal left bundle to capture either the main trunk or its vesicles along with the local ventricular myocardium at a preferably lower output. So not all deep septal pacings are left bundle branch pacing. So you need to have some criteria to be satisfied to confirm that you have captured the left bundle. So there are some 5 criteria, out of which 2 should be satisfied to confirm that you have captured the left bundle. One is a QR pattern in lead V1. The base QRS morphology should have a QR pattern in lead V1, and you must be able to demonstrate left bundle potential, and you have to measure the peak left ventricular activation time. I'll just show you how to measure the peak left ventricular activation time. That should be less than 80 milliseconds. And you have to be able to demonstrate this non-selective to selective capture transition, or you can do a programmed deep septal stimulation to find out, to differentiate whether the left bundle is captured or not. Procedure-wise, it is just like doing a His bundle pacing, but only thing is that, so you have to go 1.5 centimeters below the distal His bundle region. So what you have to do is you have to draw an imaginary line connecting the distal His bundle towards the RV apex. You have to take the lead in the initial 1.5 centimeter, place the lead there, just pace and see whether you are going to get a W pattern. Suppose if you are right on the opposite segment of the left bundle, your V1 should show a W pattern when you're pacing from the RV side of the septum. If you see the W pattern, then starts doing the lead. So once the lead goes in, the notch on the W will gradually ascend up. You can see the notch is going up here. Once the lead reaches the mid-septum, the notch has gone up here, and there is a simultaneous reduction in the QRS duration. And once the lead reaches the left bundle zone, you can see this notch has formed an R wave, so thereby forming a QR pattern in lead V1. And in sinus rhythm, you'll be able to demonstrate a beautiful left bundle potential. So this is by giving turn by turn. The other way, what we usually do is, instead of giving turn by turn, we'll give rapid turns so that we'll reach the left bundle zone at a one go, rather than giving one by one turn to this problem of giving one by one turn is sometimes you may end up in the mid myocardium where there may be some scar which will not allow the lead to go further in. So once you reach the target zone, you can do a sheath angiography by using 1 or 2 ml of contrast, and you can demonstrate how deep the lead has gone in. You can see here almost a 13-14 millimeter of lead is deep inside the septum. So once your lead is in the left bundle zone, you'll be able to see the left bundle potential like a sharp potential preceding the local ventricular electrogram, and you have to measure the peak left ventricular activation time. So this is very important. So your peak left ventricular activation time should be less than 80 milliseconds. So you have to measure it from the onset of the QRS to the peak of the R wave in lead V5. So you have to choose either lead V5 or V6. Measure the interval between the onset of the pacing spike to the peak of QRS. It should be less than 80 milliseconds. So like his bundle, you can use left bundle as an alternative to CRT. Since you are pacing the proximal left bundle, almost 90 to 95% of the time, you'll be able to correct the left bundle branch block, and you'll be able to reproduce a normal appearing QRS. Even in dilated left ventricle, you'll be able to narrow down the QRS to close to 100 or 110 milliseconds if you're going to capture the proximal left bundle. Another important thing which we have observed is this acute hemodynamic benefits. This we have seen even in his bundle pacing. So this duration, the interval between these two echoes is just 7 days. This is pre-procedure. You can see a global LV hypokinesia with an EF of 20-25%. And this is 7 days after the procedure of doing left bundle branch pacing, where you can see an improvement in LV contractility to an ejection fraction of close to 45%. Even you can see, we can demonstrate a reduction in mitral regurgitation. This is again a 7 days gap echo. This is pre-procedure showing 3+ MR, and this has come to 1+ MR after doing a selective left bundle branch pacing in a case of a non-ischemic dilated cardiomyopathy. So not only in LBBB, even an RBBB can be narrowed down, like in this case where the QRS was reduced from 150 to 106 milliseconds, and this patient showed dramatic improvement in ejection fraction over a period of 2 months. Not only in adults, even the pediatric populations, this left bundle branch pacing can be done, but only thing is that you have to decide about the loop. The loop has to be just more than the adult loop. Leaving an alpha loop is going to be a problem because it is going to affect the stability of the beam. Refractory atrial fibrillations with the fast ventricular rate. Again, this option of pace and ablate for AFib with the fast ventricular rate was not practiced until recently because RV pacing, we know that a lot of limitations are there. With advent of physiological pacing, so we can do a left bundle capture by placing the lead in the left bundle zone. I can ablate the AV node and you can regenerate the near normal appearing QRS. You just have to pace for 80 beats per initial 1 or 2 months. Then you can come down in your pacing rate to 60, and it gives an excellent opportunity for managing the patients with a permanent atrial fibrillations. In patients with an ischemic cardiomyopathy, your left bundle pacing alone will not narrow down the QRS. You may have to look for the benefits of additional leads, like placing a lead in the coronary sinus, placing a lead in the RV septum, or by using all the 3 leads together, one in left bundle, one in CS, and another one in right ventricle for shocking. So that is known as left bundle, LB LOT CRT, which is otherwise known as LBB optimized cardiac resynchronization therapy. So sometimes in patients with his bundle pacing failure, you may have to go for either RV pacing or left bundle pacing. But of course, left bundle pacing is going to be ideal because it is going to produce a near normal QRS. This particular patient who had undergone almost 1 year back his bundle pacing, who was landed up to us last month with the rising threshold. So we just removed the his bundle lead and put a lead in the left bundle, and we could create a QRS of almost 92 milliseconds. So our experience, we had only 1.5 years experience of this physiological pacing, where we have done close to 213 altogether, 165 at our center and 48 other centers. Predominantly, we do left bundle pacing. In our center, close to 135 cases were left bundle pacing. We have published our data of 1 year experience where it could show that the threshold remains stable, the measured R wave remains stable, the impedance remains stable, and we could reduce the QRS duration from 144 to 110 milliseconds. The LV ejection fraction, needless to say, improved from 44 to 53%. We had some problems. One patient had subacute lead dislodgement. One patient had transient coronary injury, which settled within a period of 5-10 minutes. There is no episodes of late rising threshold, no late lead dislodgement, no thromboembolic complications. One mortality occurred due to respiratory tract illness. So we could demonstrate 94% success rate. 6 patients failed. Potentials were noted in 40 patients. Almost 3/4 of the patients had an LVAT of less than 80 milliseconds. So that was our strategy, to have an LVAT of less than 80 milliseconds to confirm the capture of left bundle branch. EF improved from 44 to 53%, and the average fluoroscopic time was close to 23 minutes. Of course, this as an alternative for CRT, we had a success rate of 94%. 66 out of 70 patients, we could successfully capture the left bundle, and we could reduce the QRS from 115 to 130, when we could improve the ejection fraction from 34 to 48%. So we had collaborated with an international LVB collaborative group, and this was presented as a late-breaking clinical trial in that recently concluded HRS 2020, where we could show that left bundle pacing could reduce the QRS duration from 152 to 137 milliseconds, and it could improve the NYHA function class, and it could increase the ejection fraction from 33 to 44%. When subgroup analysis was done, as expected in any CRT trial, patients with an LVVB morphology, they did very well as compared to those patients with a non-LVVB morphology. A word of caution, remember this left bundle pacing was a recent procedure. It was started in the year 2017. There's no long-term data available. And this 30-30 lead is not meant for primarily for deep septal pacing. It was actually a site-selective septal pacing lead, which is in the market since 2015. It was later adapted for doing Hisbeld and left bundle pacing. So the long-term safety of lead and its effect on myocardial contraction is yet to be available. And we have to keep the potential complications in our mind, like the late lead dislodgement into the left ventricular cavity. See, we are placing the lead in the left ventricular subendocardium. So in case if the lead is going to dislodge into the left ventricle, it's going to produce thromboembolic complications. That should be kept in mind while doing this novel strategy. Of course, the lead extraction data is yet to be available. So all these things has to be kept in mind before doing this left bundle branch pacing. To conclude, so we know that the RV pacing has a lot of demerits in terms of atrial fibrillations, heart failures, and mortality. So the search has ultimately resulted in a physiological pacing, wherein you can choose either the His bundle to place the lead, which is associated with the late rising threshold lead dislodgement, or else you can place the lead in the left bundle, which produces excellent lead stability and excellent threshold, but without long-term safety data. So these has to be kept in mind. And of course, the physiological pacing is an evolving therapy. At least in the last couple of years, people in India have started adapting this strategy. So once we have long-term safety data, probably it is going to might replace almost 70-80% of the RV pacing requirement. Thank you.
Thank you, Dr. Shanmuga Sundaram. I'll request Dr. Ullas Pandurangi to give his comments.
Well, it's again an extraordinary talk by my dear friend Shanmuga Sundaram. He's now the master of this conduction system in the country. Well, I will have very few words here, but before that, anybody would like to give a comment?
Ullas, Dr. Hajra here. And Sundaram, as usual, very nice talk and nice to meet you. What about your W pattern in V1 versus AVR-AVL discordant versus the height of lead 2 over lead 3? Which one is the best and user-friendly? And in non-epicenter, which criteria you think is a good criteria for beginners? Number one. Number two, in hypertrophic cardiomyopathy, if you have LV dysfunction, will this lead penetrate your full thickness of septum?
Yes, sir. Regarding the first question, so this paced QRS morphology, the W pattern in lead V1, of course, like you said, there are 3-4 criteria. One is W pattern lead V1, and second one is going to be AVR-AVL concordance, and third one will be lead 2 should be predominantly positive, and lead 3 should be biphasic. So that is what the conventional description is like. But what we have seen is almost in 80% of the patient, we will be able to see this W pattern. Remaining 20-25% of the cases, this W pattern will not be seen. So these are the patients, young patients with good septal conduction, with probably if you're doing a congenital complete heart block physiological pacing, or a 30-40 years old patient with a complete heart block. In these patients, if you're going to pace the septum, we will not be able to see that W pattern. So of late, we have stopped seeing that W pattern. We will go based on this anatomical landmark. So if you could delineate the hispidal signals, and it usually will be in the apex, in the RAO view. If you see the RAO view, probably if you will be able to see the fat pad, which will delineate the AV groove, will be just inside the apex of that AV groove. So if you could localize that hispidal area, all you have to do is just go below 1 to 1.5 centimeter and go into and give rapid turns to reach the left ventricular subendocardium. But otherwise, instead of going this W pattern, what we have observed is if you are going by this AVR-AVL discordance, which will tell you that you are in the para-Hessian region, that will give you a good idea that you are going in the right directions. So this W pattern may not be an ideal one to choose if you are working in a non-MP lab where you will not be able to localize the hispidal signal. But going by this AVR-AVL discordancy will help. And another important thing is you can always watch the lead to see the height of the pacing of the lead. So if your lead 2 is predominantly negative, that means that probably you are not in the right area. But if it is predominantly positive, then probably you are in the area closer to that left bundle zone. And regarding your second question, what your second question?
Hypertrophic cardiomyopathy.
Yeah, hypertrophic cardiomyopathy. Yeah, the septal thickness, in fact, is not a criteria to place the lead. Of course, you are going to put an excessive length of lead inside the myocardium for the insulation failure, because a myocardial contraction is going to produce damage to the lead. But as such, there is no clear-cut contraindication for doing deep septal pacing or left bundle pacing in patients with hypertrophic cardiomyopathy. So all you have to do is you have to ensure that you are capturing the left bundle by confirming all the criteria. But in patients with hypertrophic cardiomyopathy, probably in a later evolved stage, there is a chance that they may have a mid-myocardial scar due to fibrosis, which may not be visible by echocardiography. As of course, we may be doing a cardiac MRI in many of these cases. So the limiting factor is going to be the scar, and many times it will be in the mid-myocardium. So you'll be able to penetrate the lead for 2 to 3 millimeter. Beyond that, the lead will not go. So it will be a tough job for us to penetrate that mid-myocardial zone. But if you succeed in penetrating that mid-myocardial area, the lead will just jump into the left ventricular subendocardial.
Do you see the screw bits like RBB type of morphology, VPC, most often, very often, screw bits, RBB type when you're reaching the left side?
Yeah, so actually that was an entirely different study which we have published it recently. So what we have observed is it is not like an RBB morphology alone will be seen. So of late, in fact, we started doing the procedure by VPC guidance. So we'll go to LAO, we'll start screwing. So once starts the screwing procedure, that should be very rapid. The turn should be rapid and it should reach the LV subendocardium within 10 seconds. That's what we have observed. If you're going to deliver the lead within a fraction of seconds into the left ventricular subendocardium, the VPCs will start appearing, and the VPCs will have a changing morphology. The first VPC will have a QS pattern, just like an RB-sided paced QRS morphology. So once the lead goes in, the QRS morphology changes, and the QRS duration changes. So it will gradually change from QS with a wide QS morphology to a narrow QRS morphology. So you could classically see that change in QRS morphology. So we usually stop giving the turns once we reach that LV subendocardium with a QR pattern of VPCs. In fact, it is very difficult to handle it, single-handedly do it. So I usually tell my rep to watch the VPC and usually see the movement of the lead in LAO by myself or vice versa. So you need to have at least one person to do the monitoring work. And once you reach the area, then your parameters will be good. Subsequent rotations will be given based on the parameters.
Dr. Shanmugasundaram.
Yes, sir.
I'm Professor Kar. Now the thing is that whatever you said just now, that so by all pacings, I mean ventricular pacings by default it should be a LV pacing, left bundle pacing. All ventricular pacings by default it should be LV pacing.
Yes, sir.
There should not be any other types of pacing when you are considering ventricular pacing, isn't it?
Of course, the incidence of RV pacing induced cardiomyopathy is varying depending upon the description. So at least 10 to 15% of the time, you will end up in seeing what is known as pacing-induced cardiomyopathy after 3 to 4 years of RV apical pacing. But if you are going to pace your cardiac conduction system, and that chance of developing a pacing-induced cardiomyopathy is going to be very, very less. Even in patients with the AV block with normal.
CRT also will be out of hope. All CRT should also be abolished, isn't it?
No, sir, not exactly. In fact, this dual chamber physiological pacing by his bundle or left bundle will work in at least probably around 80 to 90% of the patients with a non-ischemic cardiomyopathy. In patients with an ischemic cardiomyopathy, this chance of complete correction of QRS is going to be less. So you may have to depend on
the scar problem.
Yeah.
Dr. Paya here, Sundaram, I want to question when doing in cases of HOCM, during the left ventricle, in that case, postural contraction on left ventricle, particularly gradient will be increased in the case of HOCM. Gradient will increase. Yeah. That is the problem.
Yeah. So actually, sir, in HOCM, the idea of pacing RV apex is to re-excite the septum and to reduce the LVOT gradient. So if you are doing a pacing strategy for reducing the gradient, then probably physiological pacing is not the way to go, because you need to pre-excite the septum to reduce the dynamic motion of the septum, this mitral leaflet, and to reduce the LVOT gradient. So that will not happen with physiological pacing, because that is going to again generate a normal appearing QRS. So if you want to pre-excite the septum and if you want to reduce the LVOT by doing pacing, then I think it's not the strategy. But if you are doing it for a brady indication, then I think this is the way to go.
Okay.
Yes, Saban, do you have any comments, Dr. Pal? Dr. Saban Pal, do you like to have any comments?
Well, I may make some final comments, because I think we are quite into the
Yes,
night.
we are already late, running late, and our dinner is ready.
Yeah.
Yes.
You see, when it comes to the CRT, okay, let's not forget the CRT, the conventional CRT. Now, this left bundle pacing or his bundle pacing should not be the first choice. The CRT has been a proven therapy, especially when you have a typical left bundle branch block and a sinus rhythm. Idiopathic dilated cardiomyopathy, for example. We have so much of a data. I think we should respect the CRT, where your RV apical pacing with the lead where you think it is giving you a good QRS. I think that is the first choice. Now, on the table, if you're not okay with an expected result, I think you can think still about an epicardial placement of the LV lead. But if you think that is causing excess morbidity or it's a high-risk case, then you should go. So presently, this left bundle pacing or a conduction system pacing should not be considered as an alternative to the conventional CRT when the case is a class 1 indication for conventional CRT. One should also remember that there are cases where your conduction system pacing is not going to work. That is known as when the QRS is suggestive of acute and peripheral conduction disease. So one should not, it's a great technology, all right, but then we need to respect this technology and should not extend its application indiscriminately. So if you're talking about a patient who is a bradycardia dependent with a good biventricular function, either it's a sick sinus node or it's a AV conduction disease, a normal heart, I think we should consider this over the conventional right ventricular apical pacing. But if you are dealing anything other than a normal heart, bradycardia dependent, bradycardia who is dependent on a pacemaker, extension of this particular therapy to any other group, we should be cautious. If your patient with a class 1 indication for a conventional CRT asks you this question, why are you doing this left bundle pacing, this bundle pacing? If your patient is going to ask you, you have no answer. So if you do this, be prepared to answer the question from your patient why you did not do the class 1 indication is conventional CRT. So this is what is my comment.
Sir, I know it's late. Can I ask the one last question?
Brother, please listen to me. Can you take up these questions too, along with your comments? How do you go for the port connections, and how do you program the device if you are going for septal pacing, a double chamber septal pacing, and along with your comment? That will be the last one in this program.
So if you're going to use a dual chamber pacemaker, then there is no problem. So you'll be connecting the left bundle lead or a his bundle lead to the RV port and the HL lead to the HL port. The AV delay, what we have to do is, if you're doing a his bundle pacing, you have to subtract 35 to 55 milliseconds from the routine programmed AV delay just to account for that HV interval. So roughly it will be like 120 minus 35, so it will be around somewhere around 80 or 85. And if you are placing the lead in the left bundle, you have to subtract 15 to 25 milliseconds from the conventional programmed AV delay. And that will be again roughly around 90 to 100 milliseconds. That is the usual programmed AV delay for a dual chamber pacemaker with a his bundle or a left bundle lead. Suppose if you are doing it for LBBB correction in either in a left bundle pacing, then you may have to use the native AV node to achieve a good fusion to mask the RBBB delay. So we know the criteria for left bundle captures. It's going to produce a QR pattern or an RBBB delay pattern lead V1. So if you want to correct it, then you can allow the native AV nodal conduction so that the right ventricle will be activated by the right bundle via the native AV node, and the left ventricle will be activated by a left bundle. So that you have to adjust it so that you have to take into the native PR interval, and on table you can do some manipulation to get the AV fusion.
Right.
But if you are doing is using a triple chamber, then you have to connect the RV lead to the RV port and the left bundle or his bundle lead to the CS port and do the settings.
Debabrata, your comment? MVP should be switched off. MVP should be switched off. Yes, Debabrata.
Yeah, absolutely. So great presentation and great summary from Mullah sir. For Shanmugam, just I wanted to know, in my limited experience, in couple of patients where the right atrium is quite dilated, it becomes very difficult to even reach the his bundle. So how do you tackle with that? And even if you reach there, it becomes a little unstable, because even with the sheath, it becomes a little difficult. For both your comment and Ullah sir's comment.
Yeah, so in a dilated atrium and dilated ventricle with the bulging septum into the right ventricle, it will be a difficult task to do his bundle as well as the left bundle. So you may have to reshape the sheath. So I usually see in RAO view to see where I'm going to reshape, whether I'm going to increase the proximal or distal curvature, or if I'm going to reduce the proximal or distal curvature. So the RAO will give a better clue whether to increase or reduce the curvature. Of course, you can use the sheath in sheath technique, where you can use the right MP coronary sinus sheath, and you can just cut the proximal end and thread it over the this C315 sheath and use it as an extensor to reach the target zone. But many times reshaping alone will do. So I hardly used mother-in-child technique using another CS sheath. But when the deflectable C304 sheath comes into the market, probably it will come soon into the market. So that will probably solve the problem of this dilated atrium. So you can deflect the curvatures approximately or distally to reach the target zone. Ullah, sir?
Well, I think as long as there's no deflectable sheath, I think those two techniques, what you said, is the most practiced ones. Outside the sheath is made a larger curve, and then not necessarily MB2, any one of those sheaths which has a larger curve, not necessarily from the Medtronics, but there are other sources of large CS curve sheets are there. Well, proximal end can be put, and then that can be based. The other technique what we have been using is the Agilis sheet. The thing here is it is going to be causing much of a trauma to the vein. It's only in a well-built person you can use the Agilis sheet. Through the Agilis sheet, you can try to create not only the extra curve, but even the septal curve could also be manipulated. So there are occasions where, in addition to those techniques, we use Agilis sheet.
Right. Short Agilis or normal Agilis?
No, we have an extended Agilis.
Okay.
It is costly. The Wheatley sheath is also available in Europe. Wheatley sheath 11 French.
Yeah,
anyway,
Wheatley sheaths are quite strong ones, they can be used multiple sites. So we do not use one new Agilist sheet for each case. It's like a reused Agilist sheets. Yes. Otherwise, the cost becomes tremendous.
Okay. So I think that was a wonderful session, and everybody has learned a lot of things from both the pioneers and legends of septal pacing in Indian, not Indian, East Asian subcontinent. And we have two Pandits, one is Ullas and another one is Sundaram. And all the time when I listen to them, we really learn something new, some new slides, some new PPTs. And I hope everybody has learned something new from this discussion. And on behalf of CSI West Bengal, I would like to thank both the speakers and chairperson, those who have participated in this beautiful symposium. And it's my valedictory part. I would like to thank other team members, Adhunika, and all the support team, Raghu, and all of you. Have a good night, good sleep, and Happy New Year. Thank you very much for joining.
Good night, sir.
Bye.
Thank you for the opportunity. Good night, sir.
Bye.
Thank you, Dr. Shanmugam.
Good night, everybody. Thank you.
Thank you, sir.